Ji, a very good morning to all of you. Good morning to all my dear students, and it's a pleasure to connect back once again with all of you, right, in a very special series, which is the live rapid revision. Okay, so I'm really excited for this, and as always, I want to begin with a heartfelt thank you to everyone to give me an opportunity to be a part of your journey once again. And because you've given me the opportunity, I'm going to try and make the most out of it. I am going to wholeheartedly try my best to give you a concise version of my own notes, yes, which is very close to my heart, and also at the same time keeping it very high yielding. Have you gone through the notes? I personally think I've done a very good job. I'm sorry if I seem to brag, but no, I genuinely mean it for you, right? That the set of handwritten this notes that I have made for obstetrics and gynae LRR are going to be amazing. Yes, and on top of that, it is your own or my own notes of the main class. Yes. Secondly, after this, DVT will be a even more concise version of this, so that in your final phase, like last 1 month, right, 1.5 months, you can only resort to DVT. Until then, sit back, relax, be active in the class, use LRR till the month of April, revise, identify your weak zones and work on it. Yes. So is everyone ready for the class? Since everything is already there, I want you all to actively participate with me. Do you all have your handouts with you ready? So what I'm going to do is I'm going to keep highlighting things. Yes. And I want you all to speak up. Yes. Will you all do that? Even if you don't want to write in the chat box, you can all keep speaking wherever you are sitting to ensure that we really make the most of it today. Okay? So should we start on that note? Okay, G. So now let's do this. Okay, so let's begin. So as you see, the first topic here is going to be basics of pregnancy, right? That's how I start my real class as well. Okay, so let's look at this. So first we are going to talk about spermatogenesis. Okay, now very importantly, whenever we talk about spermatogonia, any type of gonia, I've already told you they initiate with what? They always undergo mitotic division. So gonia is always mitotic division. Okay. Now what do they form? Jaldi batao. It's all written there, right? So gonia are going to form the primary spermatocytes. So can you tell me, will they be diploid or haploid? As mentioned here, spermatogonia are diploid, है ना? So they are diploid, and as a result of which, even the primary spermatocytes are going to be diploid. Yes, so even they are going to be diploid. Okay, then the primary spermatocytes, perfect, is going to undergo what division? Meiotic division. It is going to undergo meiotic division. And how many secondary spermatocytes are going to be formed? The keyword here is it is going to form 2 secondary spermatocytes. All right. And therefore, can you tell me this secondary spermatocyte, is it going to be haploid or diploid? So this is what? This is a reduction division. Yes. So they are going to be haploid. Yes. Then the secondary spermatocytes undergo meiosis 2, and eventually they are going to form what? Spermatids. So bar they will keep asking you the order. So it's gonia, then primary spermatocyte, then secondary spermatocyte, then spermatids. So how many sperms or spermatids are formed here? So look at this. There are going to be 4 spermatids. Yes, and they are also again going to be haploid. Now, can you tell me, when we talk about spermatogenesis, do you remember the duration? Anyone? Duration? We've talked about it. So the duration is 72 days, right? But that is for spermatogenesis. Now, can you tell me what was spermiogenesis? So I've taught you spermiogenesis is when the sperms undergo the process of maturation. Very good. Now, who is going to tell me what was the site? So I'm going to just ask you key things. So when you talk about spermiogenesis or maturation, do you remember the site? What was the site? The site is epididymis. Yes, the site of this is epididymis. Yes, perfect. Okay. And then eventually what is going to form is spermatozoa. So when you say spermatozoa, they are the mature forms. So let's look at the key points, and we need to differentiate it from oogenesis, right? So this begins at when? Puberty. Okay, unlike oogenesis, which begins really early in intrauterine life. Is there any arrest? No, there is going to be no arrest. It's a continuous process. Okay, and one spermatocyte, primary spermatocyte, how many sperms? It is going to form 4 sperms. Yes. Now, what is it regulated by? FSH, LH and testosterone. But now you are going to tell me, if we ask you the single best hormone for spermatogenesis, what is the answer? The single best answer for spermatogenesis will remain as FSH. This is required for initiation of spermatogenesis. Perfect. Very good. And what was the time duration for spermiogenesis? So spermiogenesis kitna time le raha tha? This was going to take 12 to 14 days, right? So 12 to 14 days for spermiogenesis. Let's go on to the next one now, and we will look at the key differences with oogenesis. Okay. Again, we begin with oogonia, and they are going to undergo mitotic division again, right? Which means oogonia are diploid, that's all same. And they are going to form primary spermatocytes. Remember, primary spermatocytes always undergo meiosis 1, and there is going to be a arrest. Yes, so that is how they are different from spermatogenesis. There is an arrest. Now, quickly, I want you to tell me, prophase 1 is, yes, is the stage, but do you remember the very specific name of the arrested stage? The very specific name was dictyotene. Yes, do you remember? It was dictyotene. And we said dictyotene is the stage between, yes, prophase and metaphase. It is the name of the arrested phase. Perfect. Very good. Chalo, aage badhte. Primary oocyte is going to undergo a meiotic division. Hai na? Primary oocyte 1 is going to form how many secondary oocytes? Again, only one secondary oocyte, but here there is going to be a polar body. So secondary oocyte, again, just like the secondary spermatocyte, is haploid or diploid? It is going to be haploid again because it is a reduction division. Okay, perfect. Then the secondary oocyte enters into meiosis 2, and now there is another arrest, but this is going to be in metaphase, right? So now the arrest is in metaphase. Okay, when is meiosis 2 completed? So we've written completion of meiosis 2 will happen only if fertilization happens. Yes, so it will form the female pronucleus and the second polar body. Okay, now, so very, very important. What are the differences? The oogenesis is going to begin before birth, that is intrauterine life, and it resumes at puberty. Yes. So if I ask you, when is meiosis 1 completed? Can you tell me? So please remember, if we talk about meiosis 1, it is completed at ovulation. When we talk about meiosis 2, it is completed after fertilization. Very good. Excellent. Okay. And who is going to tell me what is inside the ovum? Is it secondary oocyte or primary oocyte? We've done this. So ovum will have what? Ovum will have the secondary oocyte. Yes, the ovum will have the secondary oocyte. Very good. Perfect. So now this is again regulated by FSH, LH and estrogen. Okay. So very, very important. And now we know the differences. Quickly tell me, when we talk about fertilization, we are talking about fertilization of a sperm with an ovum. Who is going to recall and tell me the fertilizable lifespan? Lifespan क्या होता है? Sperm का lifespan होता है, fertilizable lifespan 72 hours. What about ovum? Ovum is 24 hours. Yes. They are going to form a zygote. What is the site of fertilization? Repeatedly asked as MCQs, right? So it is going to be the ampulla, which is also the widest part of the fallopian tube. Perfect. Now, steps of fertilization, AIMS में भी आ रहा है, NEET-PG में भी आ रहा है. So quickly look at this. So there is first going to be a sperm transport. Who is going to tell me how much time does it take to reach the site of fertilization? It takes around 30 minutes to reach the site of fertilization. Yes? Okay. Then there is going to be capacitation. This is the order. in capacitation, please remember there are only biochemical changes, no genetic changes. So basically there are changes in the membrane permeability. Yes? And can you tell me which ion? So membrane permeability to which ion? It is going to be calcium ion. Yes, calcium ion. Perfect. What is the duration of capacitation? Yes, 6 to 7 hours. Right? So 6 to 7 hours is the duration. Okay, perfect. Then after capacitation, there is going to be binding, right? So there is going to be binding to zona pellucida, and after binding, there is going to be acrosomal reaction. So they are not a part of capacitation, they are separate steps. Who is going to tell me the enzyme released? Yes, in acrosomal reaction, it is going to be hyaluronidase. Yes, it can be taken as 6 to 8 hours, 6 to 7 hours. When you say binding to zona pellucida, who is going to tell me which is the receptor? So if you remember ZPGP3, right? Zona pellucida glycoprotein receptor 3. Okay, perfect. Then once the sperm enters, there is going to be what? There is going to be fusion of the sperm and the ovum. Yes, there is going to be fusion. Uske baad kya hota hai? After the fusion, what is going to happen? There is going to be a cortical reaction. Yes. Now please remember, what does cortical reaction do? Cortical reaction is going to do hardening of the zona pellucida. So now you have to tell me, when we say cortical reaction and zona pellucida hardens, what is hardening called as? This is called as zona reaction. Yes, do you all remember? So this is zona reaction. Okay, so cortical reaction के बाद होता है zona reaction, and yes, what are they going to do? They are going to prevent polyspermy. So both cortical and zona reaction are going to prevent polyspermy. Yes, this is what happens in humans, and this is what is considered as slow block, which is the main mechanism in humans. Okay, now we've already discussed completion of meiosis 2 कब होता है? After fertilization. So the male and female nucleus are going to fuse. Perfect. Zygote is going to be diploid. Yes, the zygote is going to be diploid. Yes, site of capacitation, aap batao. The site of capacitation, the single best answer will remain as fallopian tube. Okay, it happens in the fallopian tube, and the general answer is it happens in the female genital tract. But the main answer very specifically will be the fallopian tube. Are you ready? Okay. Then we move on to the next phase, which is going to be implantation. Okay. Now, implantation happens in which phase? It happens in which phase? It is going to be in the blastocyst. Okay. So please, so this is a revision cycle, bache. Okay. You must go through your main notes. We can't do it like the main class. Okay. The idea is do a rapid revision. So you have to follow with me. Everything is already there. Okay. So yes, fertilization is going to happen where? We will see. But as we said, implantation happens in which stage? It happens in the blastocyst stage. But can you tell me in what form does it enter into the uterine cavity? So when we talk about zygote, it enters the uterine cavity in which form? In morula. Yes. So it is entering the cavity in the form of a morula. On which day? Day 4 post fertilization, in the 16 cell stage. Okay. So in the 16 cell stage. Perfect. Now, the blastocyst is going to implant in which layer? It is going to be the decidua basalis. Yes, it is going to be the decidua basalis. What is the time duration for implantation? Day 6 to day 10 after fertilization. It's even a recent exam question. Okay? Now, blastocyst, we are fond of asking you, when does it form? So you have to know it forms on day 5. Yes, so blastocyst is going to form on day 5. Then there is going to be a zona hatching. What is the best answer for zona hatching? The best answer for zona hatching is going to be again just before implantation. But if they are asking in days, the answer will again remain as day 5. If it is just before, implantation, that is the best answer. Okay. Then next, the conceptus is going to undergo adhesion. Then there is, apposition. Then there is going to be adhesion. Then there is going to be invasion. So that's the sequence. Now you have to tell me which molecules are involved when we talk about apposition. So apposition was about selectins. What about adhesion? Adhesion was with integrins. Okay, adhesion is with integrins. And what about invasion? Invasion was with matrix metalloproteinase. Yes, so matrix metalloproteinase. Right? Perfect. Okay. Now, please remember when we talk about implantation, when it is invading into the decidua, there may be bleeding. What is implantation bleeding? It is called as Hartmann's sign. Yes, Hartmann's sign. Okay. Always remember implantation is eccentric. Now, I want you to tell me what is the site of implantation? It is upper posterior wall. It's never in the center. It is in the posterior wall and it is eccentric. Excellent. Very good. Very, very important topic. Superfetation and superfecundation. Yes. Now let's look at this one by one. So when you say superfetation, what is the key word? I will highlight the keywords for you. There is an already existing pregnancy. That is what is superfetation ka keyword. First keyword. The second keyword, there is going to be a second pregnancy or a second conception, which means the two babies will have different gestational age. Do you look at the keywords? So there is an existing pregnancy, then there is another fertilization, and the two babies will have different gestational ages. Okay. Please remember, this is extremely rare in humans. It happens in other species, but very, very rare in humans. The two babies, as I said, will have a gap of, yes, it has to be at least a gap of 4 weeks because it is happening in different menstrual cycles. Yes. So because the fertilization is happening in different menstrual cycles, there would be a difference in the gestational age. Very good. The reason here is actually hormonal irregularities because of which ovulation might happen. Normally, do you remember there is no ovulation in pregnancy? Can you recall the reason? Because of inhibition by progesterone. The LH and FSH in pregnancy are usually low, right? So pregnancy may FSH, LH are low because of what? Feedback inhibition. But here ovulation may happen rarely. Yes, very good. So key things, a typical example is they will say a woman is pregnant with babies of 2 gestational ages. Yes, let's look at superfecundation. What is the key word here? The key word here is there is fertilization of 2 or more ova, right? Please remember this has to be by separate acts of intercourse, right? But what is the most important thing? The most important thing here is same menstrual cycle. So will they have different gestational age? No. There have to be separate acts of coitus. The father can be same, the father can be different. Do you understand this? But the acts of coitus have to be different. Yes, because there are 2 zygotes. What kind of twins is it going to be? What kind of twins? There are 2 separate zygotes. Yes. So this is going to be fraternal twins. What is the other name for fraternal twins? Dizygotic. Right? So they are dizygotic. Even in superfetation, they will be dizygotic because there are 2 different types of zygotes formed. Right? So will be dizygotic here. Okay. So please remember, I've already highlighted it will happen in the same menstrual cycle but with separate acts of coitus, with separate ovulation. Yes. So multiple eggs are released here and the sperm is going to fertilize it. Please remember, as I said, there would be twins. The father may be different. The father may be same as well. So this can be a heteropaternal as well. That is the key word that they could use, right? So don't get confused. Heteropaternal matlab twins hain, but the fathers are different, right? Good to go, everyone. Chalo, let's go forward now. What is the next thing that we are going to look at? So now we are going to look at the placenta and the fetal membranes or the hormones. Okay. So please remember there are two things forming the placenta. It is chorion frondosum and decidua basalis. Jaldi se batao, when does it start forming? It starts forming by 6 weeks. And when does placental formation complete? Formation is complete by 16 weeks. So 6 and 16. Okay. So 6 and 16. Yes, obviously it can be heteropaternal. Yes. But typically when we say heteropaternal, we use it for superfecundation. Okay. Then these are parameters that you should remember. Diameter kitna hota hai? 15 to 20 centimeters. The average thickness is 2.5. But who is going to tell me what is the cutoff for placentomegaly? Kaun batayega? So for placentomegaly, it should be bigger than 4 centimeters, right? Okay. Weight is going to be 500 grams. Ratio of fetus to placenta at term is 6:1. Please be very careful. यहाँ मैंने लिखा है ratio of fetus to placenta. If it is placenta to fetus, it will become reverse. 1:6 हो जाएगा. Okay. Remember, umbilical cord is always attached to the center. On which side? Fetal side. In fact, that's how you identify the fetal side. It is smooth, shiny, and it will have the attachment of the cord in the center. Remember, it has 2 arteries. Yes, 2 arteries, and it has 1 vein. Which carries the oxygenated blood? The umbilical vein. कहाँ से लेके जाता है? From the placenta to the heart. All this is how exactly the words would be used in your exam. So as I said, I've put in a lot of effort. Yes, is it going good for everyone? Okay. Then 2 important things. Remember, if we ask you about fetal circulation, yes, then it is day 21 post fertilization. But if we ask you about placental circulation, then it is going to be day 17. Yes, then it is going to be day 17. Can you tell me what is placental blood flow at term? So placental blood flow at term is somewhere between 500 to 750 ml per minute. Okay, so somewhere between 500 to 750 ml per minute. That is the placental blood flow. Okay. Chalo. The most important hormone is HCG. Yes. So it is produced by which cells, beta? Syncytiotrophoblasts. What kind of a hormone it is? It is a glycoprotein hormone. How early is it produced? As early as 8 to 9 days after fertilization. Okay? Now, please remember it has 2 subunits, the alpha and the beta subunit. So which one is specific? Remember it is the beta. And that is why all pregnancy test, है ना? Pregnancy test में कौन सा subunit are we testing? We are testing the beta subunit. Okay. If I ask you the, HCG most closely resembles which hormone? तो answer क्या करोगे? Single best answer will be luteinizing hormone. है ना? We have already said that it is functionally and structurally. है ना? याद है? Similar to LH. So functionally and structurally. Similar to what is the single best answer? LH. Perfect. All right. Then very, very important. Remember the doubling time is 48 hours. But when you say doubling time is 48 hours, this is for a live as well as intrauterine pregnancy. Okay? When do we see maximum levels? 10 weeks. When do we see minimum levels? 16 weeks. Okay, so minimum levels is less often asked, but maximum can be asked in the exam. So maximum at 10 weeks, minimum at 16 weeks. What are the important functions? So very, very important. Number one, it is going to maintain the corpus luteum of pregnancy. That's the key word. Okay? Second, it has role in immunosuppression. That is why the baby is not rejected. Third, it also decreases uterine contractions. And very, very important, it is the first stimulus for the release of what? Testosterone. Yes, so it is the first stimulus for the release of testosterone. Okay, everyone good to go? Please remember, HCG levels will be high whenever there is big placenta, and HCG levels will be small whenever there is small placenta. So all clauses of placentomegaly can have higher levels of HCG. Yes. So big जितना होगा उतना ज़्यादा HCG का level होगा. Is that clear to everyone? Okay. Perfect. Now let's go further. Progesterone is the second very, very important hormone. Yes. So where is it produced from in the first 8 weeks? Corpus luteum. So first 8 weeks it is going to come from the corpus luteum. And after 8 weeks the source becomes placenta. Can you recall and tell me what was the product that the placenta is going to use to make this? So it is made from maternal LDL cholesterol. है ना? Maternal LDL cholesterol. Perfect. Now, what are the most important functions? Number one, it is going to be responsible for making up of decidua. Yes, it makes up the decidua. Okay, what is the second important function? The second important function is again immune tolerance. Third, it is going to reduce contractions. So remember, progesterone decreases contractions, estrogen increases contractions. Yes? And it is responsible for all the physiological changes of pregnancy. Yes, I told you, for whatever physiological changes we say, the main reason is progesterone. ठीक? Now, coming to estrogen, please remember it is the same thing. Again, in the first 8 weeks, it is going to come from the corpus luteum. After 8 weeks, it is going to come from where? It is going to come from placenta. Now, which estrogen is specific to pregnancy? It is E3. है ना? E3. Now, let me see if anybody can recall. Can you tell me where is it E3 made from? What is the product that it is made from? It is made from fetal DHEAS, which is coming from the fetal adrenal gland. Yes? Okay. Next. It is the reverse. In every way, it is reverse of progesterone. So if progesterone decreases contractions, what is estrogen going to do? It is going to increase the contractions. Yes? Okay. All physiological changes are primarily because of progesterone. There are 4 changes which are because of estrogen. What are those 4 changes? Water retention. And do you remember what I have taught you? What was the reason behind it? Give me the why behind it. Upregulation of RAS. Yes. Second, pigmentation. So whether it is cloasma or it is linea nigra, any pigmentation, it is because of estrogen. Very good. All clotting factors increase. Who is going to tell me except which ones? Except 11 and 13. These clotting factors are going to actually decrease. Yes. So 11 and 13 decrease, everything else increases. What else is the function? It is going to increase thyroid binding globulin. Yes, so TBG increases. Okay, good to go everyone. The last important hormone is HPL, human placental lactogen, also called as what? HCS. Okay, it is also called as HCS, human chorionic somatomammotrophon. Okay, now what is the main function? The main function of HPL is what, beta G? It is insulin resistance. Yes. Who is going to recall and tell me when do you see maximum levels of HPV? Maximum levels are seen at 36 weeks. So as placenta becomes more mature, HPL keeps increasing. So what will happen to insulin resistance in pregnancy? It will also keep increasing. So insulin resistance also increases as POG increases. Okay? Chalo. Let's quickly talk about the most important physiological changes. Single best answer for all changes is progesterone. Combination is always a better answer, E plus P, but single best is progesterone. Okay. Now, definitely red cell mass increases. Yes. So red cell mass is going to increase in pregnancy by 20%. But plasma volume और ज़्यादा increase हो जाता है by 40%. So what happens to hematocrit? It is going to decrease. Yes, hemoglobin and hematocrit are going to decrease. Now, I want to ask you, what is the cutoff for anemia? Anybody? What is the cutoff for anemia? So, hemoglobin less than 11 and hematocrit less than 33. Yes, that would be the cutoff. Non-pregnant में cutoff क्या बताया था? 12. Perfect. बहुत अच्छे बच्चे हो. शाबाश. I'm so proud of you. Good going, everyone. Nice. What happens to WBCs? The WBCs are going to increase. They can reach up to 15,000. Okay. What happens to ESR? ESR is also going to increase. Yes. So ESR is going to increase. What was the main reason? Do you remember the Y has been a names PYQ? The reason is fibrinogen. Yes. What happens to platelet count? Now listen to me very carefully because it could be a potential question. Platelet count remains in the normal range, but does it fall from the pre-pregnant value? Yes. It decreases from the pre-pregnant value, but it remains in the normal range. And can there be gestational thrombocytopenia? Yes. So gestational thrombocytopenia is mild thrombocytopenia. It is the most common cause of thrombocytopenia in pregnancy. The platelet counts would not be very low. They will be between 1 and 1.5 lakh. They never go below 1 lakh. Okay, so then this is also physiological. So 1, 2, yes, 1.5. ये 5 है. Yes. Okay. Coagulation factors, we have already discussed what happens. They are all going to increase except 11 and 13. Okay, what happens to blood pressure? So systolic and diastolic blood pressures both are going to decrease. Plasma volume, we have already seen, is going to increase. Yes. Now, what happens to systemic vascular resistance? Very, very important. It is also going to decrease because of a fall in blood pressure. Nice. Cardiac output, it increases. Okay. Now, important. When do you see maximum cardiac output? It is highest in the immediate postpartum phase. Yes. Followed by second stage of labor. And during the trimesters, it is 32 weeks. So, followed by 32 weeks. But if AIMS people ask you what happens to cardiac output at term, do you remember what I have taught you? At term, it actually decreases a little. Okay? Chalo. Cardiac output high ke alawa, we will also ask you about low cardiac output. Yes? So please remember it is lowest in the supine position. What is the why behind it? Very good. Compression or IVC, which reduces the venous return. Okay. Which murmur is physiological? It is ejection systolic murmur. Yes, so ejection systolic murmur is physiological. Up to which grade? We might go to a little depth. So up to grade 2. Beyond grade 2, it becomes pathological. What about diastolic murmur? So please remember, when we talk about diastolic murmurs, the typical word we have to know is soft diastolic. Yes, and what did we say? Soft diastolic can be seen physiologically in up to 20% of women. So if it is not soft diastolic, if it is a harsh murmur or more prominent, it is pathological. Okay. In the respiratory changes, we are very fond of asking you about tidal volume and minute ventilation. AIMS के PYQs हैं. They both are going to increase. Yes. NEET के questions क्या हैं? They will ask you about reserve and residual volumes. So residual volume decreases and typically the expiratory reserve volume is also going to decrease. Okay. Perfect. What kind of a state is pregnancy? Compensated respiratory alkalosis. So when we use compensated, what happens to pH? No change. Yes, pH shows no change. Please remember, vital capacity also shows no change. Yes, vital capacity also shows no change. But what happens to PCO2, PO2? PO2 increase hota hai, PCO2 decrease hota hai. This is what is respiratory alkalosis. Okay. When we talk about renal physiology, they are very fond of asking you about the ureter car dilatation. Yes. So we are able to see ureteric dilatation. What is the reason? The reason is always to be answered as progesterone. But if we ask you which side do you see more, it is right side is more. Can you recall the reason why behind it? The reason is dextrorotation. Yes, so the right ureter is compressed more. Shabash, very good. Let's go forward. Then what happens to GFR? बहुत important है बेटा. GFR increases by almost 50%. And as a result of which, creatinine, blood urea, nitrogen, uric acid, they are all going to decrease, right? यहाँ पे मैंने लिखा है उनका clearance increase हो रहा है. So be very careful. Clearance is increasing, so serum levels will decrease. They will play with words. You have to be very conscious. Okay. Pituitary, NEET-PG का प्यार है. Yes. So NEET-PG keeps asking you. So pituitary increases a lot in size primarily because of lactotrophs. Yes. Now, which means it is susceptible to ischemia. What were the keywords? So a patient who is having severe postpartum hemorrhage and she develops postpartum hypotension. What will happen? Pituitary ischemia and which syndrome? Yes, it is going to be Sheehan syndrome. Yes, it's going to be the Sheehan syndrome. Okay. All right. Then what happens to thyroid gland? So as far as the gland size is concerned, you don't see any visible change. We already know about TBG. TBG क्या होता है? Increase. Very, very important. Total T3, T4, they are all going to increase. But when we ask you about free T3, free T4, then the answer is unchanged. What happens to TSH? It remains in the normal range. Okay, it remains in the normal range. Shabash, very good. I'm very happy with all of you. Then we are going to talk about diagnosis of pregnancy. So when we talk about diagnosis of pregnancy, we talk about presumptive signs, probable signs and the positive signs. Yes. So please remember, presumptive may anything that the woman feels herself. Do you remember my concepts from the class? Yes. So anything, if it is felt by the mother herself, it is presumptive. So look at quickening. Quickening is a presumptive sign. Yes. So do not do this mistake. Probable signs are the ones which are seen by the doctor. Okay. So these are the probable signs. The positive signs is the next table. So probable signs are seen on usually by manual examination. Yes. So what are the signs? So very important again for your exams. Remember the Goodle's is softening of cervix. Hagar's is softening of the isthmus. Yes. Shadwick's is bluish discoloration of vagina, vulva. It can be bluish discoloration of the cervix as well. But primarily it represents the bluish discoloration of the vagina and vulva. Okay. Osiander's sign is lateral vaginal fornix pulsations. Palmer's is regular rhythmic uterine contractions, the Braxton Hicks, right? Pisca sex unequal growth of uterus. Who's going to tell me the reason behind it? The why behind it is, yes, eccentric implantation. Okay. Then please remember and don't do this mistake. A positive pregnancy test, it is never a confirmatory thing. It is a probable sign. So positive pregnancy test is a probable sign. Now, the softening signs are the ones which come at 6 weeks. What about all other signs? They will come at 8 weeks, right? So all other signs at 8 weeks. Okay? Positive signs are confirmatory. So what are those signs? If you see a fetus on ultrasound, if you are able to hear the fetal heart rate, if you are able to palpate the fetal part, so then there is no doubt that the woman is pregnant. So these are probable, presumptive and positive signs. Good to go everyone. Are you with me? All the bachas are with me? Perfect. Then we are going to talk about teratogenesis or teratogens. Now, the most important period or the period between 3 to 8 weeks, please remember this is from fertilization. Yes, this is the period of greatest teratogenic risk because यहाँ पे क्या हो रहा है? Who's going to tell me? Gastrulation. Yes, formation of germ layers, formation of organs. So this is the most teratogenic period. ठीक है? Now, what are the important teratogens that we should know? So the first one is radiation exposure. So radiation exposure, if it is less than 5 rads, what will you do? Will you do MTP or will you continue the pregnancy? Continue. So no increase in any kind of anomalies or abortions will not happen. Next, very important, diethyl stilbestrol. What are the keywords? So T-shaped uterus. Second, vaginal adenosis. Okay. And third, vaginal clear cell cancer. Now, vaginal adenosis का क्या मतलब होता है? Adenosis means ulta conversion. Conversion of squamous epithelium to columnar. That is what is adenosis. Second, clear cell cancer is which type of cancer? It is a adenocarcinoma. Yes, it's an adenocarcinoma. Okay. What will be the keyword for isotretinoin? The keyword is going to be microtia or anotia. Okay? So microtia and anotia. What is the minimum time gap required for conception? 1 month. Minimum requirement is 1 month. Okay? Lithium तो बहुत पॉपुलर है. It causes Epstein's anomaly. Streptomycin. Yes. So all the mycins, what are they going to do? They are going to do a 8th nerve damage. Yes. So problems with hearing. Tetracyclines is very important. INICET के questions हैं. Yes. Teeth का discoloration. Okay. Thalidomide is a PYQ. So what does it do? Phocomelia. Proximal defect or a distal defect, beta ji? It is a proximal defect. Yes, so it is a proximal limb defect. Okay. What about valproic acid? It is a category X drug, not to be given. Yes, it will cause primarily spina bifida. Right? So this is absolutely contraindicated in pregnancy. Yes. ACE inhibitors, very commonly asked, they are going to do problems with the renal system of the baby. It can cause agenesis also, it can cause other problems as well. Chloramphenicol, INICET ka PYQ hai. What does it do? Grey baby syndrome, right? What about pre-gestational diabetes? So its characteristic is, yes, sacral agenesis. So this is most specific. What about VSD? VSD is most common, है ना? VSD क्या होता है? Most common होता है. और sacral agenesis most specific होता है. What is the other name? Caudal regression syndrome, है ना? SLE, INICET का PYQ है. It is going to cause a complete heart block. अब मेरी बात ध्यान से सुन लो. A potential MCQ that I think can come this year in your exams is phenylketonuria. Remember, it can cause microcephaly. It can cause microcephaly. Okay, so remember phenylketonuria. Okay, is that clear to everyone? Okay. Yes, valproate should be preferably changed. Okay, that is the only one involved with exception. Okay, so please remember this. Then we move on to investigations required that we should do for, yes, FAS is also microcephaly. FAS, fetal alcohol syndrome, yes, is going to be microcephaly, but along with that, remember there is growth restriction. Yes, and there are characteristic facial features. Everything is small, small, small. Okay. Now, first antenatal visit. Should we do hemoglobin for everyone? Absolutely yes. Yes, we should be doing a hemoglobin. Blood group and RH typing? Yes. VDRL? Yes. HIV? Yes. How screening or what kind of screening do we do? Opt out. Right? So the screening we do is opt out. Okay. Then everything that is here is a potential MCQ. Okay, I'm writing it. Ocha baba lo. Okay, potential new question is phenylketonuria. Chalo. Then urine screening. Usually in screening we will use dipstick. We don't send a blood test. Okay. Now dual test. Is it mandatory for everyone? No. So please remember dual test is not mandatory. Right? But should we advise? Yes. Okay. So what is included in the dual test? Remember it is HCG and PAP-A. Okay. HBS antigen again not mandatory, but we usually always write it. Should we do screening for gestational diabetes? Yes. What is the method? It is called as the DIPSI test. Okay. It's called as the DIPSI test. And remember, if the test is normal at the first antenatal visit, when should we again do it? We should repeat it at 24 to 28 weeks. Remember, any value which is more than 140 is gestational diabetes. But if it is more than 200, it will be overt diabetes. Yes, it will be overt diabetes. Shabash. Should we do it first trimester ultrasound for everyone? No. So first trimester ultrasound is again not mandatory. But yes, under certain situations, we will have to do the first trimester ultrasound. For example, gestational age assessment. In which patients would you need a gestational age assessment? Women with irregular cycles. Yes. Women whose LMP is not known. Women who conceived on OCPs. Yes. Again, I've taught you all this in your regular class. Okay. So, for all this, we would need a gestational age assessment. And yes, the parameter that we use is CRL. So, we are going to talk about it more a little later. Viability of pregnancy कैसे पता लगता है? By looking for cardiac activity. Okay, so by looking for cardiac activity. Suspected ectopic मतलब any patient who comes with pain in early pregnancy, we should do a ultrasound. Yes. Suspected molar, which means any patient with who comes with bleeding, any patient who comes with fundal height, which shows discrepancy with POG. So if there is a discrepancy of fundal height with POG, we should again do an ultrasound. Whenever there is twins, so there will be again discrepancy. Yes, also to determine then the chorionicity. The best thing is first trimester scan. Whenever there is any kind of abortion, yes, so either pain or bleeding, and then to do procedures like nuchal translucency and chorionic villus sampling. Yes, everyone with me? Chalo, let's look at the dual test. What is the best time to do dual test? 11 to 13 weeks. Okay. Now, what is a combined test? Combined test hota hai when you do ultrasound for NT and you also do a dual test. So this is the preferred method of screening. Okay. So this is the preferred method. It should be done in the first trimester. Yes. And when do we do it? We will do it between 10 to 13 weeks. Yes. So dual test or combined test can be done as early as 10 weeks as well. But most commonly we do it between 11 to 13. Okay. Now, Can you tell me, when I said dual test, we said dual test has HCG and PAP-A. Which one will decrease and which one will increase? I am sure you all know that HCG is going to be higher. What about PAP-A? PAP-A is going to be less, right? And as we said, most commonly done between 11 to 13. Okay. Now, they will give you a question. If you are doing an NT scan and it is increased, पहले मुझे ये बताओ, what will be considered as increased? NT more than or equal to 3 mm. If they ask you what do you do next, your answer has to be what? It has to be follow it up with a diagnostic test. Which diagnostic test? The answer has to be chorionic villus sampling. Yes, it cannot be what? It cannot be, what do we say? It cannot be amniocentesis. Why? Because amniocentesis is done in the second trimester. Okay. Now, quad test देख लेते हैं फटाफट. So when you say quad test, when do you do it? 15 to 22 weeks. But most common कब होता है? Most common is between 15 to 18 weeks. The earlier you do, the better it is. Okay. What are the components? HCG alpha fetoprotein. Please remember it is UE3 and it is inhibin A, not inhibin B. Yes? Okay. Can you tell me in Down syndrome which ones will increase and which ones will decrease? यहाँ पे already लिखा है. Alpha fetoprotein and estriol are decreased, whereas HCG and inhibin A are increased. Yes? And what should you do next if this is the finding? The answer should be perform amniocentesis for karyotyping. If this is the finding, you have to perform an amniocentesis. But look at the next line. If AFP levels are raised, not low, they are raised, then this is a marker of what? It is a marker of either neural tube defects or abdominal wall defects. Then what should you do? Then you should follow it up with ultrasound. So follow up with then a level 2 ultrasound. Yes? Okay, perfect. When can we do amniocentesis? We all know this. Amniocentesis can be done any time beyond 15 weeks. Yes? We want to do karyotyping. So what cells are we going to use? We are going to use the dermal fibroblast. Okay, dermal fibroblast. Also, please remember, I have taught you, let me see if you can recall. Can you tell me what is early amnio? Who is going to tell me what is early amniocentesis? So early is if it is done between 11 to 14 weeks. We don't do it because it causes fetal loss. Should we do level 2 ultrasound for everyone? Yes. Level 2 ultrasound has to be done for all pregnant women. When do we do it? Between 18 to 22 weeks. Okay. It is also called as anomaly scan or TIFA. Okay. Please remember, what about fetal echo? Do we do it for everyone? No. Only in high risk pregnancies. And when do we do it? Again, 18 to 22 weeks. Okay, 18 to 22 weeks. So we are done with the first part and we must now see some relevant images. So are you happy with how it is going, everyone? Yes. So now whatever we have done so far, we will do the relevant images of that as well. So I want you all to open up your image folder. Yes. And let's quickly start looking. Okay. So we have covered the theory part. So we will just focus on the most important things. So quickly, what is image number 1 here? So image number 1 is a normal placenta. They are again from your routine classes. So don't worry about anything. Yes, our purpose is to revise our own notes with you. Yes, so that it stays with you like very strongly. Can you tell me which side of the placenta is this? This is going to be the fetal side. Can you tell me the reason why? Because you are seeing the umbilical cord. Smooth, shiny fetal side. It is a disc-like structure. What is the finding in image number 2? Yes, this is going to be battledore. right? So this is a battledore placenta. Why? Because the cord is attached to the periphery. Yes, it is also called as marginal attachment. Yes. Can you tell me what will it cause? It can cause, yes, cord avulsion, and therefore it can cause retained placenta and postpartum hemorrhage. Yes, so cord avulsion and retained placenta and postpartum hemorrhage. Very good. Can you tell me what is image 3 and what is image 4? So they are both having two lobes, but in 3 they are similar. Yes, so they are similar. So what is this? This is a same size and therefore bilobata usually doesn't cause any problem. The cord is attached to both the lobes. Yes. 4 is succinturiata because one lobe is smaller, right? So there is a smaller lobe and cord is attached to the main lobe. It's not attached to the smaller lobe. Yes. What can this do? This can cause postpartum hemorrhage because of reaching smaller lobe. And this can cause both types of PPH, primary also and secondary also. Yes, it can be associated with vasa previa also. If it is associated with vasa previa, it is called as type 2 vasa previa. Yes? Okay, perfect. Can you tell me what is the next image, image number 5? This is velamentous attachment of the cord, right? Can I say that the cord is attached to the membranes? Yes. So cord is inserted on membranes. Yes. So cord is inserted on the membranes. Do they have a protective covering, the vessels? No. Yes. And this kind is typically associated with the next image. So what is image number 6? It is vasa previa. We will talk about vasa previa in theory as well when we do antepartum hemorrhage, right? So what do you see in vasa previa? We are seeing fetal blood vessels, okay, crossing over internal os. Yes, so fetal blood vessels crossing over internal os. Yes, therefore whose blood? Fetal blood. So if it is associated with vasa previa, this will be called as vasa previa type 1, which is what is the more common type of vasa previa. Yes, we will talk about management and everything when I go to antepartum hemorrhage. Okay. All right, let's look at the next image. So image number 7. Can you tell me which pregnancy sign am I eliciting here? So this is how we elicit the Hagar's sign, softening of the isthmus. And which sign is being elicited in figure 8? It is unequal enlargement. Very good. So this is going to be the Pisca sex sign, right? So this is at 8 weeks and Hagar's can appear as early as 6 weeks. Okay, is that clear? All right. Early pregnancy and ultrasound findings. What is the first finding of? They are all findings of intrauterine pregnancy. Yes, early findings. So let's keep numbering them. So the first one is called as intradecidual sign, which simply means you are seeing a gestational sac and all around it is the decidual reaction. Who is going to tell me the POG when we see it? The single best answer is 5 weeks on a transvaginal ultrasound, but it can be seen as early as 4.5 weeks also. Yes. So the single best answer is 5. Followed by intradecidual sign, you will see the double decidual sac sign, right? So that comes at number 10. So double decidual, can you tell me what are the two rings that you see? Two white rings. What are these rings? They are decidua capsularis and decidua parietalis. You are seeing them separately because they haven't fused. So who is going to tell me when do they fuse? Yes. So capsularis and parietalis. So they are going to fuse completely by 16 weeks. And this will lead to what? Obliteration of the cavity. Yes, it will lead to obliteration of the uterine cavity. Okay. The next sign that we will see is that the sac becomes bigger and we will see the double bleb sign. Yes, so this is the gestational sac and inside the sac we see two blebs. Okay, so who is going to tell me what are these blebs? So double bleb sign, one will be the yolk sac and the other will be the amniotic sac. Yolk sac typically can be seen as early as 5 to 5.5 weeks. That's how early you can see a yolk sac. Amniotic sac is usually seen around 6 weeks. Okay. So can you tell me when would we see the cardiac activity? Cardiac activity is again seen as early as 5.5 to 6 weeks, but the single best answer will be 6 weeks. And we use what? Doppler or ultrasound? We use M mode of the ultrasound, right? Motion mode of the ultrasound. Okay. The next image that we see here is which one? It is, yes, absolutely. You are right. We are seeing here the nuchal translucency. Yes, we are seeing the NT here. What is the best time to look for NT? 11 to 13 plus 6. Yes. So 11 to 13 plus 6 is the best time to look for NT. Okay. Which plane are we using? Sagittal or coronal? It has to be in the sagittal plane. And do we take the measurements from inside to outside, outside to outside, or inner to inner? So we take it from inner to inner margin and we will take it at the widest area. Yes. So at the widest area, we will take the measurements. And please remember, as I said, anything more than or equal to 3 mm is considered as raised NT. Raised NT का highest association किससे है? Trisomy 21. Followed by what बच्चा? Monosomy X. Followed by what? Then it can also be seen with cardiovascular anomalies. Yes, it can also be seen with cardiovascular anomalies. Perfect. The next image is already labeled for you. It is chorionic villus sampling. When do you do this? So chorionic villus sampling can be done anywhere between 10 to 13 weeks. Do not do it at less than 9 weeks because it will cause limb defects. Remember, out of chorionic villus and amnio, which gives faster results? It is going to be chorionic. The results are faster, usually in 48 to 72 hours, right? Okay, the other image where we are taking the sample from the amniotic fluid is amniocentesis. Should be done beyond 15 weeks. We have already talked about amnio in the theory part, so I am not going to talk about again. But out of CVS and amnio, please remember amnio is more reliable, it is more safe, but it takes more time as well for the results. So it takes more time for the results. Okay. What is this one? This is PUBS. PUBS is the other name for chordocentesis. We take the sample from the umbilical cord. Do we take it from the vein or the artery? It has to be the umbilical artery. Yes. From the fetal side or placental side? Placental side. When do we do it? At and beyond 18 weeks. Typically, in which condition do we do it? Yes, Rh negative, where we want to know the hemoglobin level of the baby, right? So these were the relevant images so far. Are you with me, everyone? Yes? Should we move ahead? Chalo. Let's go back to the theory. So is this going good for everyone? Yes? Going good for all? Are you able to revise? Okay. Let's move on to the next part. Okay. Now, when we talk about the, sorry, did I write the artery? No, it is the vein. I will correct it. Okay. So we'll take the sample from the umbilical vein. Did I write the artery? Sorry, please correct it. It's the umbilical vein. Okay, I'm correcting it here as well. So you also can correct it. Okay, so a typing error. So I need to correct it there. So everyone needs to correct. Yes, yes, yes. Okay, chalo. Let's go forward now. Okay, done everyone? Done everyone? Yes. The umbilical vein, because it has the lower pressure, so chances of bleeding are less. Okay, we always do it with concepts, so you don't do it wrong. Are you with me now, everyone? Yes, quickly, thumbs up. So let's go forward now. Okay, so the next thing is going to be abortions. Yes, so when we say abortions, it is typically pregnancy loss before 20 weeks. Please remember, WHO also uses another method or another criteria which is less than 500 grams, but we typically use before 20 weeks. Okay, now what is the cause of early pregnancy losses? So whenever you say early losses, we mean first trimester, and the cause is going to be chromosomal anomalies, right? So the cause is going to be chromosomal anomalies. When we talk about APLA, it can cause first trimester losses, but more characteristic for APLA is second trimester. Yes. What about cervical insufficiency? Always will cause second trimester losses. So please remember, cervical insufficiency will never cause first trimester abortions. APLA can cause both, but more common is second trimester. Now, when you say chromosomal abnormalities, it is usually the trisomies, all trisomies put together. Yes, but if we ask you single most common cause among chromosomal, then it becomes monosomy X. The single most common is monosomy X, okay, followed by trisomy 16. How do I teach in the class? 16 से 16%, है ना? So next is trisomy 16. Now, if we ask you most common trisomy at term, that means we are wanting to know which is the viable one. So it is trisomy 21. So it is also the most viable. Okay, perfect. Then, when do you say it is recurrent losses? So we say it is recurrent pregnancy loss when it is 3 or more consecutive losses. Okay, then we say it is RPL. Now, there are only 4 established causes of recurrent pregnancy losses. What are those causes? So yes, it can be APLA, it can be uterine abnormalities, it can be chromosomal abnormalities, it can be endocrinopathies. But in the endocrinopathies, the one which is the most established cause is hypothyroidism. So endocrinopathy is a group. As a group, it becomes very, very common. But they will never give it as a group. They usually write hypothyroidism. Okay. So this is with respect to the 4 causes of recurrent pregnancy loss. All right. And what is in general the order we have taught you? We have taught you that when we talk about comparison of groups, the groups में सबसे ज़्यादा common क्या है? Endocrinopathies, followed by uterine abnormalities, right? Because here we are not talking about one individual entity, we are talking about a group. Is that clear? Okay. Please remember, if we ask you most common cause of RPL in first trimester, what will you answer? You will answer chromosomal. If we ask you most common cause of RPL in second trimester, answer it as uterine abnormalities. Yes, so then it will be uterine abnormalities. Perfect. APLA का criteria क्योंकि बदल गया है, that is why I have put this picture for you. So we need 3 or more losses, right? So we need 3 or more losses. Please remember, earlier the cutoff was 10 weeks. Now the cutoff for losses is up till 15 weeks. So more than or equal to 3 losses up to 15. Then there was a fetal death. Earlier the criteria was beyond 10 weeks. So now it is what? It is beyond 15 weeks, right? So one fetal death beyond 15 weeks. So any time from 16 weeks onwards. Then the women with APLA are very likely to have preeclampsia, especially if she develops preeclampsia with severe features, which is early onset. Do you remember what is early onset preeclampsia? So early onset preeclampsia is if it happens before 34 weeks. Yes? Then please remember, it is always more than or equal to बच्चे, ठीक है? More than or equal to. Okay? Then maybe if the patient does not develop preeclampsia with severe features, but if she develops uteroplacental insufficiency, then again we should think of APLA. So please remember, any MCQ where they are saying a combination of abortions and a combination of UPI or preeclampsia, think of APLA. That's what NEET-PG will do. So any MCQ where you have a combination of abortions and UPI or abortions and preeclampsia, think about APLA. Okay? All right, let's go further. As far as management is concerned, please remember, if your patient has APLA, but there has been no thrombotic event and there has been no pregnancy loss, then what are you going to do? Then you are going to give only low dose aspirin. Okay, yes, these are the ACR guidelines. Okay, EULAR ACR guidelines. Okay, then if there is history of a thrombotic event or there is history of a pregnancy loss, then you will give both heparin and low dose aspirin. Which heparin do we use here? Low molecular weight heparin, and these two drugs will be given throughout the pregnancy. Okay. Please remember, if we are asking you a general answer, the general answer will remain always. If we are not specifying anything, then the general answer will remain as heparin plus aspirin. Okay? Then let's move on to cervical insufficiency. When do you make a history-based diagnosis? So you make a history-based diagnosis if the keywords are painless losses. So there is a painless cervical dilatation, which means there are no uterine contractions. If they cause more than or equal to 3 consecutive losses in the second trimester, yes, and the upper limit we take is up to 28 weeks, then this is a history-based diagnosis. So it has to be painless, it has to be consecutive 3 or more losses, they have to be in the second trimester. How do you make a ultrasound-based diagnosis? So if the criteria for history is not met, let's say she has only 1 loss, right? Then we will have to do a transvaginal ultrasound, and what we will measure here is cervical length. What is the cutoff that we take? Very, very important, less than 25 mm. Then we will say it is a ultrasound diagnosis. Yes? Okay. Now, if your patient has history-based diagnosis, is it necessary to confirm cervical length? No. Now, it is not necessary to confirm the length. So, we can straight away put a cerclage. What is the best time to put a cerclage? 12 to 14 weeks. On the other hand, women who do not meet the history-based criteria, we will put a cerclage whenever they come. Right? Now listen to the other indications of cerclage. If your patient has a short cervix and she also has history of preterm labor, should we again put a cerclage? Yes. So again we can put a elective cerclage at 12 to 14 weeks or whenever the patient comes. Please remember, along with cerclage, do we always give progesterone? Yes. So along with cerclage, we will always give progesterone. Now, let us look at the next clinical condition. Your patient has a short cervix, but there is no history of pregnancy loss and there is no history of preterm delivery. Then what are you going to give? Now you are going to give only progesterone. There is no need to put a cerclage. Okay? Okay. Very, very important for exams. Contraindications for cerclage. The most important one is ruptured membranes. What is the next one? Anytime the MCQ says uterine contractions. Yes. So anytime your MCQ says uterine contractions, do not put a cerclage. If there is a current pelvic infection or there are gross anomalies. Okay. Progesterone supplementation has to be done throughout pregnancy, beta. Okay. Now, which is the most common cerclage? It is McDonald's. It is also called as a purse string suture. है ना? Now, what are you going to do if the patient comes to you and the cervix is fully dilated? So, if the cervix is dilated, then provided the membranes are not ruptured, then yes, we can apply a cerclage in emergency. This emergency is also called as rescue cerclage. What is the name of this cerclage? Now we call it as the worm stitch. So worm is the name of rescue cerclage. Okay. When do we do the transabdominal cerclage? So transabdominal is applied when the previous cerclage fails. It is also the treatment of choice in non-pregnant state. And in the transabdominal, which one is the best? The best is laparoscopic cerclage. Okay. Please remember, lash and lash can also be done in non-pregnant, but it is not the best one. Okay. So the best one is lap. While lash and lash, as I have said, is a vaginal procedure, it is not the best one. Okay. When do you remove the cerclage? You will remove it at 37 weeks or whenever the woman goes into labor or she develops ruptured membranes. So all these would be an indication to remove the cerclage. Now, let's look at the different types of abortions and how you will decide. So which are the types of abortions where the os is closed? So os is closed in missed abortion, in threatened abortion, and in complete abortion, right? In which of these the bleeding is going to be heavy? So it is going to be heavy in complete abortion because she has to expel everything out and then the bleeding will stop. Yes. So please remember, in missed and threatened, the bleeding is usually very mild. Okay. Then what about pain? So again, the pain is a characteristic feature of abortion because of uterine contractions. So they will happen in all types of abortions. But typically in complete abortion, the patient will say that the pain improves after she expels. So please remember, in complete, there is history of expulsion. Whereas in missed and threatened, there is no history of expulsion. If you do an ultrasound, what is the finding? No cardiac activity. That is why it is missed abortion. In threatened, it is a live and intrauterine pregnancy. So that's why it is a threatening. And in complete abortion, everything is expelled. So the uterus is empty. So what will happen to fundal height? It will be less than the POG in complete abortion. It will also be less than the POG in missed abortion. Why? Because the baby is dead. But in threatened abortion, the fundal height will correspond to POG. Okay. In which two conditions is the os open? So the os is open in inevitable and in incomplete. In which of the two will you have, history of expulsion? Incomplete. So here there is history of expulsion and in inevitable there is no expulsion. In both the products can be seen. Yes, in both of these the products can be seen, but where do you see it? Yes, that's the important thing. In inevitable, the products are still seen in the uterus, whereas in incomplete, they will be seen in the cervical canal as well as some products in the uterus. So here you will see the products in cervical canal. Yes, and management is very simple. For missed abortion, you have to either do an evacuation or you have to give medical methods of abortion. Yes. In threatened, you continue. Yes. Then inevitable will automatically complete. For complete, no intervention is required, and for incomplete, you have to do a suction and evacuation. Are you all with me? Good to go? Let's look at the MTP Act now very quickly. So when you talk about the MTP Act, remember it allows MTP up to 24 weeks. This is typically true for a rape victim. But when we ask you for contraceptive failure, it is up to 20 weeks. What about gross anomalies? Then it can be done even beyond 24 weeks. But we need approval of the medical board. Who constitutes the medical board? I think we all know. So medical board is an obstetrician plus a radiologist plus a pediatrician. Yes? Okay. Then remember this, up to 20 weeks, we need opinion of only one registered medical practitioner. Between 20 to 24, it has to be opinion of 2 registered medical practitioners. Whose consent is needed? Only the female. Husband consent is not required. Okay. Up to 9 weeks, what method will be used? Outpatient medical abortion. What drugs do we use? We use mifepristone, which is also called as RU486. I'm sorry, that's a typing error by me, not 482, it's 486. Yes, the dose is 200 milligrams oral. Then what are you going to give? Mifi ke saath you will give misoprostol. The dose is 800 micrograms. It can be given oral also, vaginal also. Most commonly we give it oral. Beyond 9 and up to 12 weeks, what are you going to do? Vacuum aspiration. So this aspiration can be manual also. It can be suction evacuation with an electronic machine as well. Okay. Beyond 12 weeks, we call it as second trimester abortions. And what methods are we going to use? So we can use prostaglandins. They are the most commonly used. And among that, it is actually misoprostol. Do you remember the dose? I have taught you it could be a potential MCQ for your upcoming exams. It is given after 48 hours, bache, not 24 hours. Okay. So yes, 400 micrograms. Yes. And you are going to give it every 3 to 4 hourly per vaginally for a maximum of 5 doses. Can we also use PGE2? Yes. Okay. Can we also use PGF2? Yes. We can also use F2. Okay. Then what are the other drugs we can use? We can use intraamniotic saline or extraamniotic ethacridine. We can also use oxytocin. The surgical method in the second trimester is called as D and E. Please remember this is not D and C. Okay, D and C is very different. It was earlier used in first trimester. So this is D and E. Okay? Okay, so everyone good with abortions? Is it going good for all of you? Are you able to revise and recall with me? And do you realize that it's your own notes, the ones that I made with you? Yes, good to go every bacha? Chalo. All right. Okay. 24 weeks, beta. MTP is now allowed up till 24 weeks. Okay? Chalo. Ectopic pregnancy. Let's look. I'm glad. Okay. See, I've put in a lot of effort to know what I have to put here so that my students feel confident also. It is doable also. They don't have a FOMO on missing out anything. And it is very revisable. So we've compressed the whole obstetrics into one day. We'll compress whole gynae into one day. And in DBT, we will compress it together into an 7 to 8 hour session. Yes, so it is subsequent revision. Yes, DBT is something that is a must do towards the end. Okay, वो इसका भी एक concise version होगा. Okay, चलो. So ectopic pregnancy, what is the most common location? Fallopian tube. In the fallopian tube, it is the ampulla. Who is going to tell me the reason why? The reason is because it is the site of fertilization and it has what? It has maximum number of plicae. You remember this? Okay. What would be the words used so that you think of ectopic? There is going to be pain, amenorrhea and bleeding. Can you tell me which is the most common out of these? It is going to be pain. Then, what is important risk factors? Previous ectopic as well as a previous tubal surgery, okay? And any kind of tubal damage, especially if it happens with PID. If we ask you most common risk factor, then the answer is PID, okay? Please remember, assisted reproductive techniques like IVF increase the risk. And please remember, among contraceptive methods, tubal surgery like tubal ligation, progesterone only pills and IUD increase the risk. Okay, they increase. You remember what we've taught you? We've told you that it increases the relative risk. है ना? Chalo. What would be the findings on pelvic examination? Yes, what would be the findings? So look at this. Will the uterus be enlarged? Yes, it will be slightly enlarged. Cervical motion tenderness can be there. Adnexal tenderness can be there. And we can find an adnexal mass. Can you tell me what is the most important one here? Adnexal mass. The most important finding is adnexal mass. Okay. Investigation of choice is, yes, transvaginal ultrasound because it has early detection, high sensitivity. Now please remember, if you see a gestational sac with a yolk sac or cardiac activity or fetal pole outside the uterus, then this is what is diagnostic. You don't need anything else, okay? But there are certain findings which we call as suggestive of ectopic. What are those findings? So when we say suggestive of ectopic, number one, no intrauterine pregnancy, but presence of an adnexal mass. Yes? Okay. Then if they see you are seeing free fluid in the pelvis, it could actually be telling you about ruptured ectopic. Yes? What are you going to do if you see findings which are suggestive? So if we ask you next step, what should be the answer? The answer should be serum levels of beta HCG. Yes, then it should be serum levels of beta HCG. What is the cutoff we use? 2000 international units. Yes. So if you see findings which are which are suggestive, and beta HCG is more than 2000, what are you going to do? So if it is more than 2000, then we will start medical management. What will you do if it is less? Then you will repeat after 48 hours. If it is less, you need to repeat beta HCG. Perfect. How do you make a diagnosis of ruptured ectopic? What would be the key words? So we will say, number one, there will be history of amenorrhea for sure. But along with that, the bleeding is going to be more. But where is the bleeding? It is not external, it is inside. So please remember, there will be severe pain. There can be hemodynamic instability. And very, very important, there can be signs of peritonitis. Who is going to tell me what are the signs of peritonitis? So guarding, rigidity and rebound tenderness. So if we use these words, then we are dealing with ruptured ectopic. Perfect. Very good. Now, I told you the preferred management we do is medical, but we will only do medical management if we meet the requirements. So what are the requirements? Number one, the patient has to be hemodynamically stable. The HCG value should be less than 5000. The sac size should be less than 4 centimeters and there should be no cardiac activity. Okay? What kind of ectopic? Ruptured or unruptured? It has to be very, very important. Unruptured ectopic. Okay? It has to be unruptured ectopic. What is the drug of choice? Methotrexate. The route is intramuscular. Who is going to tell me the dose? 1 milligram per kg. Yes, so 1 milligram per kg. What will happen on day 7? Day 7 value will decrease to call that it is successful medical management. I want you to tell me it will decrease by how much? By at least 15% from day 4 value. ठीक है? When do you do surgical management? Surgical management करेंगे. Number 1, anytime your MCQ says ruptured ectopic. ठीक है? Number 2, if the MCQ says family is complete. Number 3, criteria for medical management not met, which means maybe the sac is big, maybe the HCG value is more, maybe cardiac activity is present. Okay. Next, failed medical management. Please remember, if we say day 7 value increases, then what should you do? Don't give repeat methotrexate. This is failed management. Do surgery. Okay. Now, please remember, when we do surgery for an unruptured ampullary tubal ectopic, what is the procedure? Ostomy. If it is unruptured, we will preferably do a ostomy. Your exams will ask you, when do you do a jectomy? Yes, so when do you do a jectomy? It is done when it is a ruptured ectopic, or when the family is complete, or we said if it is a very big pregnancy, for example, bigger than 5 centimeters, yes, then we will do a jectomy. Named criteria are important. So what are the criteria for cervical ectopic? We say Palman criteria. Yes. What about ovarian ectopic? Spiegelberg criteria. What about abdominal? Studiford. Apart from this, likely MCQs are these. What is a cornual ectopic? So cornual is an ectopic pregnancy which is in the intramural part. Is it same as angular? No. Please remember, I am telling you these are potential new MCQs. Angular is an intrauterine pregnancy. It's not ectopic. Okay. You are likely to get heterotopic. Okay. Heterotopic is when there are 2 pregnancies at different sites of implantation. Most commonly it is one intrauterine and one tubal ectopic. So there has to be simultaneous 2 pregnancies. What is the most important risk factor for heterotopic? IVF. Okay, IVF. All right. So heterotopic is, the risk factor is IVF. बेटा जी मेडिकल मैनेजमेंट फेल्स में आप नहीं देते हो मोर methotrexate. Failed आप तब बोलते हो when you've already given 3 methotrexates or the levels are rising. Then you have to do surgical. ठीक है? Let's go forward. So next is going to be molar pregnancy. Again, something that the NEET-PG is fond of asking. Everyone ready? Are you ready? Then we will do some images as well. Okay, so we use the term gestational trophoblastic disease. Okay, it will, no, you can never give methotrexate in heterotopic, only surgical. Okay, now there is abnormal proliferation of placental tissue, so cytotrophoblast as well as syncytio. So which means it is primarily a disease of chorion. Yes, so it is a disease of chorion. You say benign, okay, you say benign when it is both complete mole and partial mole, they are benign. What about malignant? Malignant may we have 4 things. What are the 4 things? We include invasive mole, we include choriocarcinoma, we include PSTT and ETT. Can you tell me which is the most common? The order in which I have written. The most common is invasive mole. The least common is ETT. Okay. So the order in which I have written is the order from most common to least common. Now, complete mole. What would be the key words that your examiners will use? So number 1, they will say that there is a pregnancy which is early, either first or second trimester. But there are no fetal heart tones, okay. The passage of vesicles is there. So there is going to be bleeding, as I've mentioned in the next line. And please remember, it is altered or dark in color. Yes, so passage of vesicles, fundal height tends to be large, we will see. So let's look at this. Most common signs are what? Fundus larger than the dates. Yes, so fundal height is larger. There are no fetal heart tones. There can be cystic enlargement of the ovaries, which are called as what? Theca lutein cyst. All these are only features of complete mole. Now, what is the classic finding on ultrasound? Snowstorm. What are the other names? So we also call it as Swiss cheese pattern. Yes, also called as honeycomb pattern. है ना? So Swiss cheese, honeycomb are other words. All right. Now, this table is very important. I'm going to highlight most of it comes in the exam. So karyotype is the first important thing. So triploid is partial mole. Complete mole is diploid. And the most common karyotype here is 69, XXY. Okay. So out of the two, the more common is 69XXY. All right. Then what is the typical finding on ultrasound? Partial mole is going to present as missed abortion. Even on ultrasound, it is missed abortion. And here we know we are going to see the snowstorm appearance. The uterine size is small in partial moles. Here it is larger. What is the risk of conversions we will see? Theca lutein cyst, I have told you, are only seen with complete mole, but important for upcoming exams. Do you see in all complete moles? No. They are not seen in every patient, but yes, they are only seen in complete moles. HCG values are more than 10 to the power 5 in complete mole. Okay. Risk of conversion to GTN is important. Yes. It is 15 to 20% in complete moles and up to 5% in partial moles. Very good. Fetus किस में होता है? Only and only partial mole. It is not there in complete mole. Amnion, vascularity, all this is present in partial mole. It is not seen in complete mole. Remember I said it is a disease of chorion. Yes. Very important is villus edema. Villus edema is very, very extensive in complete mole and it is focal. I say ऐसे याद करो partial में partial. So there is focal villus edema. What about trophoblastic proliferation? It is extensive in complete moles. Very, very potential MCQ are last two. In which one do you see atypia and P57 staining? So remember, P57 is positive in partial mole, all P's. P57 positive partial mole, so triple P. It is negative in complete mole. And atypia is more in complete mole. Remember, it has more risk of conversion to neoplasia. So atypia will be more in complete mole. Now, whenever we ask you management, right, what are you going to do? So your treatment of choice is suction evacuation. Yes, we will do preoperative beta HCG chest X-ray. Okay. Now, do we give prophylactic chemo to everyone? No, it is only given to high-risk patients. A potential MCQ, who are high-risk patients? So patients who have what? HCG value which is very high, uterine size is more, yes. Then age is more than 40 years and they have large theca lutein cyst. What drug are we going to give? Again, the answer is methotrexate, but we can also give actinomycin D. Okay? When do you do hysterectomy? Only if family is complete and she has a complete mole. Okay? Only if family is complete and she has a complete mole. Please remember, this is important. It reduces the risk of persistent disease but does not eliminate. So are you going to still follow up? Yes, we will still follow up with monitoring. Okay? Even after hysterectomy. Now, follow up kaise karna hai? Again, a potential MCQ. You are going to initially do weekly values till you get 3-week normal values. Then you will do monthly values. The total duration is going to be 6 months. What is the contraception of choice? OCPs. Which one is to be avoided? Intrauterine device. Okay? Now, how do you make a diagnosis of GTN? If you see rising values, please understand this. The weeks are 2, but the values will be 3. There will be 3 values. So day 1, day 7 and day 14. So there are, so as I said, there are 2 weeks, but the values are going to be 3. Similarly, what is the answer here? Plateau. The weeks are 3, but the values will be 4. एक ज़्यादा होता है. Value is 1 more than weeks. ठीक है? There could be a possibility of histological diagnosis as well. And if you see metastatic disease. Okay, perfect. When do you say it is good prognosis? Because when you say good prognosis, what are we going to give? We are going to give single agent chemo. Right? So when do you say it is good prognosis? Let's do this. If the HCG value is less, if the diagnosis is made early within a 4 months, if there is no metastasis or only lung metastasis, only lung, only vaginal are considered as good prognosis. Who is going to tell me what stage is lung metastasis? It is stage 3. What stage is vaginal metastasis? Stage 2. No prior chemotherapy. Age is less. Then, if previously the patient had molar pregnancy, please remember, after full term pregnancy, it is considered as poor prognosis. After molar, it is considered as good prognosis. Number of metastasis is less. Tumor size is also less. Okay. Now, the initial treatment to be offered is single agent chemo if the patient has a WHO score of 6 or less. Yes. Whereas combination therapy is given if the score is more than 7. Now, when you say low risk patients, what is the drug of choice? It is, please identify the keywords. It is multi-dose methotrexate. The agent is one, but it is multi-dose. All right. Route, as we have said, is intramuscular. How do you alternate? You alternate with folinic acid. Yes? Okay. High risk patients will receive multi-agent chemo. All of you should know the drugs named by this small acronym. Okay, so you should know what is Imaco. The C here is not cisplatin. It is what? Cyclophosphamide. All right, so be very careful. Is it clear to everyone? It is cyclophosphamide. Okay, what is the period of surveillance? It is going to be for 12 months and the contraception of choice remains the same, OCP. What else? The one that you should avoid is IUD. Okay. Good prognosis means you have to give them single agent chemotherapy. Bad prognosis means you will have to give them multi-agent chemotherapy. All right. Chalo. Let's look at the next very important topic. Okay, it is going to be antepartum hemorrhage. And what are the two most important things when you talk about APH? We talk about placenta previa and we talk about abruption. Yes, so let's start looking at keywords. So when you say placenta previa, it means placenta is either over the internal os or it is near the internal os. Yes. Low risk is WHO score more than or less than or equal to 6. That's what we have written. Score is 6 or less, then it is single agent. That's what we've written. Multi-agent is for score 7 and more. We have written absolutely correct. FTP beta G is full term pregnancy. Okay, so if it develops after full term pregnancy, it's a poor prognosis. All right. What is abruption? It is premature separation of the placenta. All right. What would be the kind of bleeding? Sudden and painless. But please remember, warning hemorrhages, they are seen in which one? Placenta previa or abruption? They are seen in placenta previa. Right? Here, the bleeding is also going to be sudden, but it will be associated with pain. So pain is seen with abruption. Warning hemorrhage is seen with, yes, it is seen with placenta previa. Placenta previa is painless. We often say it is causeless, right? Then, as we said, in abruption, there is going to be pain. Bleeding कैसा होता है? It is bright red. Okay, recurrent matlab warning hemorrhages. Here it is dark and altered. Okay, then what is the feel of the uterus? Soft and non-tender, whereas rigid uterus, tender uterus and fundal height more than POG is what is abruption. Fetal distress can happen in both, but it is more common with abruption. Risk factors are important. What are the characteristic risk factors for placenta previa? They are previous placenta previa, cesarean section, multiparity and twins. What are the most important risk factors for abruption? Important, a question with hypertension, question with trauma, polyhydramnios. Please remember, increasing age, increasing parity and smoking are risk factors for both placenta previa as well as abruption. Okay, so they are risk factors for both. Is that clear to everyone? All right. So once you identify whether the question is on previa and abruption, let's look at the management. So please remember, for abruption, the management itself is delivery. How you will deliver is what we want to ask you. Yes. So number one, cesarean will be done only if there is maternal or fetal jeopardy or distress. Vaginal delivery is the preferred mode. Now, please remember, we want to accelerate the process of vaginal delivery. So what are we going to do? Perform amniotomy. Yes, so it will induce labor, and if there is already labor, what is it going to do? Augment it. Yes, so it is going to be augmentation. Fundal height in placenta previa is usually corresponding. Okay. Please remember, the MCQs confuse you. Avoid cesarean if they say fetus is dead, right? So then we will not do a cesarean. Can we do conservative management? Very rarely. We will only do it if she is remote from term, which means less than 34 weeks. But along with that, the mother and the baby have to be stable. There should be no contractions. There should be no DIC. The bleeding should stop. So extremely rare, and therefore do not think of rare things. Go with common things. If you go with rare, you will do your answers wrong. Okay. What complication can happen? Now, severe abruption, we all know, can result in shock. Yes, it can result in shock. What else? It can specially lead to renal failure, and it can result in DIC. We will ask you what is the cause of DIC. Batao, the cause of DIC is release of tissue thromboplastin. Yes, release of tissue thromboplastin. I am sure you all remember cuvular uterus. So we will ask you, where do you see it? We see it in abruption. What is the finding? You will see a discolored uterus, right? A uterus with typically bruises, right? So reddish blue because of blood going there. What do you do in placenta previa? Batao? Yes. So number one, placenta previa may avoid PV exams, no PS, no PV. Yes. You admit the patient, you monitor them, which means, yes, we will do what? We will do a conservative management. Now comes tricky questions. What are the tricky questions? If your patient is asymptomatic, which means she is diagnosed on ultrasound, what are you going to do? Then you have to do a follow-up scan. When do you do a follow-up scan? Initially at 32 weeks and then at 36 weeks. Okay. If your patient is symptomatic, which means she has come to us with bleeding, what do we do then? If the bleeding is mild, then we can do a conservative management. But if the bleeding is severe, or the baby has distress, or the mother has hypotension, then we will do a emergency cesarean section. Yes. If you are doing a conservative management, yes, conservative management का नाम क्या है? Johnson's and McAfee's regime. So if we are doing a conservative management, when do we do the termination? It is then done at 37 weeks. Yes. What complications can happen? So complications that can happen here are this. So if your patient has a previous scar, what can happen? It can result in PAS, placenta accreta spectrum. The three types there are increta, accreta, percreta. Yes. Risk factors for PAS क्या होते हैं? They are same as risk factors for previa, but the most important one is history of previous cesarean section or a previous surgery. Yes, placenta previa itself is a risk factor. Okay, DNCs are a risk factor. Advancing age is a risk factor. Okay, now diagnosis. We will usually use ultrasound with Doppler. Is Doppler mandatory? No. But if we have it, it is better to use it. What will be the findings? Important. Placental lacunae, also called as lakes. Yes, heterogeneous placenta. Do you remember what word I have given you in the class? Batao. Moth-eaten. Yes, it will look like a moth-eaten placenta. Then there will be loss of bladder line and there is loss of clear space behind the placenta. Now, I presume these findings can be very potential MCQs this year for your exams. What is the best investigation? The best is MRI. Yes. This is typically done in which case? Typically when we are suspecting a percreta, we want to know the depth. What do you do with this? Always, when we talk about PAS, the management is elective cesarean and usually we will do a hysterectomy as well. Okay. Please remember, no manual removal. If you try and manually remove it, you will lead to severe hemorrhage and mortality. Okay. So PAS is very important. Vasa previa, you all know. So fetal vessels are traveling over the internal os. I told you which two conditions is it associated with? Quickly, vela mentis, but it can also be seen with succenturiata, right? Okay. Now, please remember they are coming from the fetal circulation. So this is going to be associated with severe fetal distress and even fetal death. All right. Diagnosis. Usually diagnosis is made in labor, but sometimes, yes, diagnosis can be made before labor when you are doing an ultrasound and it has to be now with Doppler. Please remember Doppler is mandatory because only then you will see the blood. Okay. So you will see vessels crossing over internal os. When in labor, the patient will usually have a painless bleeding, severe distress. Yes, typically associated with what? I've written rupture here. What rupture is this? Membrane rupture. Uske niche likha hi hai actually. I've written all keywords here for you. So typically you will see this with membrane rupture. So membrane rupture, severe distress and bleeding. Which test are you going to do? APT. Can you tell me alkali or acid? This is a alkali or an acid? Alkali test. We use NaOH. Okay, what are you going to do? Always do an cesarean section. So it is emergency cesarean. In case it is diagnosed before labor, then you will do a elective cesarean any time after 34 before she goes into labor. Right? So then we will do a elective cesarean. The third important DD for placenta previa and abruption is uterine rupture. When do you say it is complete rupture? When all layers including the serosa rupture, so fetus will come out of the uterus, right? What is incomplete rupture? Incomplete rupture hota hai dehiscence. What is intact here? Serosa. Yes, the myometrium is ruptured, but serosa is intact. What would be the key words to tell you we are dealing with rupture? Most importantly, patient will be a case of previous cesarean, but she can also be a case of myomectomy. Yes? Is it always going to happen with these? No. Sometimes with drugs. If we ask you one important drug which can cause rupture, then the answer is misoprostol. Okay, so therefore, misoprostol is contraindicated in previous cesarean. It will cause rupture. Now, what would be the clinical presentation? There will be sudden bleeding and the bleeding is going to be very painful. There will be loss of contractions. Okay, there will be severe distress. Even the baby can be dead. Yes. There can be maternal shock, so tachycardia, pallor, yes. Then the most important thing, fetal parts are superficial, so easily felt or difficult to feel? Easily felt. What about abruption? Abruption they are difficult to feel. It is the reverse with uterine contour. Contour किसमें easily feel होगा? Abruption. Difficult to feel in rupture. So it is the reverse. ठीक है? So contour is difficult to feel, but fetal parts are easy. And this is the reverse in abruption. Okay. The most specific sign is loss of station. But if we ask you most common sign, first sign, then this is fetal distress. Okay. So most common or first is distress. Okay. Now, what are you going to do? You are going to take her for an emergency laparotomy. Yes, you deliver the baby. If possible, we can repair the uterus, but if there is excessive bleeding or the patient is unstable, we will have to do a hysterectomy, right? So this is early bleeding and late bleeding. Are you all good? Are you all with me? We will see the corresponding images and then we will give you a break as well. So are you all ready with the corresponding images? All right. So what is this finding here? So what was the labeling? Okay. So what is the thing here? So this shows you a complex adnexal mass with empty uterus. What is it suggestive of? Suggestive of ectopic. Remember, not diagnostic. Okay. The other signs that you will see, it is called as tubal ring sign or bagel sign. They are the same. They are also what? Suggestive of ectopic. So what are you going to do next if you see signs suggestive of ectopic? HCG. Yes. So if it is more than 2000, begin treatment. If it is less, repeat. Okay. Yes, we can also see the ring of fire sign. But please remember it is not specific. Can we also see it in corpus luteum? Yes. So it is a non-specific sign. Okay. What circlage do you see here, bache? Oops. What circlage do you see here? So what we see here is McDonald's. We have already discussed all about it. So I'm not going to repeat all that. When do you put it? When do you remove it? Contraindications and all those things. Yes, it is per string. Do we use absorbable sutures or non-absorbable? Non-absorbable. Right? So we will use non-absorbable sutures. What is this next device? Carmen's cannula. What do you use it for? Suction and evacuation. What is the pressure generated? 600 millimeters of mercury. What size do you use? It should correspond to the size of the uterus, right? So the size should correspond, okay? What is this? This is a MVA syringe. Quickly tell me, what is the capacity? 60 ml. What is the pressure? The best answer is 660 followed by 600 millimeters of mercury. Up to what time did we use it? 12 weeks. Does it need electricity? No. No electricity. Yes? Snowstorm, everybody knows. I also told you we call it as honeycomb. We also call it as Swiss cheese. So they are all terms for molar pregnancy. Which molar, beta ji? Complete mole. There is no fetus inside, and if I take it to the adnexa, I will see big cyst in the ovary. Are they bilateral or unilateral? Bilateral. We will see bilateral cyst in the ovaries. Okay. So also, since we have already covered level 2 ultrasound previously, we will do some more images here. Let's look at this. It's already labeled. So anencephaly. This is the only anomaly that can be diagnosed in first trimester. How early? 10 to 11 weeks. What is the sign called as? Excellent. Frog eye, also called as Mickey Mouse sign. Yes. So frog eye sign, Mickey Mouse sign. So this is anencephaly. Associated with poly or oligo? Poly. Yes. So it's associated with polyhydramnios. What would be the dose of folic acid? Yes, it has to be high dose, 4 milligrams up to 12 weeks, right? So whenever there is history of neural tube defects or there is woman on anti-epileptics, we are going to give 4 milligrams per day, right? Okay, what do you do in sickle cell? Sickle cell anemia, 5 milligrams per day, but we will give it throughout pregnancy. Yes, so we will give it throughout pregnancy. What about folic acid deficiency? 1 milligram per kg, again throughout, okay, till the time you correct anemia. All right, what sign do you see here? It is the lemon sign, basically concavity of the frontal bones. Yes, so lemon sign. What is it a marker of? Spina bifida, right? So it's a marker of spina bifida. Banana sign, again spina bifida. What is the banana here? It is the banana shaped cerebellum. Yes, can also be seen in which one? Arnold Chiari, Chiari type 2. Okay. Omphalocele. How do you identify that omphalocele? Because we have a covering membrane. And the umbilical cord, this is the umbilical cord, is attached at the top of the sac. Yes, so the cord is attached at the top of the sac. Yes, yes. Okay. Then very important, when we talk about omphalocele, please remember associated with high AFP or low AFP? High alpha fetoprotein. Yes, quickly tell me, associated with what else? High risk of chromosomal anomalies. Yes, so there is increased risk of chromosomal anomalies. Also, there is a higher risk of which aneuploidy? Which is the typical answer? All can be seen, but the single best answer is trisomy 18. Yes, trisomy 18. Yes, is that clear to everybody? Okay. Gastroschisis, there is herniation, but what is the problem here? No covering membrane. Is it associated with anomalies? No, there is no association with anomalies. Will you see it in Down syndrome? No, we will not see it in Down syndrome. Does it have high AFP? Yes. Is it more high than omphalocele? Yes. The higher levels are more in gastroschisis. Yes. Let's look at these images which your NEET-PG is very fond of asking. So this is type 1 placenta previa, also called as what? It is also called as low-lying. When do you say it is low-lying? When it lies within 2 centimeters of internal os. This is type 2 placenta previa, also previously called as marginal. When the placenta is partially lying over internal os, then it is called as partial, also called as type 3. And when the whole of placenta lies over the internal os, then it is called as type 4, also called as central or complete. Now we don't use these terms. Now they are simply together called as placenta previa. right? So this was an older classification. Now 2, 3 and 4 are called as placenta previa, while 1 is called as low-lying. What is the investigation of choice? Transvaginal ultrasound, okay, TVS. Perfect. What is this finding, beta ji? Who's going to tell me? What is the finding that you see here? Jaldi jaldi batao. Yes, this is what is cuvillaire uterus, a uterus with bruises. What is it also called as? Uteroplacental apoplexy. What is it seen with? Abruption. Yes, so uteroplacental apoplexy seen with abruption. Is it an indication to do hysterectomy? No. But is it a risk factor for PPH? Yes. So it will increase the risk of PPH. It will increase the risk of hysterectomy, but it is not an indication. What is this? Who's going to tell me? What is this? So yes, this is PAS. This is an intraoperative procedure. This is the uterus here, which looks intact in the upper part, and in the lower part, the placental tissue is invading into the myometrium. So this is PAS, right? So this is an intraoperative finding with PAS. So at this note, we have covered a lot of it, and now you deserve a break. So we will take a short break, not a lunch break. So it will be a 15 minutes break, and we will be back, and we will take the lunch break a little later, maybe 2:15ish. Okay. So 15 minutes and you're going to be back. We should be able to wind up by maximum 7, but with breaks. Yes. So go back, but tell me, are you all enjoying it? Do you think that this is going to help you a lot for your exams? This is cuvillaire beta. This is the bluish, reddish blue discoloration. Yes. So this is the cuvillaire uterus. Yes. I've worked really, really hard. I've put really all my night work into this to make it for you. And therefore, it is very close to my heart, right? It had to be in the same order as my notes so that, you know, you don't find it anything new. It's completely my notes, but it's a concise version. Yes? Okay, somebody wants to see the banana sign. This is the banana sign where I said you will see a banana-shaped cerebellum. Okay, so 15 minutes. At 12:50, we are going to be back and we will restart. Yes, take care everyone. Loads of love to you. See you soon. Chalo. Anji, is everyone back? All right. Let's move forward now. Okay, so the next topic that we're going to be discussing is going to be hypertension in pregnancy. Yes, and the first thing that we NEET-PG people are now asking is clinical questions where they will ask you the diagnosis, right? So when do you say it is gestational hypertension? So the pregnancy has to be beyond 20 weeks. The BP has to be high on 2 occasions and it has to be 4 hours apart. There should be no proteinuria. There should be no end organ damage. Yes. Now very important, the blood pressure has to return to normal within 12 weeks postpartum. Okay. And remember, what we do is conservative management. You will give antihypertensives only when the BP is consistently high. When do you do the termination of pregnancy? So then we will be doing a termination at 37 weeks. We don't take the pregnancy beyond 37 weeks. Okay? When do you say it's preeclampsia? So the findings are absolutely same, but the only thing now has to be that there should be either proteinuria or there should be end organ damage, or it could be both. Okay? Now, when do you say it is proteinuria? Again, they've been repeatedly asking this. So remember, we will say proteinuria when it is +2 or more on dipstick or 300 milligrams in a 24-hour urine sample, right? Or we say protein creatinine ratio of more than 0.3. Okay? Now, when do you say it is end organ damage? So when we say it is end organ damage, you have to know that this is likely to come as an exam question also. So then the requirements are, it could be any of these. Okay. Platelet count kitna hona chahiye? Less than 1 lakh. Creatinine should be more than 1.1. Liver transaminases more than twice the normal value. Pulmonary edema and any kind of cerebral symptom. So it could be headache, it could be dizziness, It could also be visual symptoms. So then you say it is end organ damage. Okay. Now, when we talk about risk factors, there are certain things or at certain places where we ask you risk factors. So remember, first pregnancy or primigravida is a risk factor. Extremes of age and obesity are risk factors. Medical conditions which specially increase the risk are which ones? A patient who has chronic hypertension, diabetes, kidney disease, APLA. Please remember, I've told you before as well. So APLA, SLE, they are important risk factors. Okay. Then multi-fetal pregnancy, or please remember IVF pregnancies, right? So they are all going to increase the risk. Extremes of inter-pregnancy interval, very short intervals and very long intervals also tend to increase the risk. Yes. Now, this line is very, very important. Smoking is protective. Okay. Smoking is protective, whereas placenta previa and preeclampsia have a negative association. Can you tell me what has a positive association? It is preeclampsia and abruption. Okay. They have a positive association. Okay, everyone? Okay. Pathophysiology, this is one topic where they do ask you. So please remember, it is primarily absent vascular remodeling. Yes. And you have to know, when we say absent remodeling, what is going to happen? There is going to be these parameters, which I have, again, this is a photo from the class itself. Remember which ones are going to increase. So placental factors like SFLT1 and SENG are going to increase. Yes, which ones are decreasing? VEGF as well as placental growth factor are decreasing. Nitric oxide को क्या होता है? Decrease होता है. What about prostacyclin? Decrease होता है. Thromboxane A2 increase होता है. Right? So anti-angiogenic factors are going to increase and angiogenic are going to decrease. Very good. So what all this does is basically uteroplacental insufficiency is there. Yes. And there is a reduction in intravascular blood volume. Okay. Because of which the kidney compensates and there is vasopressor release, and which causes hypertension. Right. So pathophysiology is important. Yes. Now I want to ask you, when you say vascular remodeling, quickly, who's going to tell me which vessels undergo remodeling? Spiral arteries. Who controls these remodeling? So this is decidua NK cells. Remember, I told you it happens in two phases. What was the first phase? 12 weeks. Second phase, 16 weeks. Okay. So these are the other things that you should know about vascular remodeling. Okay. Which cells do it? Extravillous, cyto or syncytio? Cytotrophoblast. And which cytotrophoblast? Endovascular? Yes, they have to be the endovascular cytotrophoblasts, right? So these are important questions. You should know them. Let's go further now. If we ask you specific treatment, this is going to be delivery, and you have to remove the ischemic placenta. When do you do it? You will typically do it at 37 weeks. Up till 37, we do a conservative management, and beyond 37, we deliver. What is the mode of delivery? Vaginal delivery. Yes, vaginal delivery is preferred. Very good. आगे बढ़ते हैं. Very, very probable MCQ always keeps coming in the exam. When do you say it is preeclampsia with severe features? So whenever there is a very high blood pressure, right? So if it is as high as 160 by 110 or any evidence of end organ damage. We have already seen what end organ damage features are, and these are the same. Yes. So anytime there is end organ damage, anytime there is severe hypertension more than or equal to 160 by 110, we say it is preeclampsia with severe features. Okay. Now this is important because the management is different. When it is preeclampsia with severe features, when do you do the termination? Now you will do the termination at 34 weeks. Without severe features, we were doing a termination at 37 weeks. Okay. please remember, in case your patient anytime has fetal distress or maternal jeopardy in terms of, let's say she develops renal failure, she develops pulmonary edema, then these would be indications to do termination at any gestational age. So when do we say any? When there is either very high risk to the mother or to the baby. All right. Now, antihypertensives always are being asked in the exam. So please remember, what are the first line medications and which ones are contraindicated? So among first line, we have methyl dopa, we have labetalol, we have nifedipine. All three are first line. But when we ask you drug of choice, what is the answer, bacha? Then it is labetalol. Labetalol is both alpha and beta blocker. It is not just beta blocker. Okay. Then please remember important contraindications. Never use labetalol if your patient has asthma or your patient has heart failure. Don't use labetalol in that case. Use alternatives like nifedipine or methyl dopa. Okay. What are second line drugs? So you can give hydralazine, but when do you give it? You give it only in hypertensive emergencies. Yes, when the BP is very high, then yes, the second line drug is hydralazine. Which ones are contraindicated? You all know it's an important question. So ACE inhibitors, everyone knows. Apart from these, angiotensin receptor blockers, renin inhibitors, diuretics, and even beta blockers. Now please be careful. Can I give a beta blocker for heart failure or any other condition? Yes. But beta blocker should not be directly used for treating hypertension. Is that clear? Okay. Now, when we talk about eclampsia, it is a complication. So what complication is happening here? There is severe vasospasm in the brain. So there is cerebral vasospasm and there is cerebral edema. Okay. What is the first thing you do if the woman has eclampsia? You are going to, secure her position and then you will secure her airway. Okay. So position secure the airway. Then yes, you have to eventually do a termination, but you will do it after stabilization of the mother. So very, very important. You will quickly secure the airway. You will stabilize the mother by doing what? By giving Magsalve and antihypertensives. Yes. So you stabilize and then you have to deliver. There is no conservative management. Please remember the delivery is again vaginal. So what we prefer is vaginal delivery. Now listen to me very carefully because then you do it wrong in the exams. When we say your patient has sudden onset of headache, epigastric pain, visual symptoms, we will take this as impending eclampsia. It's like the premonitory symptoms that she's about to throw seizures. So what are you going to do? You have to remember anytime the MCQ says this, it is impending eclampsia, and look what I have written. The treatment is exactly like eclampsia. So which means you have to stabilize the patient and then you have to deliver, which means you have to give Magsalve, you have to give antihypertensives and you have to deliver, right? So it is treated just like eclampsia. Magsalve is super important, always coming in the exam, something or the other. So let's look at this. Please remember, Magsalve is not an antihypertensive agent. So you have to give antihypertensives to her. Second, the route of excretion is going to be renal. Okay. Third, loading dose will not change even if your patient has renal insufficiency, right? Only the maintenance dose will change. Third, next important thing. You will give Magsalve ka maintenance dose only if patellar reflex is present, respiratory rate is more than 12, and urine output is more than 100 ml in 4 hours. Or what is the other way of saying it? 30 ml per hour. Which means I want to ask you, if there is a reduction in urine output, should you give Magsalve? The answer is no. You will not give Magsalve. Okay. But if we ask you, is oliguria a sign of toxicity? No, oliguria is not a sign of toxicity. We are not giving because the route of excretion was urinary. Is that clear? So please remember, I've told this repeatedly in the classes as well. Oliguria is not a sign of toxicity. Then what are the therapeutic levels? 4 to 7 milliequivalents. Repeatedly asked, what is the first sign? The first sign is loss of patellar reflex. So what do you do if you see the first sign? Now you send serum magnesium levels. Do we send serum magnesium levels routinely? No, we don't. We will only send the serum levels when you see the signs of toxicity. Okay. Next. What are the other things that Magself can do? Magself is also a weak tocolytic agent and it is also used for neuroprotection of the baby. But when do you give it for neuroprotection? Only if you are anticipating a delivery before 32 weeks. After 32 weeks, the brain is developed. The baby does not need a neuroprotection. Okay. Next, let's talk about HELP syndrome. So HELP is a feature of usually severe preeclampsia. Yes. So what are you going to see here? The patient is going to present with right upper quadrant or epigastric pain. Please remember this is the most common symptom. But she can also have other symptoms like nausea, vomiting. It typically develops in which trimester? Third trimester. Yes, third trimester. The diagnostic criteria, you should know the name. They're called as Tennessee criteria. Okay, Tennessee criteria. Now what do we need? We need all the three. We need hemolysis, we need elevated liver enzymes, and we need a low platelet count. You should know how will we look for hemolysis. So for hemolysis, we need at least 2 of these. It could be a peripheral smear with what finding? Schistocytes. It could be bilirubin level more than 1.2 and it could be low haptoglobin and high LDH. Yes. So any of these 2 and we will say she has hemolysis. Okay. How do you manage? Like severe preeclampsia. So you have to deliver her, but you will deliver her at and beyond 34 weeks. We can also give prophylactic Magself during labor. Okay, so we can also give prophylactic Magself during labor. We will treat the hypertension with labetalol. So everything remains the same. When do you say it is chronic hypertension? Very important. Either the patient develops hypertension before 20 weeks or she is a known case of hypertension prior to pregnancy. Okay. Please remember, if your patient has gestational but the blood pressure remains high beyond 12 weeks postpartum, then you again change the diagnosis to chronic hypertension. Okay. Now, when do you say, so this is very probable MCQ now, chronic hypertension with superimposed preeclampsia. So you will say, when your patient is a known case of hypertension, but she develops any of these after 20 weeks. What is that? She could develop worsening hypertension. She could develop new onset proteinuria and she could develop end organ damage. So if she is chronic hypertension, but she develops these things, then we say it is hypertension with superimposed preeclampsia. Now, coming to DDs. So one of the important DDs, especially of HELP syndrome, is acute fatty liver. NEET-PG is very fond of it. Please remember it is a rare disease. It's not a common disease. Typically presents again in the third trimester, but unlike HELP, it has a very high mortality rate. The presentation is also similar. It will present with pain. So there is pain. And again, she can have jaundice. She may have mild fever as well. Yes, but fever is uncommon. Okay. Now, remember, she could also have underlying hypertension. So yes, preeclampsia itself is a risk factor. So it can very well mimic preeclampsia. So how will you differentiate whether it is HELP or severe preeclampsia? You have to look for keywords. So what are the keywords? If the patient develops acute renal failure, pancreatitis, encephalopathy, right, then you have to think of AFLP. So basically, the patient will develop liver failure, which is usually not seen in preeclampsia or HELP. Yes, the lab findings could be given to you. So apart from liver enzymes which are raised, you will see what else? Features of DIC, hypoglycemia, raised ammonia levels. These are the key markers that tell you that it is acute fatty liver. Whatever it is, once it is acute fatty liver, we have to deliver the patient. So you are going to deliver, that is the management. Okay. Intrahepatic cholestasis. Again, not a very close DD, but yes, a DD for HELP syndrome. But what is the presentation here? It's not going to be pain. The presentation here is pruritus, right? So there is pruritus. Please remember there is no pain. And typically they will tell you that it is more on palms and soles. It is more at night. Okay. They could ask you risk factors, especially NEET-PG. So remember, estrogen is what is going to is implicated in this. Apart from that, multifetal pregnancy gene could be asked. The gene is primarily ABCB4. It could be B11 as well, but the single best answer is ABCB4. It has a very high recurrence risk, right? So if there is a previous history, it's very important. The recurrence risk is almost up to 70%. Okay. Then the pathophysiology is bile acids are not cleared from the body. So it's accumulation of bile acids. So when we ask you diagnostic test, it has to be serum bile acids. That is what is going to be the diagnostic test. Okay. And the higher the levels, the more is the risk. The liver enzymes can be mildly raised. Okay. So they could be mildly raised. What is the drug of choice? Ursodeoxycholic acid. It will reduce the bile acid levels. When do you induce labor? 37 to 38 weeks. Yes. So you are not going to do a preterm delivery, but usually we want to do a delivery by 37 to 38 weeks. What are the fetal complications? Do you remember anybody? It can cause sudden intrauterine death, meconium aspiration syndrome, and itself it can cause preterm delivery, so prematurity. So these are the fetal risks. Okay, good to go everyone. Are you with me? Chalo, let's move on to what you should know for diabetes. So when do you say it is pre-gestational? So when your patient is a known case of diabetes prior to pregnancy. Yes, known case of diabetes prior to pregnancy. How do you decide that? Although this is medicine, but you should know these cutoffs. What are the cutoffs? Fasting ka cutoff kya hai? 126. HbA1c ka 6.5. Random plasma levels more than 200. And 2-hour OGTT more than 200. So then you say these are criteria for pre-gestational or overt diabetes. Okay. Then when do you say it is GDM? So how are we going to screen? So first important thing, we do universal screening for all pregnant women. Second, it has to be done at the first antenatal visit. If it is normal, we will do it again at 24 to 28 weeks. What should be the minimum time gap between two tests? 4 weeks, right? So there should be at least 4 weeks gap between the two tests. All right. Then what are the important things about this test? Number one, fasting is not mandatory. The glucose load that we give is 75 grams. Okay. Second, we will not take a fasting sample. We will take a sample straight away after 2 hours. The cutoffs I have already told you. If it is more than 140, it is gestational. If it is more than 200, then it is overt diabetes, right? Now, if the value is more than 140, what do? Then you are going to initiate medical nutrition therapy, which means diabetic diet. If it is less than 120 on a diabetic diet, then you will continue diet, right? Because 120 is our target level. INICET is very fond of asking you. So our target is less than 120. So if it is less than 120, you continue diet. But if it is more than 120, then it is indication to start insulin. Again, something that NEET people are fond of asking. Now, if the value is straight away more than 200 of a screening test, then you directly start insulin. Okay. Please remember, whatever insulin you are giving, or when we talk even about maternal insulin, does it cross placenta? No. Please remember this. Insulin will not cross placenta. Glucose will cross placenta. IAP DSG criteria are not usually asked in NEET, but they are important for INICET. Yes. So the cutoffs are fasting more than 92, 1 hour PP 180 and 2 hour PP more than 150. Even if one value is deranged, we will call it as gestational diabetes. Okay. Now, please remember, when we talk about pre-gestational or overt diabetes, they have a very high risk of fetal anomalies. Would you see it with gestational? No. So please remember, anomalies are not increased in GDM. Bar bar aata hai. Yes. Next, most common I have already told you is VST. What is the most specific one? It is going to be caudal regression syndrome. What is the other name? Yes, sacral agenesis. Yes. Okay. Let's go on to the next thing. Do we do the ultrasound? Yes. Now please remember, we will also do an ultrasound in the first trimester if the patient has pre-gestational diabetes. Why? Because they have higher risk of anomalies. They can have anencephaly. Yes. Whereas if she is just gestational diabetes, then we will do a level 2 ultrasound. Fetal echo किसमें करना है? Pre-gestational, gestational or both? Fetal echo has to be done only in pre-gestational. We don't need it in gestational. Okay. Then every month we are supposed to do ultrasounds. Why? Because there is risk of fetal macrosomia and risk of what? Polyhydramnios. So diabetes is a very important risk factor for polyhydramnios. Yes. So you have to keep the screening going. Then it is high risk pregnancy. So we are going to start screening the baby. When do you start screening? Again, the fetal monitoring will begin at 32 weeks. Okay. Please remember, how do you monitor? You will monitor by doing a biophysical profile. You can also do NSTs, but you would not require Doppler. Doppler किसमें करते हैं बताओ? Uteroplacental insufficiency में. Yes. So here we will do NSTs, we will do, biophysical profile, but we don't need Doppler. And as I said, you begin at 32 weeks. Okay. When do you do the delivery? You will do the delivery at 39 weeks if it is a well-controlled diabetes. It doesn't matter whether it is controlled on drugs or it is controlled on diet. If it is well-controlled, you deliver at 39. Okay. Whereas if it is poorly controlled, we can deliver a little early, anywhere between 36 to 38 plus 6, right? Please remember, we will never go beyond 40 weeks. That is why I have written do induction at 39 to 39 plus 6. The single best answer will be 39 weeks. When do you schedule a cesarean section? The cesarean will be done if fetal weight is more than or equal to 4 kg. This is Indian guidelines. American guidelines say 4.5 because वहाँ पे macrosomia का definition is 4.5. India में macrosomia का definition is 4 kg. So for us, the cutoff for cesarean section is 4 kg. Okay. And again, when do you do it? 39 weeks if it is well controlled. All right. Please remember, when we talk about insulin requirements in labor, then they usually decrease in labor. So what are you going to do? You will stop insulin on the day of induction or cesarean. Yes. So you will give the night dose, but you will not give it on the day of cesarean section. Is that clear to everybody? Very important, repeatedly asked, what are the neonatal issues? So baby will have hypoglycemia, not hyper. जब तक वो fetus है, inside है, it is hyper, but once it is out, it is hypo. There is also hypocalcemia, polycythemia, hyperbilirubinemia, and respiratory distress syndrome, right? So these are important. They are repeatedly asking this. A related thing to diabetes is macrosomia. So we must talk about it. So when we talk about macrosomia, as I said, the Indian guidelines are birth weight more than or equal to 4 kg. We also use another cutoff, which is fetal weight more than the 90th percentile. Okay, there are two definitions, but what we use more commonly is the weight. Okay, now what are the risk factors? We all know it is diabetes. Please remember, it can happen with both types of diabetes, gestational as well as pre-gestational. But the other important risk factors, obesity is a standalone risk factor, excessive weight gain is a risk factor, advanced age, previous macrosomic baby. The most important one, please remember, it is related to male sex. Okay. Hypoglycemia because the baby has excess insulin, but the glucose has stopped. So that is why the baby will now have at birth hypoglycemia. Okay. How do you do estimation of fetal weight? We need ultrasound for it, right? The best way through ultrasound is the Hadlock's formula, where we use all these parameters: biparietal, head circumference, fetal femur length, abdominal circumference. But if your exams ask you single best parameter for fetal growth, what will you answer? Then the answer will change to abdominal circumference. Okay. Now, please remember, why are we talking about macrosomia? Because it can cause certain problems. For example, in the mother, it can lead to a risk of operative deliveries, perineal tears, and postpartum hemorrhage. Yes. Please remember, as far as the fetus goes, the baby is likely to have, very, very importantly, we all know shoulder dystocia. The baby can also have asphyxia. Neonatal, we all know the baby can need intensive care admissions because of hypoglycemias and other injuries, as well as respiratory distress. We've already told you, if you want to avoid these complications, we will do an elective cesarean if the weight is more than or equal to 4 kgs, right? This is in a diabetic pregnancy. Sometimes they will ask you, what is the cutoff used in non-diabetics? Then the answer is 5 kg, right? So in non-diabetics, it is 5 kg. For diabetic, as far as Indian guidelines are concerned, it is 4 kg, right? Let's talk about shoulder dystocia. So can you tell me the name of the sign? I've already written, it is turtle sign. But can you tell me, there is a delay in the delivery of shoulders. By how much time? Can you tell me? So delay of delivery of shoulders by 1 minute. Yes. So more than 1 minute delay in the delivery of shoulders is going to be considered as shoulder dystocia. Yes. We use the helper maneuver. So first, it's an emergency, call for help, give an episiotomy. Okay. The first maneuver we do is to the legs of the mother, which is MacRoberts. What exactly do you do here? You hyperflex the thighs. So remember, I have told you it is abduction and flexion. Okay, so it is abduction and flexion. If this fails, then we will give suprapubic pressure. Do not give fundal pressure. What do you do if this also fails? We can try things like Gaskin maneuvers. Although it is an older maneuver done by midwives, the doctors are specialized, right? So we usually will not do Gaskin, but we can. But please remember, helper is a mnemonic, but sometimes, we might be very specific of what do you do next. So if you have done MacRoberts, if you have given suprapubic pressure, then you should go on to removal of posterior arm, right? So removal of posterior arm if suprapubic pressure fails, because these are all external maneuvers. So before you do the internal maneuvers, so that's where I'm trying to correct you. When you say enter maneuvers, they are internal maneuvers. Enter का मतलब क्या है? You will put your hand in the pelvis. You enter the pelvis. So internal maneuvers are our last resort. So we'll first try removal of posterior arm. Then we will go to internal maneuvers like Rubin's and Wood's corkscrew. Yes. Last resort. What is the last resort? The last resort is Zava Nelly. Do you all remember what is Zava Nelly? You have to push back the head and take her up for cesarean section. Okay. Jacques Mears is the other name for removal of posterior arm. ठीक है, उस maneuver का नाम है वो. Okay, what are the problems that the baby can have? Very, very importantly, brachial plexus injury, typically Erb's palsy. कौन सा tip hand कहते हैं? Policeman's tip hand. But yes, the baby can also have fractures. Typically, which is the only destructive maneuver we do? Yes, Jacques Mears should be done before U-beams. Yes, so the only destructive maneuver that we can do is cledotomy. What is that? Where we will cut the anterior clavicle to reduce the diameter. Do we do a symphysiotomy? No, no symphysiotomies. The only one that we can do is cledotomy. Okay, let's move forward now. So let's talk about a topic in short, which is anemia in pregnancy, more of PSM, less of gynae, but yes. We already know the cutoffs, less than 11 grams and hematocrit less than 33%. You should know the classification. So mild, moderate and severe. You call it severe when it is less than 7. 7 to 9.9 is moderate and mild is from 10 to 10.9. Okay. Most common anemia in pregnancy is iron deficiency, which is, I'm sure you all know, microcytic and hypochromic. Yes. Removal of posterior arm has to be done before the enter maneuvers because they are external maneuvers. Okay. All right. What is the prophylaxis program as per the government of India? We are going to give how many tablets? Only one tablet. 60 milligrams of iron, 0.5 milligrams of folic acid. When do you start? 4th month, or we can say after 12 weeks. So beyond 12 weeks, we will give this. Remember, it has to be continued throughout pregnancy, which means 180 days during pregnancy and 180 days postpartum. We should also be doing deworming. The drug of choice is albendazole. The dose is 400 milligram. It's just a single dose. Please remember, I've written after the first trimester, so don't give it in the first trimester. Okay. Then you should know a little about iron sucrose because we are using or asking you questions about it. Now, as far as management of anemia goes, let's look at that first and then I will tell you about iron sucrose. So if your patient has severe anemia, so this is a graph from Anemia Mukt Bharat Abhiyan. So if there is severe anemia, you are going to look at hemoglobin levels. If the hemoglobin is less than 5 any time, you start with blood transfusion. Okay. If it is between 5 to 6.9, then you have to look at gestational age. If the age is less than 34, then what do? Then you give injectable. But if the age is more than 34, then you will give blood transfusion. Yes, then you will give blood transfusion. On the other hand, if your patient has mild to moderate anemia, then you will look at gestational age. If the age is less than 34, you are going to begin with IFA tab. What is the difference here? Now you have to give 2 tablets, not 1, because we are treating anemia. If the age is more than 34, then we can begin with injectable iron, parenteral iron, right? and you are going to look for improvement after 1 month. Okay, so you're going to look for improvement after 1 month. If you are giving oral iron to your patient, yes, and you see no improvement, then we might have to start her on injectables. Okay, so therefore we must know a few more things about injectable iron. When we say injectable iron sucrose is the drug of choice. Please remember, we give it only as IV infusion. Okay, what are you supposed to know? Indications. So anytime your patient has moderate to severe anemia, right, and oral iron is ineffective or she is not tolerating, then we'll have to switch to parenteral. Remember, parenteral iron is contraindicated in first trimester. So if your patient has anemia in the first trimester, what are you going to give her? You are going to give her rather, yes, oral iron. If it is very severe anemia, you're going to give her blood transfusion. Yes. What dose of iron sucrose do we give? We will give a maximum. This is the maximum dose, 200 milligram per dose. The maximum frequency can be 2 to 3 times per week. As I said, it is an IV infusion and we give it over 15 to 30 minutes. Okay. How do we know what is the total dose? So we use Ganzini's formula, right? The Ganzini's formula is take the body weight in kgs, multiply it by target hemoglobin, which for us will be 11 grams, minus the actual hemoglobin into 2.4, and this plus 500 is for the stores. So this will give us the total iron required by the patient and we can give it over multiple infusions. Yes. कौन सा एक फॉर्मुलेशन है जिसमें आप एक ही बार में 1000 मिलीग्राम दे सकते हो? Carboxymaltose, right? So the benefit of carboxymaltose is large dose in a single infusion can be given. Also, please tell me, do iron sucrose and carboxymaltose, do they need a test dose? No. So the test dose is not required for these. It was required for the older iron preparation. So no test dose. Yes, is that clear to everybody? Okay. Please remember, any time your patient has signs and symptoms of heart failure, there is cough, there is edema, there is breathlessness, right? So if there are signs of heart failure, always answer it as blood transfusion. Whenever we say blood transfusion, please remember we mean packed cell volume. We will not give whole blood. Is that clear to everyone? Yes? Chalo. So then we will move on to the next topic. So this is going to be heart disease in pregnancy. Again, let's focus on what are the most likely things to be asked. So sabse pehle, if we ask you about developed countries and developing countries, there is a difference. In developed countries, now congenital heart disease is most common. In developing countries like India, it is still rheumatic heart disease. And can you tell me among rheumatic, which is the most common? Mitral stenosis. So for us, it is mitral stenosis. Yes. Can you tell me what is the most common congenital heart disease? It is ASD. We are talking about heart disease in the pregnant woman, not in the baby. Okay. So now it is ASD. It's not VSD. All right. Then conditions where pregnancy is contraindicated, which means your advice to the patient should be preferably termination of pregnancy, or we can say MTP, right? What are those conditions? Number one, if your patient has Eisenmenger syndrome or severe pulmonary hypertension, if she has severe mitral or aortic stenosis, heart failure, the typical cutoff for MTP is ejection fraction less than 30%. Marfans, but please remember, Marfan alone is not important. It has to be Marfans with aortic root involvement. So a dilatation of the aortic root. Okay. Similarly, it can be coarctation also, but then it has to be with involvement of aortic valve, right? So coarctation, but not alone. coarctation with involvement of aortic valve. That makes it severe. Yes, aortic root, aortic valve. Okay. Now, anticoagulant, something that we are repeatedly asking in the exams. Prosthetic heart valve is the only condition in pregnancy where we can give warfarin. Otherwise, please remember that warfarin is a category X drug, right? We don't give it. The only condition for which we can give it is prosthetic heart valve, right? Now, what are you going to do? So if they specially give you the dose amount, right? If they say dose is less than or equal to 5 milligrams per day, then you can actually continue warfarin. You don't need to switch to low molecular weight heparin now. You will switch to low molecular weight heparin straight away at 36 weeks. Is point 1 clear to everyone? But if the dose is more than 5 milligram, then you will switch to low molecular weight heparin till 12 weeks. The new guidelines say if you are using heparin for prosthetic heart valves in pregnancy, add aspirin to it, right? So we will give low molecular weight heparin and aspirin till 12 weeks. After 12 weeks, we will switch over to warfarin, which means between 12 to 36 weeks, what are we going to give? Warfarin. Please remember, warfarin के साथ aspirin combine नहीं करना. Aspirin तब देना है when you are giving heparin for prosthetic heart valves. Okay. At 36 weeks, you have to again do a switch over to what? Again, low molecular weight heparin plus aspirin. Yes. Now, please remember, if low molecular weight heparin is used at 36 weeks, some guidelines say later on, and it can be a potential new question as well. They say because, low molecular weight heparin is has a longer half-life, switch over to unfractionated heparin typically at 38 weeks. Or if you don't want to do a switch over, you can simply stop low molecular weight heparin 24 hours before labor or cesarean section. Is this clear? So I'll say it again. So we said at 36, you are switching to low molecular weight heparin. So what do you do close to delivery? Close to delivery, we have two options. Okay. The first option is either you completely stop heparin or low molecular weight heparin 24 hours before labor, or you can switch over from low molecular weight heparin to unfractionated heparin at 38 weeks, so that the chances of PPH are less. Is that clear to everyone? When do you restart anticoagulants? You will restart anticoagulants 6 hours after vaginal delivery. What about cesarean section? So usually say if it is cesarean, then after 24 hours. Okay, so then after 24 hours. What are the other important points which especially NEET-PG tends to ask, even INICET tends to ask? Number 1, can we do induction of labor? Yes. So please remember, induction can be done. It is absolutely safe. Okay. What route of delivery is preferred? It is vaginal delivery. No. For DVT in pregnancy, no. No warfarin. I told you the only indication for warfarin in pregnancy is prosthetic heart valves. If it is DVT, you are going to give heparin. Okay. I made it very clear. I'm very conscious about the terms I use. Okay. Second, please avoid excess fluid overload. Avoid as well as repeated PV examinations. Do as less as possible. So avoid repeated PV exams. Okay. Then they will often ask you what analgesia or anesthesia can you give. Then it is going to be epidural. Okay. Can we reduce the second stage of labor? Absolutely yes. You should reduce the second stage of labor by doing a operative delivery. So it can be both forceps or vacuum, but if you have to pick one, we will go with forceps. If your patient is having PPH, which drug should be contraindicated? It should be methergin. right? So methergine has to be contraindicated. Where else is methergine contraindicated? It is also contraindicated in preeclampsia, in peripheral arterial disease like Raynaud's. Yes. So these are the other conditions. Rh negative pregnancy. So these are the other conditions where methergine is contraindicated, often asked in the exams. Also, a very potential MCQ this year for your exams is peripartum cardiomyopathy. Yes. So what should we know about it? Number one, the patient will develop heart failure, but this heart failure will either happen late in pregnancy, which means beyond 36 weeks. It can happen up to 5 months postpartum. So anywhere in this time period. When I say heart failure, how will you diagnose it? We will do an echocardiography. So if the ejection fraction is less than 45%, please remember there should be no underlying heart disease. It should not be a case of heart disease. NEET-PG can specially ask about risk factors here. So when it comes to peripartum cardiomyopathy, advanced age, multiparity, preeclampsia, obesity are typical risk factors. Can you tell me which hormone is linked to it? So here the answer will be prolactin. Don't answer it as estrogen or progesterone. It is prolactin. The symptoms are typically the symptoms of heart failure, right? So cough, edema, orthopnea, paroxysmal nocturnal dyspnea. Yes. Diagnosis, I have already told you, is on echocardiography. But yes, please remember this. Maybe you have done it in medicine. BNP levels are going to be raised. The chest x-ray can show you a cardiomegaly. It can show you pulmonary edema. Management is just like heart failure, right? But which drug can you add? You can add bromocriptine. So to the management, we can add bromocriptine because there is some role with prolactin. All right. Okay, please remember, the patient can have a high recurrence risk, especially if she has a reduced ejection fraction which does not come back to normal. If it is not coming back to normal after delivery, yes, then it remains on the lower side, then the risk of recurrence is very high. All right. So in that case, we often tell them not to have a second pregnancy. Okay. But if ejection fraction comes back to normal, then yes, they can think about a second pregnancy. Okay. Chalo. Next, we are going to talk about multi-fetal pregnancy. Okay, so next we are going to talk about multi-fetal pregnancy. All right. Cabergoline is typically when we talk about hyperprolactinemia. Here, generally we are using bromocriptine, but we will have to add what? Do you know what you have to add if you are giving bromocriptine? You will have to add anticoagulation with it. Okay, so you will have to add anticoagulation with it. Okay. Chalo, let's talk about multi-fetal pregnancy. So which is the most common type of twins? It is dizygotic twins. All right, just okay. Hanji. So let's look at multi-fetal pregnancy. So which is the most common type of twins? Batao. It is dizygotic, right? So whenever you say dizygotic, we mean dichorionic and diamniotic. Okay. Now please remember, it is only the dizygotic twins which have risk factors. Monozygotic twins do not have any risk factors. But in case INICET does ask you, which is the only risk factor for monozygotic twins, it is IVF. Okay, it is IVF. Now, I know you understand monozygotic twins matlab arises from one zygote. Why I have written this is because I want you to know that this means there is going to be one placenta, right? So it is going to be one placenta. So now let's look at, typically the timing of division, okay? And also let me bring to one placenta thing when I talk about chorion. Okay, so this is very important. Whenever we say division time, they will keep asking you repeatedly. So in the morula stage or up to 72 hours, it is dichorionic and diamniotic. please remember there is nothing like dichorionic and monoamniotic. Okay, if it is dichorionic, it is going to be diamniotic. Now, it is basically the chorion which tells you about placenta. So when you say dichorionic, it means 2 placentas. When you say monochorionic, it means 1 placenta. When you say 2 placenta, it means there are no vascular connections. Okay, there are no vascular connections. Now, if it is happening between 4 to 8 days or at the time of blastocyst, then it is going to be monochorionic and diamniotic. So now when we say monochorionic, now it means there is going to be 1 placenta, and it means there are going to be what? Vascular connections. Okay, so now we know there are going to be vascular connections. Between 9 to 12 days or at the time of implantation, it is going to be monochorionic, monoamniotic. Please remember, when we say monoamniotic, matlab no dividing membrane, right? So no doubt the placenta is one, but there is also no dividing membrane. Yes. Then if it is happening after 12 days or at the time of after the formation of embryonic disc, it will be conjoined twins, also called as Siamese twins. What is the most common complication of twin pregnancy? You have to answer it as preterm birth. For both monochorionic and dichorionic, this is the most common problem, preterm birth. And overall, complications are more in monochorionic, which is because of the vascular connections. Okay. Now, the most important one for your exams is twin-twin transfusion syndrome. So this is seen with monochorionic and diamniotic twins. Yes. What is going to happen? The donor twin is going to have oligohydramnios and anemia. What about the recipient? The recipient is going to have polyhydramnios and polycythemia. So poly के साथ poly होगा. But when I ask you about diagnostic criteria, it is not anemia and polycythemia. The diagnostic criteria are simultaneous presence of oligo and poly. ठीक है? Now, Quintero staging is important, especially for NEET-PG. You have to know the name, you have to know the staging. So stage 1 mein there is oligo and poly, and bladder is what? Visible. Yes. So stage 1 mein bladder is visible. Stage 2 mein bladder is not visible, but what is normal? Doppler is normal. What will happen in stage 3? Now there will be abnormal Doppler. Okay. What will happen in stage 4? Any one of the babies can develop hydrops. And what will happen in stage 5? Any baby can have fetal death. So hydrops is stage 4 while death is stage 5. What treatment can we do? We can do a laser ablation of the vascular anastomosis. If you remember from the class, can you tell me which type of vascular anastomosis? Artery, vein, what is it? So it is artery and vein, but I told you that's not the key word. Okay, what is the key word? It has to be deep artery connected to deep vein. So it has to be deep connections to cause this. Okay. Delivery, usually we can do it earlier as well. It depends on severity, but yes, we do not go beyond 34 weeks, and the mode of delivery will be cesarean. So if it is twin-twin transfusion, it has to be a cesarean section. Twin anemia, polycythemia. So here one baby will have anemia, the other will have polycythemia, but what is not there? No amniotic fluid discrepancy. That is the difference between TAPS and twin-twin transfusion. Twin reversed arterial perfusion. It is also called as acardiac twin, right? Now again, this is seen in monochorionic, okay? But what kind of anastomosis is this? Artery to artery. So this is artery-artery anastomosis, and there is a reversal of blood flow. Okay, so there are abnormal vessel collections which are artery. Now please remember, when I say acardiac twin, basically this twin lacks a heart. In fact, it will lack the upper body. So it's completely anomalous. The reason is this twin is only getting deoxygenated blood in a reversal of flow. It's not getting oxygenated blood. So it results in anomalies. It is also like a monster twin, right? It's feeding on the other baby. Treatment is again the same. You can do a laser coagulation of the vessels, okay? And we can also do a radio frequency ablation, but majority of times we are doing laser coagulations, okay? Cord entanglement is seen in which kind of twins? Monoamniotic. It is a specific complication to monoamniotic. It is not seen in diamniotic, okay? Now, intrapartum, how do you decide the route of delivery, okay? So the route of delivery is based on the presentation, especially of the first twin. So we will do a vaginal delivery if the first twin is cephalic, right? If the first twin is non-cephalic, anything, then it will be a cesarean section. Now, a very, very probable question for your exams is indications for cesarean in a twin pregnancy. So what would be the indications? As I said, non-cephalic first twin, okay? Monoamniotic. Please remember, monoamniotic are always delivered by cesarean section and they are delivered by 34 weeks. So monoamniotic is always cesarean. Already I told you, if there is twin-twin transfusion syndrome, right? If there is trap, if there are conjoined twins, conjoined is a type of monoamniotic. So the moment I say monoamniotic, I also include conjoined twins, okay? Then, if there is a discordant growth and severe IUGR, can you tell me what is the difference to say that it is discordant growth? A growth or weight difference of how much? 25%, right? So if there is a weight difference of 25%, and can you tell me who do we make the comparison with? The bigger twin or the lesser twin? So it is with the bigger twin, right? Our reference is with the bigger twin, okay? Please remember, sometimes your exams will specially ask you, what is twin interlocking? Twin interlocking will typically happen if the first twin is breech and the second twin is cephalic. So you are not going to do a vaginal delivery, because if you do a vaginal delivery, there will be interlocking and you'll have to do an emergency cesarean. So anytime if the first twin is non-cephalic, we will do a cesarean section. Okay? Good to go, everyone? All right. So are you ready for some images now? Let's look at some of the images that are left. So who is going to tell me what is this image? So this is what sacral agenesis looks like. Overt diabetes or gestational? Only and only overt, also called as pre-gestational. What is the next image? This is, yes, Mac-Roberts maneuver, right? This is Mac-Roberts, sudden flexion and abduction. Which nerve injury can you do at this time? Lateral cutaneous nerve of thigh, right, can be injured. Okay, so lateral cutaneous nerve of thigh. And as I said, if Mac-Roberts fails, we also along with it give suprapubic pressure, okay? Then this is important. T sign is a marker of what? Monochorionic twins. But is it MCMA or MCDA? ये बहुत basic mistake है. We are showing you an intertwin membrane. So if an intertwin membrane is present, it cannot be monoamniotic. It has to be diamniotic. Then lambda sign, is it seen in dichorionic? Yes, again, always diamniotic. There is a intertwin membrane and it is a thick membrane. Whenever there is a membrane, it is diamniotic. Okay? All right. What kind of twin pregnancy will you say is this placenta? Do you see a dividing membrane here? Yes, there is a dividing membrane, right? But is it thick or thin? It is a thin dividing membrane. So if there is a dividing membrane, it has to be diamniotic. And if it is thin, it will be monochorionic. Also because we can see the vascular connection. So I told you vascular connections are seen in which twins? Monochorionic. They are not seen in dichorionic. What about this image? This is a typical image of cord entanglement. Do you see a dividing membrane? No. So no dividing membrane, cord entanglement, it is monochorionic, monoamniotic. I told you there is nothing like DCMA. It does not exist. If it is DC, it has to be DA. It cannot be DCMA. There is nothing like DCMA. So this is MCMA. Okay. So good to go, everyone. Chalo. Let's look at the next topic, and that is, I'm sorry, that is going to be RH alloimmunization. Okay. So let's look at the most important key concepts. Number one, the mother is RH negative. Yes, the mother is RH negative. When will complications happen? If the baby is RH positive. If the baby is RH negative, there is no complication. The father also has to be RH positive. Yes, the father, if the father is RH negative, there is no problem again. Yes, then very, very important, there has to be a transfusion from the two sides. So adequate fetal RBCs must cross into the maternal circulation to produce sensitization. Okay. Now, when we talk about sensitization, how do you know if there is sensitization or not? It is going to be by ICT. So when you say ICT positive, it means she is sensitized, which means she is producing antibodies. When you say ICT is negative, it means she is not sensitized, which means she is not producing antibodies. Okay. Can you tell me, or who is going to tell me, what is the critical titer for antibodies? It should be more than or equal to 1:16, like 1:32, 1:64. Okay. Now, when should you give anti-D and when should you not give anti-D? So let's do this. So when we talk about giving anti-D, please remember anti-D will be given only and only if ICT and DCT are negative. We will never give it if either ICT is written as positive or DCT is written as positive. Okay. Then what is the best time to give anti-D? It is given when at 28 weeks. Okay. And it is given routinely to all pregnant women who are RH negative. So the best time is 28 weeks. Also remember, it should be given within 72 hours of what kind of a delivery? A delivery where the baby is RH positive and DCT is negative. I told you ICT and DCT have to be negative, right? Although we don't do DCT routinely. So what we do is baby blood group. Okay. Whenever there is any evidence of feto-maternal hemorrhage. Okay. Now, please remember, if the pregnancy is less than 12 weeks, then the dose required is less. The minimum dose can be 50 micrograms. The guidelines are different, so we can go up to 100, sometimes up to 150 as well. But the minimum requirement in the first trimester is 50. Beyond 12 weeks, we have to give a full dose of 300 micrograms, which is how many international units? It is 1500 international units. And remember, it is given as a IM injection. Yes. Now, this is a very potential MCQ. Remember, 300 micrograms will neutralize 15 ml of RBCs and 30 ml of fetal blood. Yes. So very, very important. I have put it down at one place because I don't want you to do any mistakes. Remember, we will not give anti-D if the mother is already sensitized. We will not give anti-D if the baby is negative. Why would you give it? We will not give anti-D to RH positive mothers. It's a very basic thing, but you tend to get confused with options. The father is RH negative, then there is no problem at all. Yes? And as per the new WHO guidelines, if there is an early pregnancy loss, which means up to 12 weeks, there is no need to give anti-D because the blood loss is very, very small. Okay. Beyond 30 ml, we will have to calculate the dose. Can you tell me what test will I do to calculate the dose? We will have to do a KB test, Kleihor-Betke test, right? Which is a acid denaturation test, which is a lab test. So it will help you to know how much fetal blood is there so that you can calculate the dose. Now, coming to these case scenarios. So first case scenario, if ICT is positive but the titer is less, what do? We simply repeat ICT after 4 weeks. Okay, and we keep doing it. If ICT is more than 1:16, then the next step has to be MCA Doppler peak systolic velocity. Okay. Now, if the peak systolic velocity is less than 1.5, which is the cutoff, then I repeat MCA Doppler every 2 weeks. But if the MCA Doppler PSV is more than 1.5, then we have to look at period of gestation. Yes. If the POG is more than 34, then you consider delivery. Okay. Whereas if it is more than 1.5 but the POG is less, then you will simply follow up with chordocentesis. Okay. So remember these case scenarios, they are very often asked. So if ICT is positive, don't give anti-D, look at the titer. If titer is less, repeat ICT. If titer is more, do MCA Doppler. If Doppler value is less than 1.5, repeat MCA Doppler. If it is more than 1.5, look at POG. If more than 1.5 and POG is more than 34, deliver. If the value is more than 1.5 but POG is less, then you do chordocentesis, right? Now, in chordocentesis, you will get to know the hematocrit and hemoglobin values. So, if fetal hematocrit is less than 30, okay, and hemoglobin is less than 8, then this is an indication to start intrauterine transfusions, okay. So this is an indication to start intrauterine transfusion and is a very potential MCQ. I have told you we will do a KB test if we are suspecting a large feto-maternal hemorrhage, right, to calculate the dose of anti-D. Okay. Hydrops is the area where you are now getting more and more questions as well. So please remember, when we say hydrops, it will happen if hematocrit is less than 15 and hemoglobin is less than 5. This is immune hydrops. Okay. How do you make a diagnosis? So for diagnosis, we need ultrasound. Yes, we need collection of fluid in any 2 compartments. This could be ascites. Okay. It could be pleural effusion. It could be a pericardial effusion. It could be a generalized skin edema, right? If you typically see it on the scalp, what sign do we say? We say it is the halo sign or the Buddha sign. So this is not used for generalized edema. It is used for scalp edema in hydrops. Okay. What are the additional findings on ultrasound? Very important. They are not diagnostic criteria. They are additional findings. They are polyhydramnios. Okay. So additional findings are polyhydramnios. It could also be a big placenta, right? Placentogmegaly. Because it is heart failure, the baby can have hepatosplenomegaly. Yes. Now please remember, these days immune hydrops is less common. It is more of non-immune hydrops, right? So non-immune hydrops is more common now. This could be caused by cardiac anomalies. It could be caused by chromosomal anomalies. It could be caused by infections and even anemia. Quickly tell me 2 infections that I've always told you are the best answers for hydrops. The 2 infections are, yes, they are going to be parvovirus and syphilis. Yes. Please remember HIV, herpes, they are not going to cause high drops. Okay, they don't cause high drops. So it is parvovirus, syphilis, it could be other torch infections as well. But typically HIV, herpes, they are not going to cause high drops fetalis, right? So far we have covered significant things. We can take a lunch break. You guys are hungry, so we will take a lunch break now and we will restart the class after 30 minutes. Okay, so be sharp, be on time, rejoin after 30 minutes and we are going to start again, right? I hope you understand the value of what I've created for you. You make the most out of it. You revise it with me. You revise it by yourself. Obs and Gynae is sorted. Okay. So let's meet again after 35 minutes. Sharp time. Have a lunch. Come back. Okay. So Hanchi, all the pyara bachas, is everyone back? Ready to go? Okay. Chalo. So the next thing that we are going to talk about is going to be preterm labor, right? Now, preterm labor, there are no standard definitions or guidelines. Things are different from one place to the other. So I've tried to put things at one place for you. Now, when we talk about preterm labor, the more likely topic to be asked is how can we prevent it, right? So when we talk about prevention of preterm labor, the first thing is in whom are you going to do it? So this is going to be done in women who have history of either a cervical trauma, a cervical surgery, or previous history of preterm labor. Okay? Even if they have history of mid-trimester pregnancy loss. But when we have this history, what are we going to look for? We are going to look for cervical length. So they should have both the things. They should have some history like a history of preterm labor, history of abortion, or history of cervical trauma. And along with that, if they have a short cervix, then yes, we are going to put a prophylactic cerclage. As I mentioned previously, what do you do with the cerclage? You are also going to give progesterone with it, right? Then we look at how are we going to make a diagnosis of preterm labor. So when we talk about diagnosis of preterm labor, we are going to look for contractions and we're going to look for cervical dilatation, right? So if there are uterine contractions and the new guidelines are 6 contractions in 60 minutes, which mean even if the patient is having 1 contraction in every 10 minutes. Yes. And along with it, if we have changes. Now, what are the changes that we are going to look for? We are going to look for cervical dilatation or we are going to look for cervical length. Okay. Now, as I said previously, we used to say cervical dilatation which is more than or equal to 3 centimeters. Usse pehle cutoff was used was 2 centimeters. And now the UK guidelines say 5 centimeters. Okay? Then so it is obviously preterm labor and you have to begin the treatment. Okay? If cervical length is less than 20 mm, again, this is one of the cutoffs that we use. But again, the UK guidelines are different. They use a cutoff of 15 mm. So as I said, cutoffs are varying from one place to another. They're not standard at one place. Okay? Yes, this has been updated. It has been covered in your recent classes as well. Okay? So 20 mm is American guideline, 15 mm is what is the UK guideline. We don't have a Indian guideline. So unlikely they will ask you this, right? But what are we going to do if cervical length is somewhere in the middle? It is not short, but it is not normal as well. Then this is the place which AIMS people tend to ask. So this is where we will use FFN, fetal fibronectin. So please remember FFN can be used for what? Prediction of preterm labor, right? So it will be used for prediction of preterm labor. Now, which means whenever a patient comes to us and she is having uterine contractions, we should do a speculum exam to look for dilatation and effacement, okay? If the effacement or dilatation, we are not very sure of whether she is in obvious labor or not, then you should do a ultrasound. As I said, cutoffs are different. So initially it was 20 mm and now I said as per the recent UK guidelines, they are giving a cutoff of 15 mm, which is what I've written as well. So now the guidelines say if it is less than 15 mm, this is surely preterm labor, start treatment. And if it is less than 15 mm, Okay? Sorry, if it is more than 15 mm, then it is unlikely to be preterm labor. Whereas if it is short, then yes, you will consider the treatment for preterm labor. So as I said, the guidelines, some places say 20 mm and some places say 15 mm. So this is what is the latest based on the UK guidelines, which is what is 15 mm. Okay. But as I said, unlikely they would ask you these cutoffs. The idea is if the dilatation is there and effacement is there or shortening is there, then yes, this is preterm labor. Okay. FFN मैंने आपको बता दिया, FFN is used only when the length is borderline, right? So then we use it for prediction of preterm labor. Now, if you feel your patient is in preterm labor, what are you going to do? You are going to, number one, think whether she needs MagSulf or not. So who is going to tell me how will we decide? On the POG. If the POG is less than 32, then she needs MagSulf. यहाँ पे MagSulf किसके लिए दे रहे हो बताओ? Neuroprotection. Yes, here we are giving MagSulf for neuroprotection. Then please remember, we will also give steroids for lung maturation. And now the upper limit for steroid cover has increased. So it has gone up to 36 plus 6. 34 tak to everybody gives. Now the guidelines say in preterm labor, there could be benefit of going up to 36 plus 6, both American as well as UK guidelines. Okay. No, if transvaginal ultrasound pe cervical length is short, then you don't need FFN. I said we need FFN when the cervical length is borderline. Okay, then you need FFN. All right. Tocolytics, very, very important. When do you add tocolytics? You will add tocolytics only if pregnancy is less than 34 weeks. Okay. And what are the various drugs? So we could use nifedipine. Please remember, nifedipine is the drug of choice. But yes, as I mentioned, MagSulf is also a tocolytic. Beta agonist, although less commonly used. Indomethacin, very important. Can you tell me why is indomethacin used only when it is less than 32 weeks? Because it can cause what? Premature closure of ductus arteriosus. Okay. Please do not share any unnecessary things in the chat box. You are distracting people. So let's focus and make the best use of what we are doing here. Okay. Also, please remember, as far as steroids are concerned, Indian guidelines are dexamethasone. So who is going to give me the dose? So it is going to be 6 milligrams, 4 doses. They are given 12 hours apart and it is given as an intramuscular injection. Yes, perfect. Very good. More likely, which NEET-PG tends to ask and confuse you is with where you should not be giving tocolytics. So where are tocolytics contraindicated? So remember, any MCQ which says the patient has severe preeclampsia, then it is better to deliver the patient, right? Second, any condition where there is fetal distress or significant maternal bleeding, then again it is better to deliver the patient, right? Any evidence of chorioamnionitis, never give steroids, never give tocolysis, okay? Tocolysis, as I said, is only given if POG is less than 34. So if the MCQ says more than 34, we don't give tocolytics, all right? Fetal distress, I've already mentioned. Obviously, if the baby is dead, there is no point in continuing the pregnancy, right? So we are not going to give tocolysis for a dead baby. Whenever there are gross anomalies, then it's better that she delivers, all right? Yes, as I said, significant bleeding, right? Abruption, anyways, the management itself is termination or delivery. So we are not going to give tocolysis, all right? Okay, then we are going to talk about PROM, right? So premature rupture of membranes. What would be the word used in the paper? So they will say there is a sudden gush of fluid, right? And if we ask you what do you do next or how do you confirm the diagnosis, okay? Then we will do a speculum exam. So if you see pooling of fluid in the posterior fornix or in the vagina, then we know that it is PROM, okay? Second test that you should know is nitrazine test. We are testing the pH. So if the nitrazine paper turns blue, okay, then it means yes, there is leakage of amniotic fluid. What is the concept? That vagina is acidic, whereas amniotic fluid is alkaline. Hai na? What is the pH? 7.1 to 7.3. So it will turn the color of the nitrazine paper. Then if we see ferning, so if we take vaginal secretions, make a slide, and if you see ferning on drying, then this means there is amniotic fluid, because in pregnancy there should be no ferning of the secretions. If you are seeing it, it means there is amniotic fluid. Then yes, definitely we can use ultrasound. If there is significant leakage of fluid, which means there is going to be oligohydramnios. Yes, there is the finding is going to be oligohydramnios. Then they all tell you that yes, there is leakage or rupture of membranes. There are certain bedside tests like actimprom, but they are very expensive, so they are not very commonly used. Management of prom is very simple. If your patient is beyond 37 weeks, okay, so if she is beyond 37 weeks, we are going to give antibiotics and induce labor. We don't want to wait any further. But if she is less than 37 weeks, then yes, we want to wait. So we can give antibiotics, we will give steroid cover. That is what we are going to do along with monitoring, right? And in case there are contractions, can I add tocolytics? Yes, but again, tocolytics will be added only if the POG is less than 34. Beyond 34, we won't add tocolytics. Okay, bachas? Is that clear to everyone? Now, what would be the complications of PROM? So, one of the most important complications of PROM, we all know, is cord prolapse, right? So, it is going to be cord prolapse. So, now, we all understand that cord prolapse is an emergency. The reason is the cord is getting compressed, yes, and therefore it will present as severe distress. The second reason for distress is vasospasm, yes. Now, when should you suspect cord prolapse? Number one, whenever we talk about distress with rupture of membranes, right? So, if there is rupture of membranes and then after that immediately we feel that there is distress, then yes, it is a cord prolapse. Okay, it will typically happen when the fetal parts are not tightly applied, so a high station, right? And then if there is a cord membranes rupture, then there will be cord prolapse. Can you tell me which malpresentation has highest association? The highest is with transverse lie, and it is also significantly high with footling breach, but the highest is with transverse lie. Okay. Now, what is the first thing that you are going to do? The first thing is switch off oxytocin, because if the uterus is going to contract, it will cause more hypoxia. Then, what are you going to do? You have to prevent the cord compression. So, you're going to insert a hand in the vagina and you will push up the presenting part. If you don't want to do it manually, then yes, we can put her in certain specific positions which will prevent the compression. Yes, what is it going to do? Those positions can be knee chest positions, Trendelenburg position, as well as exaggerated sim positions. All these are going to prevent compression. What is the third way of preventing compression? The third way of preventing compression is retrograde filling of the bladder. So when you do that, the presenting part is pushed up. Okay. So the best, which is the best out of these? Manually elevating the presenting part is best. Okay. If you can't do it manually, then yes, we can put her in these positions. Okay. The second best is actually pushing it up with, bladder filling. The order in which I have written is the preferred orders. Okay. So best is manually pushing up. If you don't know how to do it, then yes, we can put her in these positions. Okay. Please remember, only if the cord is lying outside a vagina, you are going to gently replace it inside vagina, not inside the uterus. Okay, so very gently, and you can cover it with a wet gauze so that it doesn't get dried up, right? Then please remember, if there are uterine contractions, we are going to give tocolytics, because if the uterus contracts, I told you, it is going to cause distress. And the treatment of choice is an emergency cesarean. So basically you prevent compression, you prevent spasm, and you take her up for a cesarean section. Okay. Now, listen to these important things. If the question specially says cervix is fully dilated, or they are specially writing cervix is dilated, head is on the perineum, then what are you going to do? Only then you will think of doing a instrumental delivery. Okay. Otherwise, the mode of delivery is what? Cesarean. Okay. And sometimes they will tell you that the baby is already dead. They will say fetal heart rate is absent. Then again, the answer will change to vaginal delivery. So answer will change to vaginal delivery in very limited conditions, when either the cervix is dilated, head is very low down, or the baby is already dead. Okay, are you good with all of this? Okay. What about cord presentation, bache? So please remember, cord presentation may, the membranes have not yet ruptured. So what will you feel? You will feel a bag of worms. So if it is cord presentation and the woman is in labor, what are you going to do? It is still going to be a cesarean. Okay. It is still going to be a cesarean section. The second complication of PROM is chorioamnionitis, right? Which is basically an intrauterine infection. So how will you know? So your patient will be a case of PROM, but along with that, now you will see fever. So any time with PROM, they are writing about fever, they are writing about uterine tenderness, they are talking about fetal tachycardia. Then think of chorioamnionitis. Yes, please remember, definitely yes, the WBC count of the mother will be raised, but remember, up to 15,000 was physiological, so this has to be more than 15,000. Yes. What are you going to do? Always start the woman on broad spectrum antibiotics, and you have to deliver her, but not with cesarean. You have to deliver her vaginally. So if she is not in labor, you will induce labor. If she is in labor, then you will augment labor with oxytocin. Is that clear to everyone? Please remember, don't write the answer as cesarean section. Usme the risk of endometritis is very high. So cesarean section is only reserved for obstetric indications, like a contracted pelvis, like a placenta previa. Okay, is that clear to everyone? Good to go. Are you with me, everyone? Quickly. All right. So then let's move on to IUGR. Now IUGR, how do we make a diagnosis? So first you have to know how you clinically get to know it. So we measure the fundal height. Hai na? If the fundal height is lagging behind the gestational age, then we say it is IUGR. How much? More than or equal to 3 centimeter lag will be considered as suggestive of IUGR. It's not diagnostic, right? So this is what will make me think that there is IUGR. What do I do next? I have to do a ultrasound. What am I going to look for? Abdominal circumference or estimated fetal weight. What are the cutoffs? The cutoffs are estimated weight less than the 10th percentile or abdominal circumference less than the 10th percentile. Among all parameters, I've told you, which is the single best parameter for fetal growth? It is abdominal circumference, right? Now, we can also use Doppler studies to help us make a diagnosis of IUGR. What Doppler? We will use umbilical artery Doppler. And what do we measure in the Doppler? PI. Those who have attended my classes have covered all these recent guidelines with you, right? So PI is pulsatility index. So what will happen? The pulsatility index will increase. So how much is the cutoff? 95th percentile. So if the PI is increased, then yes, it is suggestive of increased resistance. And any IUGR which happens, before 34 weeks, or, we call it as early onset IUGR. Okay. So remember, in fact, 32. For preeclampsia, we use the cutoff as 34 weeks. For IUGR, we say before 32 weeks. GA is gestational age, bache. Okay. Now, as I said, the initial finding will be what? A increased PI. What would be the later findings? The more severe findings would be absent or reversal of end diastolic flow. They are seen in the later stages in umbilical artery Doppler. Okay. What would be the finding in the middle cerebral artery Doppler? So in the MCA Doppler, please remember we see a brain sparing effect. So what is going to happen? The baby is sending more blood there. So there will be increased diastolic flow, which is, opposite of what is happening in umbilical Doppler. In umbilical artery Doppler, the diastolic flow is reducing. But what is happening in middle cerebral artery Doppler? Yes, the diastolic flow is increasing. It is a brain sparing effect. Okay. If we ask you which is the last vessel to show you reversal, what is the answer? Let me see if you remember from the class. Last vessel to show you the reversal is ductus venosus, right? So this will show reversal when the baby is about to die. So this indicates impending death. So the last vessel is ductus venosus. Perfect. Yes, ductus venosus, umbilical vein. So venous Dopplers. All right. Yes. So eventually ductus venosus, we all know, is connected to what? It is connected to the umbilical vein. So basically venous Doppler mein agar reversal aa gaya, then it indicates impending death. Yes. Okay, what is the other thing we measure in IUGR? So in IUGR, we are measuring the biometry parameters, we are doing Doppler, but we will very importantly also look for amniotic fluid. What is the finding? Oligohydramnios. Who is going to tell me why is there oligo? Because in IUGR, there is uteroplacental insufficiency, right? And as a result of which the renal blood flow decreases, right? And if the renal blood flow decreases, the urine output will decrease. You don't have to remember what is A wave. You just remember the most specific thing that we look for is actually the A wave. There is no need to go into the details of the waveforms. The typical wave that we look for in the venous Doppler is A wave. Okay, so just remember the name and that is good enough. All right. What are we going to do? So what is the management is dependent on SD ratios and pulsatility index. All right. So let's look at this. Suppose the Doppler is absolutely normal. What do? Then you will do weekly Doppler and a weekly biophysical profile. And you will do a growth scan every 2 to 4 weeks. Okay? And you will deliver her not before 37 weeks. There is no need. We can easily go up to 39 weeks as well if the Doppler is normal. Okay? So single best answer? Yes, 39. Sometimes you might have to deliver her at 37 weeks. If there is increased PI, which means Doppler is abnormal. Yes? Which means increased matlab the cutoff we use is more than 95th percentile. But as of now, the diastolic flow is present. What is EDF? End diastolic flow. Right? So it's not absent. There is end diastolic flow. Yes? Then what do? You increase the frequency of monitoring. So now you will do a twice weekly Doppler. You will do it 2 times in 1 week. And what have I told you? If you remember, I've told you at one time you will combine Doppler with NST, and in the second visit you will combine Doppler with biophysical profile, right? So there will be 2 visits in 1 week. In one visit we will do Doppler and NST. In the other visit we will do Doppler and biophysical profile. Okay. When do you deliver? You deliver at 37 weeks. Okay. Now, only and only if there are more complications. For example, the patient also has preeclampsia, she also has severe oligo, then I might consider delivery after 34 weeks itself. But the general answer for increased PI is 37 weeks. What do you do if there is absent end diastolic flow? Absent may you have to do a daily monitoring. So now we are doing a more frequent monitoring. Yes, you will have to do a daily NST, a daily biophysical profile, and you will deliver at 34 weeks. Be very careful. If they say there is evidence of fetal distress, then you will have to deliver immediately. For example, What are they going to tell you? They will say, you are seeing late decelerations. Then this is an indication to deliver her earlier. Don't wait for 34 weeks. Okay. In AEDF, we can do a trial of vaginal delivery. It's not contraindicated. Okay. So vaginal delivery is not contraindicated. But yes, what we prefer is a cesarean. So vaginal delivery is not contraindicated. Okay. It can be considered, but you will have to do a very intensive monitoring. When it is REDF, when do you do the termination? We do not go beyond 32 weeks. Our upper limit now is 32. And here, yes, definitely we want to do a cesarean section. Yes. Again, we might have to do early delivery if they talk about what? If they talk about presence of distress. Tab mat bolna that madam has said we will wait up till 32. If they say late decelerations, if they say absent beat-to-beat variability, then it has to be termination irrespective of POG. Is that clear to everyone? Yes? Okay. Now, whenever you talk about high-risk pregnancies, whether it is PROM, whether it is preterm labor, whether it is IUGR, preeclampsia, diabetes, we have to do fetal monitoring. Yes. So let's start talking about aspects of fetal monitoring. Okay. Chorioamnionitis is always delivery irrespective of POG. You cannot continue the pregnancy data. The bacha will die inside. Okay. Now, the first antepartum monitoring that we will talk about is amniotic fluid. So if we ask you what is the main source, it is fetal urine. But who is going to tell me precisely when does urine become the main source? It becomes the main source beyond 20 weeks. What is the main source in the first trimester? In the first trimester, if you remember, it is ultrafiltrate of maternal plasma. Yes, do you all remember this? Okay. Please remember 98 to 99% of it is water. So there is no nutritive function. Okay. pH, I have already told you, it's important to know it is between 7.1 to 7.3. All right. When do you see maximum amniotic fluid? So maximum amniotic fluid is 1000 ml approximately at 32 to 34 weeks. What is the value at term? So if they ask you at term, it is answered as 800 ml. What about post term? Post term क्या होता है? Beyond or equal to 42. वहाँ पे कितना होता है? 200 ml. Okay. Perfect. Color is important. It tells us a few things. For example, if we are seeing a pale yellow, it's clear, but the color has changed to pale yellow. It means normal. But when do you see this normal? You see this at term. So at term, it can become clear to pale yellow. Yes, sometimes it can become a little turbid as well. All right. If you see it as green, we know it's meconium. What do you mean if it is blood tinged? Altered dark, it means abruption. Yes, golden yellow, RH incompatibility because of bilirubin, right? Dark brown, which is called as what? Tobacco appearance, right? So then we will say it is intrauterine death, right? So these are different color changes that you should know as far as exams are concerned. Okay. Now, what are the ways of measuring it? One is single deep pocket, also called as deep vertical pocket. The other is called as amniotic fluid index. You should know the cutoffs for oligo, so and poly, right? So in single deep pocket, it is less than 2 centimeters, and for poly, it is more than or equal to 8. For AFI, it is 5 to 24, which is considered as normal. Oligo kisko कहते हैं? Less than or equal to 5. Poly is more than or equal to 25. Some people also take it as 24. It doesn't matter. Okay. It really won't affect. But you should know, yes, 5 to 24 is definitely within the normal range. Now, suppose they give you a question that your patient has oligohydramnios. What should you look for? So, look out for number 1, ruptured membranes. So, always do a per speculum examination. Yes, so look out for ruptured membranes as the first thing when you come across a case of oligo. Then you should look for very importantly anomalies in the baby. Which anomalies? Renal. For example, renal agenesis, dysplastic kidneys, posterior urethral valve. Right? I hope you remember Potter syndrome. What was the triad? There is severe oligo, there is pulmonary hypoplasia, and there are characteristic facial features. Yes. So in Potter's, there is also associated pulmonary hypoplasia. Right? Okay. If they ask you, your patient develops oligohydramnios in the third trimester, what should you think of? So definitely first think of ruptured membranes, as I said, but in the third trimester, look for uteroplacental insufficiency, which means you should do a Doppler. Yes. The other causes of, oligo in the third trimester are postterm pregnancy as well as a dead baby, right? Conditions which are associated with uteroplacental insufficiency like preeclampsia would also cause oligo, right? Medications, it is important. So ACE inhibitors हम पहले ही कर चुके हैं. We don't give it because they affect the development of the kidney. Apart from that, remember, indomethacin was a tocolytic. If you give it for a long time, it will cause oligo. So can you tell me where can I use indomethacin? We can use it in the treatment of polyhydramnios, right? But what did we tell you about indomethacin? Only use it at less than 32 weeks. Yes? Okay, as I mentioned, always think of ruptured membranes when it comes to oligo, right? If the patient has poly, then again think of structural anomalies, but now typically with structural anomalies, neural tube defects and GIT, which means wherever there is reduced swallowing. Apart from this, diabetes we've just covered is a very important cause of poly. Fetal high cardiac output, like what conditions? Like, yes, RH negative pregnancy, like twin transfusion syndromes, right? So these conditions, wherever the cardiac output is high, parvovirus, in all these conditions, there can be polyhydramnios. So parvovirus, twin transfusion, then fetal Bartter syndrome, where there is polyuria, right? Chromosomal anomalies can also be the reason. Now, the second test for fetal monitoring that we should know is non-stress test. Yes, so we should know about non-stress test. So now please remember, NST evaluates what? It evaluates basically the functioning of the autonomic nervous system. So the accelerations that you see here are because of autonomic nervous system. So it sees whether this nervous system is intact or not. Now remember, we call it as a reactive NST if my patient shows 2 accelerations in 20 minutes. Yes. What exactly is an acceleration? The heart rate should increase by more than 15 beats per minute. It should last for more than 15 seconds. We typically use this for pregnancies which are beyond 32. At less than 32 weeks, we use the definition as 10 beats per minute lasting for 10 seconds. Okay. So then we say it is acceleration. What is normal beat to beat variability? It is 5 to 25 beats per minute. Okay. Now, if all this is there, which means NST is reactive. Now, I want to know from you, when you say NST is reactive, is it a positive NST or a negative NST? I've taught you the concepts in class very clearly. Positive or negative? It is a negative NST because it rules out hypoxia. Okay, it is a negative NST. Very good. Okay, so this is reassuring, right? Because it rules out hypoxia. Now, based on this concept, this is what you need to know. A non-reactive NST is which one? It is the one which will not show you accelerations. But what should be the time frame now? We have to do the NST for at least 40 minutes. The non-reactive NST is what is called as positive NST. So INICET will ask you things in depth and whys. That's what we've done in regular class, stressed on whys and concepts. Yes. So remember, NST has a high false positive rate and a low false negative rate. Yes. This is why whenever it is a negative, it is a positive NST or a non-reactive NST, what should you do? You should perform a biophysical profile, right? Yes, so you should do a biophysical profile. Now, biophysical profile, I hope you know, is done by using an ultrasound, and we will do this biophysical profile on ultrasound for a span of 30 minutes. NST was done for 20 minutes. Yes. Very important PYQ. Yes. What is a modified BPP? It has only two components, NST and amniotic fluid. Whereas a full biophysical profile, also called as what, beta ji? Manning score. So a full biophysical profile will have 5 components. Yes. There is NST, there is fetal breathing, there is movement. This is again movement on ultrasound, not the maternal perception. Okay. So this is not DFMR. Okay. Fetal tone and amniotic fluid. Yes. So as we have mentioned the components, now coming to the thing that each component can be given a score of either 0 or +2. So if the total score is 8 or 10, it means there is no asphyxia. It is normal. Okay. If it is 6, it is equivocal, right? So it has to be repeated in 24 hours. If it is 4 or less, this means there is high risk of asphyxia and you need to do an immediate delivery. Please remember, if there is hypoxia, what is the first thing to become abnormal? The first thing to become abnormal is NST. The NST will become non-reactive. There will be no accelerations. Further hypoxia, it will be breathing. More hypoxia, movements will go. So this is the order that will follow. Remember, the relationship between BPP, what does it basically tell you? It tells you about pH, right? So this relationship is very well established and it is established across all gestational age, right? Which means once you say the BPP is less than 4, there is a strong correlation that the pH will be less than 7.2. And if it is 2 or less, it means there is 100% acidosis, right? So this value of 4 or less is actually very, very predictive and it has a strong association with fetal pH. Is that clear to everybody? Then yet another method of fetal monitoring is going to be Dopplers. We just saw this. So remember, when we talk about Doppler, I told you what all do we measure? We measure the SD ratios, we measure the pulsatility index and the resistive index. Now I want to ask you, what happens to SD ratio as POG increases? Okay, tell me. This is not pH of the fluid, this is pH of the baby. Okay, fetal pH, acidosis in the bacha. All right. Yes. So please remember, as POG increases, what happens to SD ratio? The SD ratio should decrease, which means a high SD ratio is indicative of what? It is indicative of uteroplacental insufficiency. Similarly, what will happen to PI and RI? Increase. So if pulsatility is increasing, it is a marker of uteroplacental insufficiency. I just told you what cutoff we use. We use a cutoff of 95th percentile, right? So let's look at this. Sometimes, yes, they could go into these details. For example, I have told you normally the SD ratio should decrease. So it should be less than 3 beyond 28 weeks. If the value is more than or equal to 3, it is a marker of UPI. So as I said, If there is an increase, there is going to be placental insufficiency and there is going to be IUGR. Whereas, do you know what will happen in anemia? It will be the reverse. In anemia, these ratios are going to decrease, right? So far, your exams have asked you about where or what is the significance if these ratios increase. Remember, they could ask you about significance of decrease. So that would be seen in anemias or hypervolemia. Okay. Similarly, what happens to PI? I just told you pulsatility index should be less than 95th percentile. That is normal. If it increases, I told you it is a marker of resistance, right? AEDF, REDF, we have already covered. These are markers of severe placental insufficiency and they can cause fetal distress. Okay. So please remember, when we talk about MCA Doppler, will it show changes early or will it show changes late? So as I mentioned previously, MCA Doppler will not show the changes early. It will show the changes late, right? Because there is a brain sparing effect. So once you do umbilical artery Doppler, you can do a further monitoring with MCA as well as with biophysical profile. Okay? On the other hand, if we ask you what is the best use of MCA Doppler, will you answer it as IUGR? No. The best use of MCA Doppler is to diagnose fetal anemia. Okay, what are we going to study? The same things. Resistive index we don't use for diagnosis. For diagnosis we use pulsatility, but the concepts will remain the same. Resistive index will increase if there is uteroplacental insufficiency. Okay. Yes, so what we measure is peak systolic velocity. Cutoff, I have already told you, is 1.5 MOM. So if it is more, we know there is significant anemia. Where do we specially use it? We use it in Rh negative, but we can also use in parvovirus. Can you tell me why? Parvovirus causes aplastic anemia in the fetus. And that is how it can also cause what? Hydrops fetalis. Yes? Okay. Yes, MCA Doppler can be used in IUGR, but it is not the best Doppler, right? The best there will be umbilical artery. So we can use it in IUGR. In early phases, I told you it will show a brain sparing effect. The flow will increase, right? Later the flow will decrease, all right? So please remember, if you are seeing a PI value or a reversal, then please remember it is already severe hypoxia. Only then you will see changes in the MCA Doppler. So that is why initially we measure umbilical artery and then we can keep monitoring the MCA Doppler. Another use is twin-twin transfusion. I told you one baby develops anemia, the other develops polycythemia. So cutoff for anemia we all know is more than 1.5. What is the cutoff of polycythemia? Less than 0.8. Yes? Chalo. Uterine artery Doppler, something that the INICET people are fond of asking. Uterine artery Doppler, if it is increased, matlab there is a high PI, high RI, or there is notching. This all means poor placental perfusion. So therefore, we use it in making a diagnosis of early onset preeclampsia. I have told you what is early onset. Women who develop preeclampsia before 34 weeks, right? And to make or to predict early onset preeclampsia, we can use uterine artery Doppler at 11 to 14 weeks. So this will predict early onset preeclampsia. Whereas if you do a uterine artery Doppler a little later, yes, so which means in the second trimester, somewhere between 20 to 24 weeks, then it is going to pick up late onset preeclampsia. This will not pick up early onset preeclampsia, right? Everyone with me on this? Okay, thank you for reminding me. Yes, I will drink water. Are you all good? Chalo. Time for some corresponding images that we need to cover. So whenever we talk about labor, we have already talked about preterm labor. We will talk more about labor, but what do we use Bishop scoring system for? Can you tell me? This is typically used for induction of labor. Yes, so this is typically used for induction of labor. So it is a pre-induction score. There are 5 parameters. Jaldi se mujhe batao, which is the most important parameter? Dilatation. And which is the least important? Position. And the total score I've told you is out of 13. Yes, anything which is less than or 6. Yes, so if the value is less than 6, what are we going to do? So if the value is less than 6, then it means the patient needs priming, or we say ripening. So we can say less than 6, or we can say less than or equal to 5. It means the same thing, right? And if we typically ask you what's favorable, then the best answer for favorable is more than or equal to 9, right? So anything more than 9 is definitely favorable, right? But anything less than 5 is considered as unfavorable and it needs ripening. Okay? Now, usually I've told you NEET-PG will not ask you the calculations, but INICET does, right? So if INICET does, do you remember how I've told you to remember? I have asked you to remember the column for which we are giving a marks of 1 because it is all mid or a value of 2. For example, look at this. Effacement कितना है? 50%. Position क्या है? Mid position. Consistency कैसा है? Medium. And the other 2 values are 2. Right? So if the dilatation is 1 to 2 centimeters or the station is -2, all these parameters will be given a value of 1 and then the calculation becomes easier. What is modified Bishops? So remember, in modified Bishops, you are replacing what? Effacement is replaced by cervical length. Right? So effacement will be replaced by length. Okay, what is this? This is a CTG machine or a NST machine. How do you decide whether it is CTG or NST? For example, let's look at image A. Is it a CTG or an NST? It is CTG because there are uterine contractions as well as FHR. So there are these two. So this is what is a CTG. NST is when you only have fetal heart rate. There are no contractions, right? But can you tell me, I have taught you this in the class. Suppose I have shown you the NST like this, and in the bottom, I have shown you some bars like this. What is this? This is still NST. Yes, so this is still NST. What are these bars? These bars are fetal movements. So please remember, NST also records fetal movements along with fetal heart rate, but there will be no contractions. Yes. So now look at figure A and tell me what graph is it? So this is a graph of early decelerations. Why? What do you look for? So the deceleration is coinciding with the contraction. So whenever it coincides with the contraction, it is early. Also, it is a slow fall and a slow pickup, right? So it coincides and it is gradual. Quickly batao reason for early deceleration. So the cause of early deceleration is head compression. Perfect. Very nice. Now tell me, what is the graph D? What is this graph? This is late deceleration. Why? The contraction has stopped here, but the deceleration is persisting, right? So deceleration is persisting after the contraction. So then it is late. Also, is it gradual? Yes, it is a slow fall and a slow pickup. It is gradual. Also look at the middle part. Do you see this middle part? What did I tell you to look for in the middle part? The oscillations. In the middle part, are the oscillations less or more? They are less. So which means the beat to beat variability is less, which means this is distress. So this is a late deceleration. And what is the cause of this kind of a deceleration? The reason for late deceleration is, yes, uteroplacental insufficiency. Very good. Let's look at graph C. So here there is a no consistent relationship with the contractions. Yes, so there is no consistent relationship, and that is why it is a variable deceleration. Yes, so there is no consistent relationship with the contractions. What else should you know about variable? In variable, it is a quick fall and a quick pickup. It's not gradual. Yes, so it is a rapid fall and a rapid pickup, right? And also look at this middle segment. Is the beat to beat variability normal? Yes. So here the B2B is normal. So is this fetal distress? No, this is not distress. This is just cord compression. But as of now, it is not causing fetal distress, right? So please remember, the most common type of deceleration in labor is variable deceleration. Okay. I am sure in your real exams, you're going to identify these graphs. So graph 1 is what is a normal umbilical artery Doppler, right? So these are graphs of umbilical artery Doppler. Can you tell me what is graph 2 here? Yes, graph 2 is AEDF. So there is flow in systole but no flow in diastole. Yes, what is graph 3? Very characteristic, REDF. I've already taught you the management, है ना? So REDF, because you are seeing reversal of flow here under the line, right? So this is what is REDF. So you should be able to identify them, and you should be able to tell the management as well. Okay. All right. So let's go back now, and we will start with labor, and definitely the first, second and the third stage all together, right? So let's start with some basics, and I'm sure you would all know that. So cardinal movements of labor are repeatedly coming in the exam. So I've just made a mnemonic already, although I hate mnemonics, but still yes. So don't forget, I enjoy really expensive eggs. So what is the D here? The first thing is descent. But what happens even before descent? Engagement, right? So the first thing before descent is actually engagement. Okay. So then there is flexion. All right. I stands for internal rotation. Okay. Internal rotation, which will happen at the level of the ischial spines. The delivery of head is by extension. Yes. So delivery of head is by extension. Then there is going to be external rotation. But what is the first part of external rotation called as? Restitution. So if you have to put in order, it will be internal rotation, then there is going to be extension, then restitution, and then external rotation. Where would you put crowning? I've told you. Crowning will come in between internal rotation and extension. That's where crowning comes. Okay? Please remember, restitution actually is not a cardinal movement, but usually your exams ask you to place them in the correct order. What happens is in restitution is untwisting, or we say removal of torsion, right? So there is an untwisting of the head or removal of torsion. Okay? The last movement we all understand is expulsion. Okay. Now, if at all you have to give an episiotomy, where do you give it? So, if at all we have to give episiotomy, it is given at the time of crowning. That is the significance of crowning. Yes. So, crowning is when the biparietal diameter is stretching the vulval outlet and it does not recede back. Yes. So BPD is stretching the vulval outlet and does not recede. That's what is crowning. So the perineum is stretched and this is the time you can give a episiotomy. Okay? Now, your exams are sometimes asking you very basic. So let's look at this. So stage 1 kab shuru hota hai? Who's going to tell me? It's already written there, right? So stage 1 will begin with the onset of regular contractions and it will end with complete dilatation, which is how much? 10 centimeters. Okay? Stage 1 of labor is divided into a latent phase and a active phase. How do you decide it's latent or active? Cervical dilatation. So please remember, now we are following the WHO labor care guide, right? So we say active stage will begin with a dilatation of 5 centimeters. Okay, so this is what is there in the WHO labor care guide, which is what we are supposed to follow now. Okay. Latent phase of labor. What is the upper limit of normal? So in primigravida, the upper limit is 20 hours, whereas in a multigravida, the upper limit is 14 hours. Please remember, even if there is a prolonged latent stage, will you do a cesarean section? The answer is no. So do not answer cesarean section in the latent phase. Okay. When do you know stage 2 begins? So stage 2 of labor will begin with complete cervical dilatation. So now there is no dilatation. It is going to be descent of head. So it ends with the delivery of the baby. Okay. Now, what is the upper limit? So upper limit for stage 2 in a primigravida is 3 hours and in a multigravida it is 2 hours. Remember, INICET people can ask you with epidural. So with epidural, you have to add 1 hour. So it will become 4 hours in primi and 3 hours in multi. What is stage 3, beta ji? Stage 3 is the stage of expulsion of the placenta. Yes. So please remember, how will you know that there is separation of placenta? So this stage is going to last for approximately 30 minutes, right? What will you see? You will see a gush of blood. You will see that the uterus will become globular and there will be a suprapubic bulge. There will be lengthening of the cord, right? So please remember, as I said, the duration can be 30 minutes. All right. Average nahi hai ye. What is the average duration? Average duration of third stage is 15 to 20 minutes. 30 is the upper limit. Okay? Yes. Out of these, what is the best sign? So out of all these signs, the best sign of separation is lengthening of the umbilical cord. Okay? Now, once we know this, you have to know that there is a stage 4 as well, which is a 2-hour period of observation. Okay? What do you understand by the term labor dystocia? So whenever the labor is slow, okay, difficult labor or a slow labor, we call it as dystocia. So dystocia is a fancy term for slow or abnormal labor. INICET again is very fond of asking what would be the cause. So the cause could be fetal, it could be maternal. Okay? Fetal causes are very simple to understand. For example, if there is a malpresentation, there is a malposition, right? There is a big baby, all right, which means there is CPD, or there are anomalies in the baby, or there are multiple babies inside, then all this will lead to prolonged labor. The maternal factors is where they tend to confuse you a little. The most important among maternal, definitely what you have to know is any time the pelvis of the woman is abnormal, right? So abnormal shapes of pelvis, nulliparity. Multiparity is not a risk factor. Please remember, obesity is a risk factor. Epidural analgesia is a risk factor. Okay. Then short stature, because that would mean, you know, that the pelvis could be small as well. Even advanced age of the mother is a risk factor, right? So all these are going to be risk factors for labor dystocia, all right? Now, how will we say that it is slow labor? So we need to know the upper limits. For example, when do you say prolonged latent phase? It's very simple. If it is lasting more than 20 hours in a primary and more than 14 in a multi, what is the first thing you will do for prolonged latent stage? Sabse pehle you have to ensure that the woman has been given adequate rest. So first we give adequate rest and analgesia. If she has already been given adequate rest and analgesia, then we will begin with oxytocin. Yes, we can also do a ARM, but it is not the preferred one. What is the preferred thing? Oxytocin, right? So once she has been given adequate rest and analgesia, we will do augmentation. Okay, is it clear to everybody? Give me a thumbs up. Then, how do you know it is a prolonged active phase? So, number one, we say it is slow progress if it is less than 1 centimeter per hour. Now, the problem here is you remember the normal values in primary and multi. What was the normal value for dilatation in primary? 1.2 centimeter per hour. What was the cutoff for multi? 1.5 centimeter per hour. So now you think that definition of slow labor would be less than this. No, this is the average time taken in a multi and a primary. But when they ask you slow labor, there is only one definition. Less than 1 centimeter per hour in the active phase. Have I made myself clear? Then the next set of MCQs will come on arrest of labor. So there can be arrest of active phase, there can be arrest of second stage. Let's look at this. If there is arrest of active phase, number one, dilatation kitna hona chahiye? More than 5 centimeters, because that's when the active phase starts. Yes. So dilatation has to be more than or equal to 5 centimeters. The membranes have to be ruptured, right? Then we will look at the criteria. Criteria is no change in cervical dilatation for 4 hours with adequate contractions. What is the cutoff for inadequate contractions? We should wait for at least 6 hours. What else have I taught you? I have taught you that you will wait for 4 hours or 6 hours only when the FHR is normal. If there is distress, we are not going to wait for 4 or 6 hours. Okay? Now, NEET-PG will specially ask you what is the reason for this arrest. So remember, the most common cause of arrest of active stage is cephalopelvic disproportion. And what is the management? It is that we should do a cesarean section. Chalo. Who is going to tell me how did I teach you that when you will read from the MCQ, how will you get to know that there is CPD? So when we talk about caput and molding together, and that to especially severe degrees. So when you see caput and molding together, it is a marker of cephalopelvic disproportion. Yes, perfect, very good. Now, coming to second stage arrest. What is the cutoff in nulliparous or primigravida? If there is no descent after at least 3 hours. So this I said is the cutoff without epidural. Very good. With epidural, it will be 4. Similarly, in multis, it is going to be 2 hours without epidural and 3 hours with epidural. Now, what are you going to do? Sabse pehli cheez. Look for whether the head is engaged or not. So, who is going to tell me what station corresponds to engaged head? It is station 0, right? Station 0 means the head is engaged. Okay. So look for head is engaged or not. Now, please remember, any time it is arrest and head is not engaged, which means it is above 0, then the management is always cesarean. Okay? So please remember, no, the cutoff is not 1 hour at all. Okay? So please remember, if the head is not engaged, yes, then the answer is always a cesarean section. If the head is engaged, what is the next thing you will look for? Then look for cephalopelvic disproportion. Okay. And I've told you, how do you know CPD? Caput and molding together. Now look at this. If there is no CPD and it is second stage arrest, what are you going to do? You are going to try either a forceps or a vacuum. Whereas if there is a second stage arrest and there is CPD, what are you going to do? Then again the answer will be cesarean. Is that clear? Obviously, if the head is not engaged, which means head is very high up, you cannot do anything else. The only management is cesarean. If it is engaged and she is in the second stage, then you have to see whether CPD is present or not. If it is CPD, then the answer is always cesarean. If there is no CPD, then I can do instrumental delivery. Now can you tell me how will you decide whether you do a forceps or a vacuum? So please remember, forceps will be preferred when station is more than or equal to +2. Okay. So forceps कब prefer करेंगे? When station is more than or equal to +2. Number 1. Number 2, it will be preferred when there is a caput but no molding. Why? Caput agar hai, which means the scalp is edematous, can you apply a vacuum? No. Right? So in this case, if I have to use a instrument, which is the preferred instrument, it is going to be forceps. समझ में आ गया सबको? Is it clear? All right. Above 0 is not engaged, beta. If it is above +2, I can still apply a vacuum. I cannot apply forceps, but I can still apply a vacuum provided it is engaged. So follow the steps. मैंने क्या लिखा है? Clearly I've written without any confusions. मैंने बोला, first see if she is in the second stage. If she is in the second stage, look at station. If the head is not engaged, which means it is above 0, then what does that mean? It means I cannot do anything else. I have to do a cesarean. If it is engaged, then you have to look for CPD. If there is CPD, then again the answer is cesarean. If there is no CPD, then I can use either forceps or a vacuum. Now, how do I decide between the two? Then you look at this. If the station is more than +2, then you can apply forceps. But if it is above +2, I will have to apply a vacuum. If there is caput but no molding, which means there is no CPD, now I cannot apply vacuum because there is a swelling. So now again I will apply what? Forceps. Is it clear now? Yes? So let's look at key things that you should be knowing about forceps, because these are very likely MCQs. So I'm trying to clear your concepts as well. Okay. Outlet forceps is what is most commonly used. When do you say it is outlet? When the head is on pelvic floor, right? Which means station is typically more than or equal to +3. That's what is pelvic floor. When do you say it is low forceps? If it is below +2, but it has not reached pelvic floor. The terminologies are outlet and low, but do you know we use the same instrument? Which instrument we use? We use the Wrigley's. I will show it to you as well. So please remember, Wrigley's is actually called as outlet forceps. But if you have attended my class, I have taught you outlet forceps uska naam hai, but do we also use it as low forceps? Yes, it's the same instrument. Okay. The classification will be different depending on the station. When do you say mid forceps? When it is below 0 but has not reached +2. That is mid cavity. We don't do mid cavity these days. Okay. High to bilkul hi nahi karna. High was an older term when the head is unengaged. So mid and high forceps are no longer used in modern obstetrics. We only use outlet or low forceps. Quickly give me a thumbs up if this is clear, bacha. Now, when will you use it? So we will use forceps number 1 when the second stage is prolonged. I have already done this, right? Also, when the mother does not want to do the pushing, for example, she has heart disease. Then if there is fetal distress in the second stage. Now, please remember, in the in the active phase of labor, if there is distress, what do? So if it is active phase with fetal distress, what do? You do a cesarean. But if there is fetal distress in the second stage, then I can also do a instrumental delivery. Is that clear to everyone? Okay. We can also do a forceps in breech where we will use forceps for after coming head. Okay. So these are the indications. Can I also use it in face presentation? Yes, we can use it in mento-anterior face presentation, right? There also we can use forceps, but we cannot use it in mento-posterior. Now listen to me carefully. If you are applying forceps number 1, there should be no CPD, right? So very, very important. The pelvis should be adequate. Number 2, membranes have to be ruptured. Any times they say membranes are intact, you can't use instruments. Okay. For forceps, we need training. It is difficult. Vacuum is the one which is easier to apply. So I need to be trained. The cervical dilatation has to be full. You cannot apply forceps if cervix is not fully dilated. Okay. As I said, station has to be at least +2. Okay, that's the minimum requirement. All right. Then I will use it in occipito anterior. I can also use it in mento anterior face as I mentioned previously. Okay. What are the complications? Definitely it can cause maternal perineal injuries. Okay. But we will not ask you that. We will ask you which fetal injuries are caused by forceps. So remember, intracranial hemorrhage is more with forceps as compared to vacuum. Okay? Facial nerve palsy is more with forceps. Brachial plexus injury more with forceps. Skull fractures, कौन से type के होते हैं? Depressed skull fractures, again more with forceps, right? So these are all with forceps. Vacuum. Now please understand, the indications of vacuum are same. So it is better that we know the contraindications. So now can you tell me what would be the contraindications? We will never use vacuum if the baby is preterm. We will not use it in breech. We will not use it in face presentation. We will definitely not use it in CPD, contracted pelvis. We anyways cannot use instruments. Yes, if there is a big caput, then again our preference should be forceps. Okay, very good. I see everybody can answer and I'm so proud of you. Requirements are almost same like forceps, which means pelvis should be adequate, cervix should be fully dilated, the head should be at least engaged. For forceps, the minimum requirement was +2. For vacuum, the minimum requirement is 0 station. Okay. Then as I said, gestational age should be definitely more than 34. Less than 34 is an absolute contraindication. Okay. What complications are seen more with forceps, bacha? So, cephalhematoma. Please see there is a difference between cephalhematoma and ICH. Intracranial hemorrhage is more with forceps. Cephalhematoma is more with vacuum. Okay. Scalp lacerations, vacuum. Injuries to retina and sixth nerve, vacuum. Shoulder dystocia, vacuum. This is very, very important. and very, very probable complications. Okay, good to go everybody? Now, a few things that you should know about. No. If molding and caput are present together, some amount of molding can be seen even in a normal primigravida. Yes. So molding and caput together, especially if they are severe degrees, indicates CPD. All right. Mild molding, mild caput can all happen even in a normal labor. Okay. So please remember, when you talk about stage 1 of labor, which is when the cervix is dilating, the pain is coming from the uterus. So what nerve roots? The nerve roots are T10, T11, T12 and even L1, right? So T10 to L1 actually is pain of uterine contractions. When you say second stage of labor, then this is coming from the perineum. So now the nerve roots are going to be S2 to S4. So pudendal. Okay. If we are talking about labor analgesia, what method do we use? We use epidural block, right? So then we use a epidural block, right? What drug do we use as an epidural block? Yes, so we will be using a combination of bupivacaine and fentanyl, right? So bupivacaine and fentanyl. Please remember, whenever you talk about epidurals, they are going to cause hypotension. So they can cause even fetal distress. So you have to use the right drug amount and you have to do a close monitoring. Okay. Spinal block is the typical one that we use for cesarean section. Can you tell me what is the level of block here? The answer is T4. So now the level of block is T4. For vaginal delivery, I told you above, the vaginal delivery ke liye, what is the level of block? It is T10. Yes? Okay. GA. So please remember, general anesthesia is used very rarely, right? When will you use it? You will need to do it whenever there is an emergency, right? And when will there be an emergency? When you have to save either the life of the mother or of the baby. Yes. So for example, maternal conditions like shock, right? Second, whenever there is an urgency like cord prolapse. So in cord prolapse, we will give a GA when we have to quickly try and save the life. No, heart disease bilkul nahi bache. Please remember, in heart disease, the preferred anesthesia is epidural. ये तो MCQ आएगा, गलत नहीं करना है. Only in those conditions where ejection fraction is low. If the ejection fraction is low, then you give GA. Otherwise, the preferred anesthesia in heart disease is epidural. Doubt. If your patient has a coagulopathy or has a thrombocytopenia or she is an anticoagulant, then which anesthesia will you give? GA. For example, woman on warfarin and she is in labor. What do? So you are going to do a cesarean and the anesthesia will be GA. You cannot give epidural or spinal. Okay? Now, when we are talking about labor, we are very fond of asking you how to prevent perineal tears. So number 1, should we give a perineal massage? Yes. We can even give warm compresses. We can support the perineum by one hand. What do you do with the other hand? With the other hand, you are going to control the rate of delivery of the head. So how do you control the rate of delivery? By doing modified Ridgen maneuver, right? So you don't allow a sudden extension. You control the rate of extension by pushing the head in flexion. So you give a counter pressure on the occiput. Okay? Please remember, routine episiotomy is not to be given. Episiotomy will be given only for very specific conditions. Okay? Is that clear to everybody? Chalo. Now, types of perineal tears. So, first degree is when there is a tear of mucosa or skin. Second degree is if there is involvement of the muscles. Third degree is whenever there is involvement of the sphincter. Now, isme bhi there is 3A, B and C. You call it as 3A when there is less than 50% involvement of the external sphincter. B if it is more than 50% of external sphincter. And C when it is both external and internal sphincter. Okay. Now listen to me very carefully. If it is a third degree tear, it has to be repaired in the operating room. OR is operating room or OT. Yes. Under anesthesia. Yes. What is a fourth degree tear? A fourth degree tear is when it involves the muscles, sphincter, but the most important thing here is the rectal mucosa. Again, it has to be repaired in the operating room under anesthesia. Remember, the third and fourth degree tears are called as complete perineal tears. And preferably they should be repaired immediately. If you can't do it immediately, better do it within 12 hours. Earlier the cutoff was 24 hours, but now we say preferably to be repaired within 12 hours. Okay, perfect. Now, mediolateral and midline episiotomy. So I'm sure you all have done this with me. This is pretty easy. Can you tell me what is the angle if we do mediolateral? 60 degrees from the midline, okay, whereas this is going to be straight along the midline. What is the advantage of mediolateral? There is low risk of sphincter injury and therefore it can be extended, because even if you extend it, it will not be near the sphincter, it will be away from the sphincter. Whereas here there is a high risk of injury to the sphincter. Okay. Then please remember, the pain is more, okay. The healing is slow in mediolateral. Bleeding is more in mediolateral. Repair is more difficult in mediolateral. In fact, dehiscence is also more in mediolateral. Dyspareunia is again more in mediolateral. So everything is more in mediolateral except the anal injury. Okay? Let's look at these, because this is what will help us to know what is the position or presentation of the patient. So let's look at image A. Can you tell me image A is what Leopold? So this is Leopold 1. What is the other name for Leopold 1? It is also called as the fundal grip. Yes. B is Leopold 2. What is the other name? It is called as umbilical grip, also called as lateral grip. C is Leopold 3. How did I tell you to identify? I told you it is the only one where we use one hand. In all other images, it's two hands. So this is 3, also called as Pollock's grip. Can you tell me what is the other name? It is also called as first pelvic grip. But when we say only pelvic or second pelvic or deep pelvic, they are all names of which grip? They are names of Leopold 4. And how do you identify? This is the only image in which the fingers are directed downwards. Do you remember these things? The only image where the fingers are directed downwards is Leopold 4. Okay? All right. So this will tell us whether the head is engaged or not, and Leopold 4 will confirm the findings of Leopold 3. It also, Leopold 4 और क्या बताता है? If you have attended my class, tell me what else does it tell you? It also tells you whether the head is in flexion or extension. So it also helps to tell us about attitude. है ना? Is that clear to everybody? Yes? Okay. Now once we have done this, let's look at important diameters. Yes, NEET-PG does tend to ask this, so you should know it. So let's look at what are the important diameters. So when we talk about the pelvic inlet, which is the most important diameter here, it is obstetric conjugate because it is the smallest one. Yes, it goes, but can you measure obstetric conjugate? No. The only one that we can measure is diagonal conjugate. Yes, it goes from lower border of symphysis pubis to the sacral promontory. Yes, and if you subtract 1.5 centimeters from it, you will get the obstetric conjugate, which is actually the shortest one. ये कहाँ से कहाँ जाता है? From inner surface of symphysis pubis, है ना? So it goes from inner surface of symphysis pubis to which place? To sacral promontory. True conjugate goes from upper border of symphysis pubis to the sacral promontory. So all these are diameters of the inlet. Which is the longest diameter of the inlet? Transverse. Right? So the longest diameter is the transverse diameter of the inlet. Talking about mid-pelvis, which is the smallest diameter? Interspinous, IID. Okay, IID is interspinous. Okay, the normal value is 10.5. Remember, this is the narrowest part of the entire female pelvis. Okay, it is the narrowest part of the female pelvis. Right? Pelvic outlet. The most important diameter here is bituberous or intertuberous because this is the shorter one. Intertuberous is the distance between the ischial tuberosities. So when you are talking about ischial tuberosities, which pelvic outlet are we talking about? We are talking about anatomical outlet. Okay. Now you have to tell me, what about obstetric outlet? So obstetric outlet, you know, does not pass from ischial tuberosities. Okay. It will pass from ischial spines up to what level? Posteriorly, it goes to body of coccyx, while anatomical outlet will go to tip of coccyx, right? So from tuberosities to the tip of coccyx is anatomical outlet. From ischial spines to the body of coccyx is going to be obstetric outlet. Okay? Now, yes, I'm going to show you some of the images that I want you to see, but let's look at this as well. So again, another format in which your exam, especially NEET-PG, is asking are the presentations and their engaging diameter. So when we say vertex, remember it is a well flexed head, okay, and the diameter will be suboccipitobregmatic. If it is deflexed, yes, we may still use the term vertex, but the diameter will change. It is called as occipitofrontal. When it is deflexed, we can also say it is sinciput presentation. So then again, it would mean what? It would mean, yes, deflexed head. Remember what I have told you. If occipitofrontal is not in the options, what is the second best answer? The second best answer is suboccipitofrontal, because it depends on what? It depends on degree of deflection. If there is mild deflection, it is suboccipitofrontal. If it is completely deflexed, then it is occipitofrontal. So these are the two diameters when we talk about deflexed head, and they are important for your exams. Okay, we could also use the term partially flexed. All right. Then what about brow presentation? For brow, it is going to be mento-vertical. It is 14. It is the longest diameter of the fetal head. Yes, that is what is mento-vertical. Face presentation kab hota hai? When the head is in full extension and the engaging diameter is submentobregmatic. Okay, it is submentobregmatic. Now, remember, when we talk about breech, then we talk about bitrochanteric, right? So bitrochanteric is 9.5 centimeters, 9.5. And when it is transverse lie, it is shoulder presentation. So then it is bis acromial, which is the engaging diameter. So these are different engaging diameters in different positions, and that is exactly how your exams are going to ask it. Okay? Now, they are memory based, but it is important for you. Let us now see whatever we have done, and let us look at some of the important images. So let's start with these. Okay, can you look at image number, let's say this as 1. Okay, so what is image 1? This is a first degree tear because there is tear of only the vaginal mucosa. Look at image number 2. This is a second degree tear. Why? There is torn perineal muscles. Okay. Look at image 3. Here, even the anal sphincter is torn. What is this white sheet inside? The white sheet inside is the rectal mucosa. So look at image number 4. What has happened in image number 4? Even the rectum is torn. So it becomes a fourth degree tear. They may show the rectum or the mucosa either as pink or as white. Right? So in this image, it is white. In certain images, they may show it as pink. So look at that. If it is torn, then it is a fourth degree tear. Okay. Yes, so this is what is modified region. What are we doing? We are keeping 2 fingers under the chin. Yes, and the other hand on the occiput. So we all know delivery of head has to be by extension. So what do we do in modified region? We give a counter pressure on the occiput. So we push it in flexion so that the extension doesn't happen suddenly. It's a slow movement. Why do we call it modified? Because originally Ridgen said do it in between contractions. When you say modified, it means you will do this maneuver with uterine contractions, which means synchronous to the contractions. Okay, so this is what is modified Ridgen. Okay, now some very basic things. I'm sure you will not do mistakes in identifying these. So please remember image A and image B both are longitudinal lie, but the presentation is different because that is dependent on what is present in the lower pole. So in image A it is cephalic, in image B it is breech. Image C is shoulder presentation, which is very different from shoulder dystocia. Also look at this, the fundal height is less than the POG. Yes, the fundal height is less. So this is what is transverse lie or shoulder presentation. Now, very often we will ask you to identify these positions. Okay, so I have told you how to do it in the exams. I will teach you once again. So what are you going to look at? You're going to look at the triangular fontanelle because triangular fontanelle means it is the posterior fontanelle, which means it is close to which bone? Occiput. Right? So which means here the occiput is more close to sacrum or symphysis pubis. It is more close to sacrum. So if it is close to sacrum, it has to be occipito-posterior. Also, this is our right hand. So what will be for the patient? For the patient, it will be left. So this is left occipito-posterior. Okay. Can you tell me what is the most common position in labor? So most babies will begin their journey in LOT. If we ask you most common position in late labor, then it is LOA. And if we ask you in OP, occipito-posterior, which is most common position, then what will you answer? So in occipito-posterior, the most common position is ROP, right occipito-posterior, right? Now, let's look at this. The pelvis, they often tell you to identify, and to identify it, we have to look at the inlet. So if the inlet is almost circular, then it is gynecoid. If the inlet is heart-shaped, then it is android. If it is antero-posteriorly oval, right, which means the AP diameter will be bigger, then it is anthropoid. And if it is a transverse oval, then it is platypeloid, which is the least common type. Gynecoid is the most common type. Okay, now quickly you will answer these questions. In which pelvis will you see occipito-posterior? So android. Android में क्या मिलता है? ROP. So occipito-posterior or right occipito-posterior. But if I ask you persistent OP or direct OP, तो आंसर क्या होगा? Then the answer will be anthropoid. Yes, then the answer will be anthropoid. Face to pubes, what will be the answer? Face to pubes, again anthropoid. If I ask you face presentation, yeah, brow presentation. So when we talk about face and brow presentations, the pelvis will be platypeloid. Okay. Platypeloid is also called as what? Flat gynecoid, right? So it will be also called as flat gynecoid. So these are positions. Also, can you tell me deep transverse arrest is seen in which pelvis? Yes, most common answer will be android. The second best answer will be anthropoid, right? So that is for deep transverse arrest. No, DTA is not in platypeloid. Okay. Which diameter are we measuring here? So look, we are going from lower border of symphysis pubis to the sacral promontory. So this is a diagonal conjugate. Where did I say obstetric conjugate goes? From inner surface of symphysis pubis to sacral promontory. And which one goes from the upper border? From the upper border to the sacral promontory will be true conjugate. ठीक है? So upper border से sacral promontory तक. So from upper border of symphysis pubis to the sacral promontory, which one is it going to be? This is going to be true conjugate. Which is the shortest? Obstetric. Yes, that is the shortest. Which one can be measured clinically? Diagonal. Okay. This I am sure we all will be able to identify. So this is going to be an episiotomy scissor. Can you tell me which muscles are we going to cut when we give an episiotomy, especially when you give mediolateral? So we will cut bulbospongiosus, also called as what? Bulbocavernosus. They are the same. We will also be cutting what? Superficial and deep transverse perineal muscles. Yes. Then we will also be cutting which other muscles? Some part of levator ani. कौन सा part? Usually it will be pubococcygeus. Yes, so usually it will be pubococcygeus. So these are the muscles that we usually cut when we give a mediolateral episiotomy. Please remember istiocavernosus or only coccygeus we don't cut, right? It is pubococcygeus that we cut. All right. Chalo. Okay. We will talk about these positions when I reach there. So let's get back now. So now we have to talk about some abnormal things. For example, breech presentation. Okay. The first thing I want you to know is that this is the most common malpresentation. Right? So this is the most common malpresentation. Remember, the incidence at term is important because the most common reason for this is prematurity, right? So at term, the incidence is around 3%, okay? The other important risk factors are which ones? It can be placenta previa, it can be polyhydramnios, it can even be oligo, it can be uterine or fetal anomalies. So please remember, if we ask you most common risk factor, then it is prematurity. If we ask you cause of recurrent breach, what will you answer? recurrent breach is going to be uterine anomalies. Okay, it's going to be uterine anomalies. Now, what are the different types of breach? So it could be frank, complete or footling. Which is the most common? Frank breach. This is the one that you will usually see in primi-gravidas. Now you could get it as a visual or as a direct MCQ. So remember, both hip and knee joints here are not flexed. It's only the hip joint which is flexed while the knee is extended. Okay. It is the complete breach in which both the joints are flexed. And if they ask you which one do you see in multi-pares, then it is actually a complete breach, right? Footling, we all know why it is famous, because it has the highest risk of cord prolapse. All right. Now, the moment we ask you management of breach, what are you going to decide the answer on? So this is what you need to know. Whenever we get a breach presentation, we should first try an external cephalic version. Now, ECV can be done any time after 36 weeks, but generally when we do ECV, most commonly we will do it at 37 weeks. Okay. So this is what we want you to know. If you have diagnosed breach at term and if ECV can be done, then you will do ECV. If ECV cannot be done, then please remember always the preferred mode in breach is cesarean. The preferred mode is not vaginal delivery. Okay, is that clear? So preferred mode is cesarean in case you cannot do a external cephalic version. So we will see these names and then we will see these images. So remember, different in case you are doing a vaginal delivery, then there are certain maneuvers we use to do the breech delivery. So you have to know peanuts is what we used for delivery of legs, right? So peanuts is used for the delivery of the legs, right? Lovesets. Lovesets, how do you remember? You love someone with both your arms. So if you remember lovesets, peanuts apne aap aasan ho jata hai. ठीक है? So remember, lovesets is going to be for the arms, extended arms. So therefore, extended legs is peanuts, right? MSB, Burns Marshall, Prague and Duhersons. What's common? They are all done for after coming head. So how do you decide which one is going to be the answer? If the after coming head is of a preterm baby, then what do? Then we will do Duherson's incision. If the back is posterior, then we will do Prague's. If the back is anterior, then we can either do Burns Marshall or we can do MSV. Which is more common? Then more commonly what we do is Burns Marshall. Remember, in MSV, what we do is malar flexion and shoulder traction. Right? So malar flexion and shoulder traction. Right? Now let's try and see these in the images as well, because they could be asked in your exams. So let me just scroll down. I will come back to this. Right. So I hope you know how you will identify breach. So breach, this is frank breach because the knees are extended. Yes. This is complete breach because both the joints are flexed. While this is the footling breach where one or both the feet might be coming down. Okay. Now maneuvers. So if you get to see something being done to the legs of the baby. So this is peanut. So as I said, this is for the extended legs, right? Look at this maneuver. So let's put it as L. So if you look at this, what is this? You are rotating the baby's body here, right? In order to deliver the extended arms. Look, right? So this is what is the Lovesets maneuver. So Lovesets is for extended arms, right? Burns Marshall looks like this. The baby has delivered. Now you have to deliver the after coming head. So you hold the legs and you take them towards the maternal abdomen. So this is Burns-Marshall. The spine is anterior or the back is anterior. So this is dorso-anterior, right? Okay. This is what is MSV. What do you see here? Again, the back is anterior. What else are we doing? Yes, we are giving a traction to the shoulders. So shoulder traction and we are putting pressure on the malar bone. So malar flexion and shoulder traction. So MSB. Please remember, after coming head of breech comes out by flexion, not by extension. In vertex presentation, the head comes out by extension. In after coming head of breech, it is by flexion. Look at this. We are making incisions on the cervix. So this is what is Duherson's incision. The position is 2 and 10 o'clock, right? So this is for preterm after coming head. Okay. Look at this. This is dorso-posterior. Yes, so this is dorso-posterior. What do we do it for? So we do it again for after coming head. Now this becomes the Prague's maneuver. Okay, so now this becomes the Prague's maneuver. Which forceps do we use for the after coming head? So the typical forceps that we use for after coming head is Piper, right? So Piper is what we use for after coming head. Bracket can be used, but it's not a common maneuver at all, right? So bracket maneuver can also be used, but not a very common maneuver at all for breech. Okay, so the forceps that we use is Piper. Remember that it is a very long forceps and it has a reverse pelvic curve. The only forceps with a reverse pelvic curve. Okay. So which means when you go from the toe of the blade towards the handle, you are going upwards. That is what is a reverse curve. So Piper forceps. Yes. All right. Then let's go back and let's do a few things that we should know about brow presentation. So brow mein the head is partially extended and mento-vertical is what is the presenting engaging diameter. It is the biggest one. Is vaginal delivery possible? No. So when you say brow presentation and you say it is persisting, yes, so brow in late labor, then you have to do a cesarean section. Okay. When we say brow in early labor, then you can do a wait and watch. Okay. But if it is persisting, then it is cesarean. Now, as I said, the largest diameter is mento-vertical. Can you tell me which is the smallest diameter? The smallest diameter is bimastoid, 7.5. A lot of times, bimastoid may not be in the options. Then what do? Then you have to know the second best answer is bitemporal, which is 8 centimeters, right? So then it could be bitemporal. Yes? All right. Face presentation is very similar to brow, but what you need to know is here the head is in full extension. Okay, it is going to be in full extension. The engaging diameter I've already told you is submentobregmatic. Okay, can we do a vaginal delivery? Yes, provided it is mento anterior. So vaginal delivery is possible. If it is persistent mento posterior, then you cannot deliver vaginally. Please remember, face presentation has a high association with anencephaly, right? So you remember, if it is face in early labor, even if it is mento posterior, on early labor, it is wait and watch. If it is persisting, then we will do a cesarean section. Okay? Shoulder presentation. We should all know this is same as transverse line, not same as shoulder dystocia. Okay? Remember, the most common cause again is prematurity. But at term, the most common cause becomes placenta previa, right? So this becomes the cause at term, so it should always be ruled out. Now, understand this. Whenever we get a transverse lie, you should consider admission at 37 to 38 weeks, because this is the time we are going to try external cephalic version, just like in breech, okay? In case I cannot do a version, then I have to do a cesarean. Vaginal delivery is not possible. Please remember, in your exams, if they say membranes have ruptured, or they are saying the patient is in active labor, she is transverse lie, will you answer it as ECV? Yes or no? No, then we will not answer it as ECV, because these are contraindications. So then the answer is going to be cesarean. So especially for NEET-PG, your exams are fond of asking external cephalic version ke contraindications, because they will ask it in an integrated manner, right? So what is the best time to do ECV? As I said, 37 weeks. What are contraindications? Remember, any time vaginal delivery is not possible, you cannot do a version. If there are gross abnormalities of LICA, like severe oligo, then you cannot do a version. If there is fetal distress or she is in active labor, again no, okay? Very, very important. If your patient has a footling breach or a hyperextended neck, what do you call it? We call it as a stargazer fetus. Again, it is contraindicated. Ruptured membranes, very important, is a contraindication. Twin pregnancy, very important contraindication. Fetal or uterine anomalies, very important. Now, INICET will specially confuse you with relative contraindications. Please remember, pre-eclampsia, previous cesarean, IUGR, macrosomia, again in these ECV is contraindicated, right? So in all these conditions, we will not do a ECV. What we prefer doing is going to be a cesarean. So if these conditions are associated with breech, no ECV. We will do a cesarean section. Okay? Arey, we are about to finish. Kya karoge with break? Okay, I'll give you a break. Don't worry. Okay? Let's do malposition and then I'll give you a short break. Fine? Chalo. Now, let's look at malposition. So when we talk about malposition, we are talking about occipito-posterior. No, stargazer is a type of breech where the head is hyperextended. Okay? Chalo. The most common is ROP. I just told you. Okay? I also told you OP is associated with android pelvis. Okay? And majority of times, what happens to OP? OP will automatically convert into OA. Yes, so if you see prolonged labor, what is the management? Wait and watch. It converts into OA. Sometimes, listen to me very carefully. Sometimes there is going to be a short anterior rotation and a deep transverse arrest. They will ask you, in which pelvis do you see this? So now we know this is what will happen in android pelvis. A short anterior rotation and a DTA, and the management would be cesarean. If there is a anthropoid pelvis, what will happen? A short posterior rotation. Yes, which will result in what? Yes, a face to pubes delivery, which is what is called as a direct OP or persistent OP. Okay, is that clear? Now, when we talk about labor or whether it is a natural labor or induction, the most important thing that your exams also tend to ask, again especially NEET-PG, are contraindications to induction of labor, right? Because they will again integrate this with other topics like pre-eclampsia, previous cesarean. Okay? So please remember, इसमें हम absolutely induction नहीं करेंगे. Okay? Now, beta relative contraindications है where although you can do ECV but we never do it because the risk is high, like previous cesarean, like preeclampsia, like IUGR. Okay? So what are contraindications? Classical cesarean or a uterine surgery like myomectomy. Then you are not going to do induction. Okay? Placenta previa or vasa previa. Again, never induction. It is always a cesarean. Okay? Transverse lie or breech. In transverse lie and in breech, we never do induction of labor. Okay? Cord prolapse. We know that the absolute management is cesarean. Active genital herpes. Again, if you see active lesions, then no induction, it will be a cesarean section. Okay. Severe distress or a non-reassuring FHR. Okay. If there is cephalopelvic disproportion, then please remember, if it is an obvious CPD, especially in a patient with previous cesarean, never do induction. So if you are seeing current CPD and she is a case of previous cesarean, never do induction. Okay. Otherwise, in CPD, we can still try vaginal delivery, but not with the previous cesarean. Okay. Cancer cervix and patients with VVF repair. Again, only mode of delivery in them is cesarean section. Okay. Now, once you know this, I want you to look at these remaining labor images. For example, very often they will ask you, how do you make a diagnosis of OP? Right? So for OP, you have to know the abdomen below umbilicus will look flat. Okay, it's not bulging. Second, you have to know that the limbs are going to be felt near the midline, whereas the back and the shoulders are away from the midline. Heart rate कैसा होता है? Again, it is hertz, away from the midline or towards the flanks. Can you tell me on a PV exam, which fontanelle will you feel? You will now feel the anterior fontanelle. Why? Because the head tends to be deflexed in OP. When you talk about well-flexed head, which fontanelle do you feel in PV? Posterior fontanelle. Okay, then we feel the posterior fontanelle, right? So these are things that you should know about normal as well as abnormal labor. Let's look at these images. What forceps is this? This is what is Wrigley's. How do you identify? Lock. Yes, this is called as the English lock. Please remember, I told you it is actually an outlet forceps, but do I also use it as low forceps? Yes, it can also be used as low forceps. Where will you never use? Never use it in CPD or in contracted pelvis. Okay. If there is less space, you cannot do an instrumental delivery. Okay. Then, what is this device? We all understand this is a vacuum cup, right? Much easier to apply as compared to forceps. We've already seen the contraindications. This tells you what should be the correct application. So when you talk about correct application of a vacuum, you apply it at the flexion point. Where does it lie? It lies on the sagittal suture. Where exactly does it lie? 3 centimeters anterior to posterior fontanelle. The triangular is the posterior fontanelle. You can also say it lies 6 centimeters posterior to anterior fontanelle. Yes, the anterior fontanelle is rhomboid in shape or diamond in shape. So that is what is the correct application. It ensures the head is in flexion and smaller diameters are coming out, right? How do you know the correct application in forceps? For forceps, the correct application is the blades should be equidistant from sagittal suture. And sometimes they might ask you, you will apply the forceps along which diameter, right? So which diameter? It is called as occipitomental diameter. Okay, not mento-vertical, it is occipitomental diameter. It is the second largest diameter, right? So this is the diameter along which you apply the blades of forceps. So with this, we've done what is normal and abnormal labor. Now we are left with PPH and some things about purpurium. So we'll take a quick break. 10 minutes, I think, should be good for everyone. And then we will restart. Okay, so we'll take a quick 10-minute break. Go have a cup of tea, come back, and we will restart. Okay? Hanji everyone, are we ready? All right. So we've done the first stage of labor. We have done the second stage of labor. And now we are going to talk about the third stage of labor. Yes? So now tell me, oh no, in cord prolapse, you give tocolytics because you want to do a cesarean section. Yes, so that is exactly why you're giving tocolytics. Why do you want to memorize it? Learn the concepts. Okay? Chalo. So we will now talk about postpartum hemorrhage, right? Which is going to be a complication of the third stage of labor. Now, when we talk about postpartum hemorrhage, remember the definitions. So it is blood loss more than 500 ml. Especially if they ask you about cesarean section, then the cutoff changes to 1000 ml. Yes. So what is primary PPH? Primary PPH is if it happens within 24 hours. What is secondary? So if it happens beyond 24 hours up to 12 weeks. It's not 6 weeks. Okay. It's 12 weeks. Now, in general, please remember the most common cause is uterine atony, especially when you talk about primary PPH. Okay. On the other hand, if we talk about secondary PPH, the most common cause is retained placental tissues, right? So it is usually bits of placenta which are left behind. Now, when we ask you risk factors, this is one place where NEET-PG, INICET both asks you about risk factors. So please remember any kind of abnormal labor, whether induced or augmented, prolonged or obstructed, instrumental delivery, they are all going to be risk factors. Any abnormalities of placenta, whether it is PAS or whether it is placental abnormalities of structure like succenturiata, right? Anytime there is a placenta previa, right, or abruption. So any abnormality of placenta itself can cause PPH. Okay? Then, what about certain specific complications of pregnancy itself? Please remember, preeclampsia is an important risk factor. Even anemia is a risk factor. Yes? Then, diabetes mellitus, okay, polyhydramnios, multifetal. Here the reason is overdistension. Okay? So please remember, other than that, areas where NEET-PG tends to confuse or INICET tends to confuse you is, yes, obesity is a direct risk factor. Grand multiparity is a risk factor. Previously retained placenta is a risk factor, right? So these are also going to be risk factors. So what do we do to prevent PPH? We are going to do an active management of the third stage of labor. So what are the components that you should know? So one, yes, is delayed cord clamping. So when do you say it's delayed? If you do it beyond 1 minute. So between 1 to 3 is what we say delayed cord clamping. So where would you do early clamping, which means we're talking about exceptions. So when we talk about early clamping, the best answer is neonatal resuscitation. So whenever the baby needs to be resuscitated, we will do early clamping. Apart from that, yes, RH negative pregnancy, especially, you know, when we say it is not sensitized, right? So ICT is negative, then it is even more important to do a early cord clamping. Whenever the baby may have a known heart disease, you don't want to overload the heart. Yes. The second and the most important component of the AMTSL is giving a uterotonic agent, and you're supposed to give it within 1 minute of delivery. But yes, can we give it at the birth of anterior shoulder? Yes, that is an alternative. Okay, we can give it at anterior shoulder as well. The first line drug is which one? It is going to be oxytocin. 10 international units. Please remember we can give it IM. We can also give it IV. But if it is IV, it has to be a infusion. Never give IV bolus. Do you remember the reason why not IV bolus? Because it causes hypotension. Okay. What are the alternatives to oxytocin? So first, we can give misoprostol. The dose is 600 micrograms. The side effect is fever with chills. Okay. The other is ergometrine or methergin. We already have done the contraindications, so I will not repeat. Right? Side effect is hypertension. It causes a very high rise of blood pressure. Carbetocin. Do you remember what is carbetocin? It is an oxytocin analog, right? So 100 micrograms slow IM over 1 minute. Okay, we can give IM also, we can give IV also. Usually we will give slow IV over 1 minute. Yes. So then we say it is carbetocin. Okay. Now please remember, can we give atosiban here? No. So don't get confused. Even if your examiners try and confuse you, we will not give atosiban. Atosiban is a tocolytic. Can I give PGF2 alpha? No. Carboprost is not given for AMTSL. It is given for treatment of PPH. Okay. Can I give Tranexa? Yes, we can give Tranexa. That can be given. Okay, so Tranexa कैसे देते हैं? 1 gram IV over 20 minutes. Okay, 1 gram IV over 20 minutes. Now, what are the other components? Controlled cord traction. What is the other name for controlled cord traction? Yes, it is called as modified Brand Andrews method. Okay, we will just see. So you have to pull down the cord and you have to give counter pressure to the fundus. Okay. Uterine massage. Is it done routinely? No. So please remember, it is not recommended routinely. You will only do it when the uterus is atonic. So it is actually used for treatment, not for AMTSL. Okay? In case there is a postpartum hemorrhage, remember the stepwise algorithm. So we will remember it as 4 R's. What is the first R? Rub the uterus. Okay? Which means uterine massage. What is the second R? Remove any placental bits and tissues, right? So if there is retained placental products, they will cause PPH. The third R, you have to replace the fluids. Do we start with crystalloids or colloids? I've taught you. You're going to give crystalloids, right? So 2 large bore IV cannulas and start fluids. And rapidly give uterotonics, right? So those are the 4 R's. Which is the most important R here? Please remember, the best thing is uterotonics. Okay, that is what is going to control the PPH. It is most effective one. Massage is not better than giving uterotonics. Okay. Now, please remember, the first line drug is again oxytocin. The dose is different, 20 to 40 international units. Again, IV infusion, not bolus. What are you going to do if you have already done this and still she is bleeding? फिर क्या करेंगे? If she is still bleeding, then after giving oxytocin, I will add more uterotonics, right? So I can add ergometrine or methergin. I can add carboprost. We can also add misoprostol. So these are the other uterotonics that we can add. And remember, the dose of ergometrine is 0.2. The dose of carboprost is 0.25 milligrams or 250 micrograms. Yes, please remember, carboprost kya hai? PGF2 alpha. It is also called as dinoprost. It is also called as hemabate. Hai na? So these are the other names. Remember, it is avoided or contraindicated in asthma. It causes what? It causes bronchoconstriction. How much maximum can we give? We can go up to 8 doses, which means 2 milligrams. Okay. So that is what is carboprost. Misoprost ka dose, if you are giving sublingual, then the recommendation is 800. 1000 is what you will give per rectal, right? So 1000 is per rectal. So anywhere between 800 to 1000 micrograms. Now, if your patient is bleeding despite uterotonics, what do? Then you have to proceed to balloon tamponade. Which tamponade? So typical example is Bakri balloon tamponade. If the bleeding is still persisting, then what do? Then you can either do a uterine artery embolization or a B-Lynch. Remember, for uterine artery and B-Lynch, the patient has to be hemodynamically stable. If my patient is hemodynamically unstable, then I should actually proceed to uterine artery ligation. So if you have done a balloon tamponade and we are asking you next step, what does it mean? It means number one, if the patient is stable, we can do B-Lynch or UAE. If the patient is unstable, we can do uterine artery ligation. Remember, the ligations are done bilaterally. And if uterine artery ligation alone does not help, we move on to the utero-ovarian anastomosis. Again done bilaterally. What is this called as? This is called as stepwise pelvic devascularization. Yes? Yes, please understand this. You don't wait for one drug and other drug. Once you've given oxytocin, you can just quickly move on to other drugs and simultaneously you can actually even start balloon tamponade. Is that clear? बेटा 0.25 है तो वो मिलीग्राम्स है, अगर माइक्रो है तो वो 250 है, ऊपर लिखा तो है. So 250 is micrograms, 0.25 कर दोगे तो वो milligrams हो जाएगा. Okay? As I said, hysterectomy is going to be the last resort, right? So yes, these two ligations, uterine artery and ovarian artery, as I said, are nothing but stepwise pelvic devascularization. Is that clear to everyone? Again, can we also give Trenexa? Yes. So as far as WHO recommendation goes, WHO says injection Trenexa 1 gram IV should be given to all patients of PPH and it should be given, the upper limit is 3 hours. Actually, you should give it as soon as possible, right? It is most effective when it is given in the first 3 hours, right? Preferably as soon as possible. Okay, is that clear to everybody? Okay. Then let's look at other causes of shock. So one of the important other things that we tend to ask is uterine inversion. Sabse pehli cheez, it is not a common thing to happen. It is uncommon. When would it happen? So what would be the key factors? If you are giving cord traction but not giving a counter traction, yes, while removing placenta. Secondly, how will the patient present? The patient is going to present with very, very importantly, shock. You have to know that this is going to be shock immediately after delivery. Right? So shock immediately after delivery, but other than that, the patient can also complain of pain. There will be some amount of bleeding as well, and you will see a red beefy mass protruding from the vagina because the uterus is, yes, inside out. So what you are seeing is the mucosal part, so it looks red, and you will not be able to palpate the fundus of the uterus per abdominally, yes, because it is lying outside. What are you going to do? You have to immediately begin with manual replacement. Yes. Now please remember, if placenta is still attached, do you remove it? No. If placenta is attached, it has to be left in place and you have to do a manual repositioning. Also, please remember, while doing manual repositioning, we don't start oxytocin. You will only start oxytocin after you have reposited the uterus. And also remember, when we talk about this manual replacement, it has to be done in the labor room itself, not in the operating room. So don't waste time. If your manual replacement fails, then we will usually go ahead with surgical management. Yes, the manual replacement is called as Johnson's method. Yes, So the manual replacement is Johnson's. And which is the surgical method? The name of the surgical method that we commonly use is Huntington's method, right? Huntington's. Remember, the first shock that we see here is neurogenic. But if we ask you cause of death, then it is hypovolemic shock or hemorrhagic shock, right? So cause of death is hypovolemic shock. Okay. The other important thing that again NEET-PG is fond of asking is amniotic fluid embolism. Again, it is an uncommon thing, a rare thing. And remember, the important risk factor is cesarean section. The other risk factors, yes, are preeclampsia, advanced age. What would be the presentation? Cardiovascular collapse. So the patient is going to present with shock as well as respiratory distress. So we say there is SOB. So there is sudden onset of breathlessness and there is cardiogenic shock. So the symptoms are cardiorespiratory. Okay. Along with this, please remember, because it is cardiorespiratory, there is hypoxia. During shock, the patient may also show seizures, right? She will go into coma. Then the second phase of amniotic fluid embolism begins, which is characterized by DIC. Okay, so whenever you think of SOB and along with it you see DIC, always think of amniotic fluid embolism. ठीक है? Pulmonary embolism में बेटा DIC नहीं होता and pulmonary embolism में कभी भी the progression is not very fast. Here there is a very rapid progression of symptoms and that is why, what is the other name if you remember from the class? I called it as anaphylactoid syndrome of pregnancy. Yes? Okay. Please remember that there is no confirmatory test. Diagnosis is clinical and it is a diagnosis of exclusion because it is an uncommon thing to happen. Yes? Please remember the lab findings would be simply the findings of DIC. Like the fibrinogen levels will be low, the INR will be high. Yes? All we can do for her is supportive care. There is no specific treatment for amniotic fluid embolism. It has a high mortality rate. What kind of maternal death will it be? Direct or indirect? This is a direct maternal death. So if there is a death because of obstetric causes, then it is a direct maternal death. If it is because of pre-existing causes like worsening of heart disease, like anemia, then it is indirect. Okay. Retained placenta, I told you, if it fails to deliver within 30 minutes. Okay. What is the most important risk if the placenta is retained? That the patient will have PPH. Yes. And yes, it will also predispose her to infections. Now, what you are going to do depends on how they give you the presentation. So if there is retained placenta and the patient is not having severe hemorrhage, then initially you can try controlled cord traction and oxytocin. Yes. But anytime they say there is retained placenta and severe bleeding, straight away you have to answer it as manual removal of placenta, MRP. Then you are not going to try control traction, oxytocin. So anytime we say severe bleeding, it has to be MRP. Okay. Please remember MRP has to be done under anesthesia. So it is done in OT. And classically, we used to do it in under general anesthesia. These days, yes, we could try it in epidural and spinals as well. But the single best answer would remain as GA. Okay, so it has to be done under anesthesia. When you're removing it, you have to ensure that there is a complete removal. Please remember, if you don't feel any plane of separation while doing MRP, it means you are dealing with PAS. So if there is no plane of separation, then as I said, it means you are dealing with PAS. Stop MRP and proceed to hysterectomy. Yes. If you keep trying MRP, she will bleed to death. So don't do this and proceed on to hysterectomy. Okay. As I said, if you are suspecting placenta accreta, you could do an intraoperative ultrasound as well. You have to keep blood transfusion ready. You have to do a hysterectomy and you have to take a high risk consent. Not only high risk consent for hemorrhage, blood transfusion, hysterectomy, but it could also be bladder injury. Because if it is per creta, it may be invading into the bladder as well. So that is also a possibility. So you have to take all these consents and proceed to hysterectomy. Okay. Purpurium, yes, we'll try and do it as short as possible, but all the relevant things. So number one, when we say uterus, when does it return to pre-pregnant size? The answer is 6 weeks. Okay. So if they ask you what is the weight of the uterus immediately after delivery, the answer is 1000 grams. If we ask you what is the weight after 6 weeks, it is almost 80 grams, right? So it comes back to pre-pregnant size. Remember, the fundus reduces by 1 centimeter per day, or we say 1 finger breadth per day. But this will happen after 24 hours. Please remember, in the first 24 hours, there is no change, okay? If we ask you when will it be not palpable, which means it has now become a pelvic organ, what is the answer? So 10 to 12 days. So by 10 to 12 days, it has become a pelvic organ, or we say by 2 weeks, it has become a pelvic organ. It will no longer be palpable. Okay? The second important thing. We know that there is a normal vaginal discharge which is called as lochia. So there is a rubra, serosa and alba. Rubra is primarily blood but also has decidua. Serosa is blood, less blood, more WBCs, and alba is primarily mucus and WBCs. Now please remember, if we ask you average duration, the best answer is 4 weeks, but it can be normal up to 6 weeks. Beyond 6 weeks, it is never normal. Okay. Beyond 6 weeks, it is abnormal. Now, important hormonal changes and their implication. There will be a sudden fall of E and P. This will lead to what? Postpartum blues. It will also lead to mood swings. Yes, which is what is postpartum blues. We will talk about it in a moment. And this is also the reason for what? Initiation of lactation. Because estrogen and progesterone, do you remember what I told you? It has a negative feedback on the prolactin receptors on the breast tissue. This is why there is no expression of breast milk during pregnancy. Okay. Please remember, prolactin levels fall after delivery, but they are significantly high to cause or continue breastfeeding. So when would you see highest levels of prolactin? So prolactin highest levels are actually seen in the 3rd trimester, not postpartum. Whenever the baby is going to suckle, there is going to be release of oxytocin, which will cause uterine contractions as well as milk ejection. What is this called as? This is called as after pains. Right? Now, when does blood volume or cardiac output return to normal? Around 2 weeks. Please remember, for the first 6 weeks postpartum, there is a high risk of thromboembolism. All right. What should you know with respect to lactation? So, colostrum is the first milk. What is it rich in? It is rich in immunoglobulins as well as proteins. What is it deficient in? Fats, carbohydrates. वो कम होते हैं, ठीक है? It is also deficient in vitamin K. Yes? Okay. Mature milk production will usually begin by day 3 to day 5. It will have fats, it will have carbohydrates as well. Okay. Now, please remember, when we talk about postpartum blues, they are very common, but they should resolve by 2 weeks and the symptoms are going to be mild. Okay, the symptoms are going to be mild, the management is going to be conservative. I told you the reason is sudden fall of E and T, right? Depression is if the symptoms are more severe and they are lasting for more than 2 weeks, and that would need treatment, right? So it would need antidepressants, could also need psychotherapy. Sheehan's, as I said, NEET-PG, yes, is fond of asking. So the key word would be severe PPH, right? So they will usually tell you about what? They will tell you about blood transfusions, okay? There will be a pituitary infarction, typically only of the anterior pituitary, not posterior. Yes. How will the patient present? There will be failure of lactation and she will continue to have amenorrhea, right? So all pituitary hormones will be low, low LH, low FSH. Please remember the first hormone to be affected is growth hormone. What would be the finding on MRI? Empty sella. Yes, so there is an empty sella sign and you have to simply replace all the pituitary hormones. Okay. Then postpartum fever, or when we say puerperal sepsis or puerperal pyrexia, please remember you will make this definition when there is fever. It should be documented on 2 occasions, right? And it should be not in the first 24 hours. So it can be from the 2nd day to 10th day. So we have to document this fever on 2 occasions, excluding the first 24 hours, because in first 24 hours it could be reactionary. What are you going to think when we give you a postpartum patient with fever? Think of endometritis, okay? Especially if the MCQ says she's undergone a cesarean section. Especially if the MCQ says there was prolonged rupture of membranes or there was prolonged labor, then definitely yes, think of endometritis. The patient will have fever, there will be uterine tenderness, there could also be a foul smelling discharge, and there can be uterine subinvolution. So uterus would remain slightly enlarged, okay? What are you going to do for management? It is a polymicrobial infection, okay? So you have to give broad spectrum antibiotics, right? Now, when we say, suppose they say, and especially again NEET-PG, if they say you have given antibiotics, but the patient keeps having persistent fever, which means she is not responding, then this is when you should also think of what? Do you know what? This is when you should also think of a condition called as septic pelvic thrombophlebitis. Okay, so septic pelvic thrombophlebitis, and that is why now what I will do is I will give broad spectrum antibiotics, continue giving them, but also at the same time add heparin, right? So we will add heparin and you will see that the patient actually improves suddenly, right? So this tells you that there was probably septic pelvic thrombophlebitis. Usually it is the right ovarian vein which is involved here. Sometimes you can feel it like a cord-like structure as well, okay? So you can feel it like a cord-like structure, and then you know that you are dealing with a septic pelvic thrombophlebitis, all right? Now, things that we should know about breastfeeding. Please remember, breastfeeding should begin within 1 hour of delivery, not immediate, not ASAP. No, it has to begin within 1 hour, irrespective of mode of delivery, okay? And please remember, when a woman is breastfeeding, there is temporary anovulation. I hope you remember the why. High prolactin inhibits GnRH. Yes. But please remember, this temporary anovulation will only last for 3 months. So even if she is breastfeeding, when will you start contraception? At 3 months. So start contraceptions at 3 months. If she is not breastfeeding, then you must begin contraception at 3 weeks. Okay, so 3 weeks in non-breastfeeding and 3 months in breastfeeding. This could actually be a range of 3 to 4 weeks. Okay. Which contraception do we usually advise? Progesterone only pills. They are very safe. They can be started immediately as well, right? They do not affect the breast milk quantity and quality. Okay. What else can be given? We can also advise her for a postpartum IUD. You call it as postpartum when you insert it within 48 hours. Okay. But it is not the preferred one. We preferred POPs because when you put IUD postpartum, the expulsion rate is slightly higher. What should you know about, combined OCPs? Should you give it to breastfeeding women? Preferably no, right? So it should not be used in breastfeeding women. It reduces the quality and quantity of breast milk, right? And you should definitely not give them in the first 3 weeks because the risk of thrombosis is very high. Okay. So in non-lactating women also, I said you should start it only after 3 weeks, right? So that the hypercoagulable state is over, right? So this is in general the contraceptive advice. But yes, can we do ligation as well? Yes, we can do a postpartum tubal ligation, and this will be done within 7 days. What we will do is a mini laparotomy. Please remember, we will not do laparoscopy, right? So therefore we will also not put fallope rings, right? So no fallope rings. What we do here is modified Pomeroy. So these are the contraceptive advices that we should follow as far as postpartum women are concerned, right? So with this, we come to an end of the session. I hope that you enjoyed it as much as I did, because I think a lot of it is, a lot of effort has gone into it, my side and your side definitely. It is super high yielding. It's just a concise version of your main notes, right? Now, wherever you feel that your concepts are lacking, you can selectively go back to your main notes. Otherwise, yes, you can revise entire OBS through this until you do DVT. Once we reach the phase of DVT, believe me, for the last lap, DVT is it. It is going to be an even more concise version of what we are doing now. So the same things, but we are concising every time we do the revision. Our purpose at DAMS was to not, leave you, to have your back, and to teach you how you can use your own notes to do a revision in a shorter span of time, right? So you use your notes, you keep reducing the time, it becomes effective, more effective. You only go selectively back to those areas where your concepts are weak or you're not understanding the application. Okay? Yes. Now until DVT, stick to LRR. Go back to main notes only where you have a conceptual problem or an application problem. Okay? Other than that, LLR is good. Okay, some images are left. I'm so sorry. I forgot and I don't want to leave it because I have put in a lot of effort. So let's quickly look at these images as well. Okay? So look at this. So can you tell me what is image number 1 here? So this is what is controlled cord traction. Yes, also called as what? Modified Brand Andrews. Okay, and this is what you do in AMTSL. What is image 2? Image 2 is bimanual compression. Yes, do you do this in AMTSL? No. Bimanual compression is not done in AMTSL. Where do we do this? We do this when we are treating PPH, not in prevention. Okay, so this is bimanual compression only for treatment. What is the next image? It's already labeled. This is what a balloon tamponade looks like, right? So this is done when the uterotonics are not effective. So if you have given uterotonics, she is still bleeding, we will put a balloon tamponade. And it's not necessary that you have to give all uterotonics first and then do balloon tamponade. No, you can do the two things simultaneously. So if you have given oxytocin and she is still bleeding, I will give more uterotonics also and I will begin balloon tamponade also. and the amount of fluid that we fill it up with, a maximum of 500 ml. Perfect, very good. Again, it's labeled. So this is what B-length suture looks like, brace sutures. Remember, they are used for atonic PPH. And remember, for this, the uterus has to have an incision. Yes? So we need to give an incision on the uterus to do the B-length sutures. Therefore, if you are doing a cesarean section and you have given uterotonics and your patient is bleeding, would you do a balloon tamponade or start with B-length? We will start with B-length. So in cesarean section, already the uterus is there. And if she continues to bleed after uterotonics, I would actually proceed directly onto B-length. Is that clear? Okay. Please remember, there are other types of sutures. For example, Heyman and Cho sutures, which do not need a uterine incision. Okay, so they will not need a uterine incision. And the last image that we need to look at is this. What is this? So this is what uterine inversion looks like. Can you tell me why this is not prolapse? Because you don't see the external os, right? So this is the fundus and the uterus is inside out. So in a prolapse uterus, you would see the external os here, and you will not see it like a red uterus, right? So this is the mucosal side of the uterus. There is no external os. This is what acute inversion looks like, right? So these are all important images. So as I said, through LLR, we have tried to give you everything, okay? So whether it is, content, whether it is concepts, we've tried to do that as well as much as possible, and images as well. So use them together. And yes, I think that is going to be very, very effective. I'm very confident and I'm very happy with what I could make for all of you. I hope you value it, you revise it multiple times, and obs and gynae is sorted. So tomorrow 10:30 we will start with gynecology. Your PDF is already uploaded. Okay. No, contraception I won't take because I very recently put contraceptive videos in Back to Basics. They are already very short videos, hardly 30 minutes. Some are even less than that. They're already very concise, okay, and very, very effective. So contraceptive videos are anyways new, so you can see them for there from Back to Basics itself. Okay, rest, yes, we will cover tomorrow in gynecology, and I promise I will try and make it as effective as possible. I'm going to try my best. So are you going to try your best, everyone? Yes? Okay. Or hum kya? Yes, of course I'm going to come to Bangalore for DVT. I'm going to come to Hyderabad for DVT, Bangalore for DVT. We really are looking forward to meeting you in person. It's a moment that creates memories and I'm not going to miss it at all, right? So we will end it on one note, which is like, the thing for dams, apna time apun khud laega. Yes, so all of you are going to write that कि हम अपना best करेंगे ताकि अपना time अपन खुद लाए. Yes, Delhi as well. Delhi में तो हम हैं ही हैं, right? So Delhi we always do DVT. We are always there, but this time it's 5 more places face to face with you all bachas, and it's an absolute pleasure. Okay. Yes, the annotated PDF will also be uploaded. Have patience. Hardly everything is already written there. Yes. So, the annotation one we will also put. And yes, you will do your best or apna time apun khud laega. Take care everyone. Thank you so much. I'll meet you tomorrow morning 10:30 a.m. with yet another session with gynecology. Okay. Take care. Lots of love. Thank you.